Good afternoon. Are we on? All right. Good afternoon. I am at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Wednesday, February 1st, 2023. The time is 2:00. We are meeting via the Zoom internet platform. I am live in room 500 of the John A. Wilson building. This meeting is being broadcast live on cable channel 12, as well as my YouTube page at CMC Henderson. I'm calling to order this meeting of the Committee on Health for the first part of the performance oversight hearing for the DC Department of Behavioral Health. We will only hear from public witnesses today. Dr. Bazaran is the director of the Department of Behavioral Health. She will appear before this committee next week on Thursday, February 9th at 2 p.m. Please be assured that Dr. Bazaran and her team are watching and listening, and they will try to respond to the concerns and issues being discussed today. The Department of Behavioral Health, also often referred to as DBH, provides intervention, prevention, and treatment services and supports for youth, children, and young adults, and adults with mental and or substance abuse disorders, including emergency psychiatric care and community-based outpatient residential services. DBH serves eligible adults, children, and youth and their families through a network of community-based providers and government services. DBH manages the district's school-based behavioral health program and operates St. Elizabeth's Hospital, the district's inpatient psychiatric facility. The Department of Behavioral Health work is essential and difficult. DBH serves district residents based on their belief that they can recover from mental and substance abuse disorders and live happy and healthy, successful lives. The COVID-19 pandemic exacerbated the existing crises that many residents were facing. At the same time, it made more difficult for DBH and their partners to provide critical services. We have seen a significant increase in the number of residents struggling with substance disorders. Oh, can we mute?
Okay. I texted them to let them. Hello.
Councilmember Gray, can you hear us?
I can hear you. How you doing?
I'm good. There was another, Basila, are you trying to?
Okay, we can see you now.
Okay, now you can see me. Were you able to hear me before?
We can hear you, but your video says Walker and not Councilmember Henderson.
I see. Okay, we will make that adjustment.
And that's only on the Zoom. So I don't know what other people are able to see.
Okay, that should be fixed now. All right, Councilmember Gray, do you have an opening statement that you wanted to make?
No, I think this what we're doing now is going to be enough for me, council member.
Okay, great. All right, so before we get started, I want to review our testimony guidelines for public witnesses. Witnesses representing an organization will have 5 minutes to speak, and witnesses testifying on their own behalf will have 3 minutes. We have a clock that will begin counting you down when you start speaking. We have a robust number of witnesses, so therefore I am asking public witnesses to please be mindful of the individuals behind you, and I will give you a nudge when your time has expired, because I believe it's important for there to be sufficient time for all people to submit their testimony. For anyone who is unable to attend or speak at today's hearing, we will accept public witness testimony until February 15th at 5 p.m. You may submit written statements to the committee, or you may leave a voicemail, and I'll provide these instructions at the end of this hearing again. So for now, I will call the first panel of witnesses. You will be elevated, so if you could please accept the invitation once it appears on your screen. Okay. First up, Justin Palmer, Brenda Richardson, Jacqueline Werner, Mark Miller, and Eric Scharf. Okay, I see Justin, so we'll go ahead and get started. Go ahead, Justin.
Good afternoon, Chairperson Henderson and Councilmember Gray. My name is Justin Palmer, and I'm the Vice President for Public Policy and External Affairs at the District of Columbia Hospital Association. I appreciate the opportunity to present testimony at the Department of Behavioral Health's FY 22-23 Performance Oversight hearing. As you're aware, DCHA is the unifying voice of the district's hospitals, representing the interests of our members who provide care to residents from all 8 wards, as well as our neighbors in Maryland and Virginia and patients from around the world. Ensuring the availability and accessibility of comprehensive behavioral health resources is critical for ensuring every resident in the district is able to thrive. Whether a resident is seeking treatment for a mental health condition or substance use, having the appropriate resources at the right time and location is essential. DBH continues to implement policy changes to help make this a reality. DCHA and DBH have been partners in advancing screening, brief intervention, and referral to treatment within the district's hospitals. The program has expanded to include not only the emergency rooms, but inpatient units as well. And this allows the district's hospitals and the department to connect patients to treatment when they are ready. Peer coaches have proven instrumental in the success of this program through their dedication to connecting patients to treatment providers. DCHA and our members anxiously await the opening of the district's first sobering and stabilization center. As I have testified before, this resource will keep individuals in the right level of care and provide support without unneeded trips to the hospital. We hope the sobering centers will eventually evolve into combined crisis emergency service centers to provide additional capacity for CPEP services, which continue to be needed. Speaking of behavioral health capacity, we are grateful the department is on track to reopening beds at St. Elizabeth's. As a result of the pandemic precautions, nearly 90 beds were taken offline, limiting admissions to the hospital. We commend Dr. Bazran for committing to have 250 beds open by June and look forward to the hospital having all of its beds open as soon as it safely can. The department's continued work in collaboration with the Department of Healthcare Finance to expand community and residential treatment options, especially for pediatric and adolescent patients, is paramount to achieving better outcomes and keeping individuals out of crisis care. As Children's National will testify later, they are seeing a higher need for intermediate levels of care for children and adolescents, which is desperately needed to avoid admission to a higher level of care, especially when they can be cared for in an outpatient environment rather than inpatient. Additionally, establishing and strengthening funding for wraparound services for those highest need and high utilizers of care is essential for treating the whole person. DCHA and its member hospitals also recognize the need to provide respite care sites for behavioral health patients experiencing homelessness so they can receive their medication and follow-up care by a community nurse or community health worker while they are awaiting housing. Our hospitals are are all too often faced with the challenge of moving patients to the next level of care without the needed community resources. Ensuring that a patient's needs are being met is key to successful discharge and reducing the chance for readmission. We'd like to thank the department for all of its continued work on for providing behavioral health care to the residents, and thank you for allowing me to testify. I'm happy to answer any questions.
Thank you, Mr. Palmer. Brenda Richardson?
Thank you, Council Member Henderson and all the other distinguished council members at the council. My name is Brenda Richardson. I live in Ward 8 and work for the Anacostia Parks and Community Collaborative. I am delighted to share my thoughts on the performance of the DC Department of Behavioral Health. Parts of my community have struggled to connect with this agency in a meaningful and authentic way for quite some time. Our disfavored neighborhoods in Ward 8 have been infected with the veins of collective trauma, especially after the pandemic. This agency may be short-staffed, but their responsiveness and accessibility is disappointing when it comes to my neighborhood. I called the agency once to talk to 3 communities on a Saturday. I was informed that they didn't make presentations on the weekends. I think we need a department that works in the evenings and on the weekends when they are needed the most. It would also be helpful if there was a hotline for our residents to get immediate help if they need to talk to someone before something unpalatable occurs. There is clearly a behavioral health issue in our city, and the uptick in crime and violence, as well as the alarming rate of growing health disparities, clearly reflect that. I don't think our government understands the depth of the problem we experience at the ground level in our communities. It is difficult for us to heal when you are constantly in a state of being sieged by the dark elements that plague disinvested areas such as trauma. We don't have the time to wait for gentrification to save us with better services that are generally not designed for us, but by only displacing the dispirited and sweeping us out of our homes and creating more debilitating behavioral health issues. Something has to change. I don't know the answer, but the DBH folks need to be more accessible, visible, and on the ground to change the paradigm. The process of healing can only begin when DBH is present to connect with the people. And finally, I will say that I have had a very positive experience with Dr. Robert Bebout at DBH. He is a wonderful example of what can happen when you care about the people you serve. Dr. Bebout is responsive and accessible. Finally, a DBH drive-by is not enough. Our community should be able to establish an ongoing relationship with DBH until we are healed. Thank you very much, Councilmember Henderson.
Thank you, Ms. Richardson, and I hope that you can stay so we can ask some questions. Jacqueline Werner. You are on mute if you were speaking.
My apologies. Good afternoon, Chairperson Henderson and committee members. Thank you for this opportunity to testify. My name is Jacqueline Werner, and I am a staff attorney at Disability Rights DC at University Legal Services, the designated protection and advocacy program for people with disabilities in DC. Pursuant to our federal mandate, DRDC advocates on behalf of hundreds of DC residents with mental illness each year. My testimony today is focused on 1, the importance of DBH maintaining thorough oversight and accountability over the district's Medicaid behavioral health services once they're carved into MCO contracts on October 1st, 2023. 2, continued concerns with the adequacy of discharge planning for individuals who are discharging from inpatient psychiatric facilities back to the community. And 3, continued concerns with staffing and oversight at St. Elizabeth's Hospital and the Psychiatric Institute of Washington. First, DRDC believes it's imperative to acknowledge the significant change in the provision of Medicaid behavioral health services that is scheduled to occur in October, when fee-for-service MHRS are carved into MCO contracts. DBH has yet to publicly disseminate information on what specific changes DBH consumers can expect to see in their services when this transition to managed care occurs, and DRDC is particularly concerned with how DBH plans to maintain oversight and accountability of these services. Currently, when a DBH consumer is experiencing abuse, neglect, and/or a rights violation by their provider, DBH's Accountability Administration unambiguously plays a central role in investigating these occurrences and works to directly address problems with providers. We are concerned that once these services are carved into MCO contracts in October, the responsibility of holding providers accountable may get diffused, and it may become more ambiguous as to whether the MCO, DBH, or DHCF is the authority to which consumers and advocates should direct concerns. Due to the shift to managed care that's already occurred for thousands of DC Medicaid beneficiaries receiving other healthcare services, such as personal care aid services, DRDC has already begun to experience ambiguity and greater barriers to consumer information when advocating for clients in that context. We fear that once behavioral health services also transition, behavioral health consumers will have a similar experience. As the district state mental health authority that has a longstanding relationship with its providers and that knows the local community well, we strongly urge DBH to continue to play a central role in oversight and accountability. Second, we continue to see significant deficiencies in discharge planning practices when an individual is discharging from an inpatient psychiatric facility back to the community. Discharge planning is incredibly important in ensuring continuity of care and stability for individuals who are experiencing acute behavioral health symptoms. It should include active involvement of CSA staff from day one of admission, assessment of housing needs during admission, and an analysis of what other resources the individual will need to be connected with upon return to the community, including an adequate supply of medication and transportation. When these practices are not followed, it can be incredibly difficult for an individual to remain safe and stable in the community and often results in hospital readmission. We've provided a case example in our written testimony of what discharge planning should not look like regarding a young unhoused adult for whom DRDC advocated and who very frustratingly was readmitted to PIW very quickly on several occasions due to systemic failures. Hospitals and CSAs are required to engage in the discharge planning process, and the district has recently assured CMS that IMDs, such as PIW, must assess beneficiaries' housing situations and coordinate with housing services providers when needed and available. We've encountered numerous examples of discharge planning not going well, and we want to make sure the council ensures that DBH is holding its providers accountable in doing this. Finally, DRDC has serious concerns about incidents of abuse and neglect at PIW and St. Elizabeth's Hospital. DRDC's multiple investigations at these facilities revealed shocking instances of abuse and neglect that we summarized in public reports this year. These reports detailed disturbing incidents, including PIW staff implementing a takedown of a patient, which caused her to suffer arm and head injuries. DRDC's report about a murder of a St. Elizabeth's patient also revealed shocking staff neglect and policy violations. Tragically, had staff been fulfilling their responsibilities, the murder might have been prevented. Many patients from both facilities have relayed to us that they were traumatized by their experiences. We urge DC Council to ensure that DBH and DC Health will hold these facilities accountable. At the very minimum, patients must be safe. Thank you again for this opportunity to submit testimony, and I welcome any questions.
Thank you. Mark Miller.
Thank you. Good afternoon, Chairperson Henderson and members of the committee. Councilman Gray, good to see you this afternoon. My name is Mark Miller. I'm the DC Long-Term Care Ombudsman with Legal Counsel for the Elderly. And I appreciate the opportunity to provide testimony this afternoon on behalf of the nearly 9,000 district residents receiving long-term care services and supports in facilities, including CRFs, and also those that are receiving services in their home under the EPD waiver. Our mission is simple. It's to promote and advocate for those persons that are receiving long-term care services and help ensure the highest quality of life and quality of care for these persons. In 2022, our office handled 264 complaints, resolving about 86% of those to the satisfaction of the recipient or the complainant. 54 of these complaints involved CRFs. This afternoon, I asked that my entire testimony be included in the record. Due to time, though, even though there's a lot of things we'd like the council to be aware of, I'm going to focus my comments on just two issues. First, support and training for staff of mental health community residence facilities, CRFs, related to therapeutic supports needs to be more of a priority. CRFs are licensed at several levels of care. However, the observed differences in care and supports across those levels seems to be rather minimal. As an example, we are not observing therapeutic services and supports being provided to residents in homes licensed as supportive rehabilitative residences, or SRRs, as required by law. This is an ongoing concern which our office has brought to the council's attention previously, and which puts residents at risk of unnecessarily cycling through crises because of a lack of trained staff to provide effective interventions, creates an unsafe environment for both residents and staff. We recommend the DBH provide SRRs with the necessary training and provide stricter enforcement to ensure compliance with this important requirement. As a side note, our office currently is surveying operators to determine their interest in obtaining training on how to reduce incidents of resident to resident violence and aggression, which seems to be a growing problem in many CRFs. Second, care coordination for residents experiencing mental health crisis needs to be improved. Facilities must request care coordination or discharge planning meetings before a situation rises to the level of an emergency or a crisis. In our observations, once a situation rises to this level, there are few supports available to residents, particularly for those who struggle with addictions to substances such as drugs or alcohol. Among our primary concerns are the underutilization of crisis beds and a cycle of residents going in and out of hospitals for inpatient mental health treatment and returning to CRFs without an updated or coordinated service and treatment plan. Prior to reaching a level of crisis or emergency, CRF should utilize the assertive treatment teams, community treatment teams, or the ACT teams and the DBH mobile crisis units for necessary support. However, what we're seeing too often is CRF's first call is to the Metropolitan Police Department, resulting in incarceration or admission to a psychiatric hospital in lieu of specialized mental health supports identified by DBH. There's an alternative. It's the crisis beds, which are underutilized. These beds are meant to offer an alternative to psychiatric inpatient hospitalization. We see this as a missing step in cases where inpatient hospitalization might not make the most sense for an individual from a therapeutic perspective. Additionally, we have observed, as Jacqueline mentioned, that there is no intervention, supports, or coordination of services provided upon discharge from a crisis bed or a psychiatric hospital to set the resident up for success once they return back to their facility or the community. We strongly recommend that crisis beds and psychiatric inpatient programs be more closely coordinated and monitored by DBH to better serve the needs of these residents. Finally, I want to say that my team meets with Dr. Moise and representatives of DBH on a regular basis and work on individual and systemic cases. We appreciate that, and we welcome this continuing collaboration to ensure quality of care and quality of life for CRF residents. Thank you for the opportunity to testify, and I'd be happy to answer any questions from the committee.
Thank you. Eric Scharf. You are on mute.
I'm gonna apologize. Should know known better after.
There you go.
Okay, hi, dear council member Henderson and members of the Committee on Health. Good to see you always, Mr. Gray. I'm glad to once again testify in front of you. My name is Eric Scharf. I serve as the DC Advocacy Chair for the National Capital Area Chapter of the Depression and Bipolar Support Alliance. I want to thank you for the opportunity to provide input on the DBH performance oversight. We applaud the committee for addressing the serious needs and concerns of the residents of the district with regard to mental health issues. I do have a fairly lengthy statement, which I will ask to be placed in the record. DBSA is the leading peer-focused mental health organization whose mission is to improve the lives of people with mood disorders. As the local DBSA chapter, we sponsor support groups throughout the region, including 2 in DC, and provide a number of education programs throughout the year. We regularly have group participants who are engaged in the DC-funded mental health system and benefit from the life-saving mission of the agency. With this in mind, I want to touch on 3 areas of concern that we've been working on. First is peer support specialist training and certification. A peer support specialist is a professional with lived mental health or substance abuse recovery experience who has been trained and certified to help others as they move forward in their own recovery. As someone who has traveled a similar path, a peer support specialist fosters hope and serves as a valuable role model for those who are walking the road to wellness. Today, the peer support specialist workforce is rapidly growing and one of the most diverse workforces of mental health, and being recognized as an integral part of the behavioral health care workforce. They can fill many roles, including helping individuals make that transition from a hospital stay, support the work of an integrated healthcare team, participate in crisis response intervention. Even the DC Public Library hires peer support specialists to work with patients on a range of life issues. The department has been providing training and certification for peer specialists for a number of years, but frankly, it is time for the city to step up its game. The district is unique among the nation, being the only state entity that controls both the training and certification process. Most states use a combination of state-approved training and affiliation with one of the two national certification boards. One of the challenges of this is the lack of reciprocity for individuals to have in DC to move to another state to work. And we also know that many individuals who seek to become a peer support specialist often lack the job readiness skills to properly undertake the job and quickly fail. Finally, the information that on the DBH website is significantly lacking in explaining the process and opportunities for becoming a peer specialist. We want to note that SAMHSA is in the midst of a process to develop an outline and framework for SAMHSA's model standards for peer support certification called for in President Biden's Unity Agenda in March 2022. These standards are expected to be issued later this year and will provide important guidance to the agency on how to improve the current program. We recommend the following. While we are encouraged that the agency is increasing the number of training programs this year, the training has been largely dormant over the past 4 years. We recommend that DBH develop a process to approve training programs offered by independent agencies that have extensive training experience. 2, affiliate with one of the national certification programs to ensure the quality of state certification and provide for employment reciprocity. 3, currently the district has an 80-hour practicum training requirement. This requirement ranges from 0 to 2,000 hours across the country, with the average being 500 hours. We think that this should be reviewed for sufficiency. A number of organizations, including the DBSA National Office, are developing peer support specialist programs, apprentice programs. Such programs will lead to enhanced training and job readiness. And last, develop employment opportunities in a pipeline for peer support specialists to easily seek employment. We want to commend Dr. Badger and her team for the support they put into managing this program with inadequate resources. We hope that the committee will make this a priority. Implementation of 988, as you may know, over the last year, Congress has a new 988 number that's the universal number for people and mental health challenges. We want to commend the department for having a dedicated team to work on this implementation, but remain frustrated at the lack of a coordinated plan to build out the system. There's a number of issues through that. We note that the city is intending to open a sobering and stabilization center later this year. Details about the program have been hard to find publicly, but we have 2 concerns. We cannot find sufficient data about the effectiveness of housing individuals with serious substance abuse problem while they sober up with people suffering a significant mental health crisis. We acknowledge that comorbidity often exists, but we question how effective the solution will be in the long run. There are a number of model programs that the city can draw on for respite activities. Second, one program in the city is not enough. We hope that the city will commit to opening 8 programs throughout the city. And finally, with regard to the behavioral health integration into primary health programs, we want to encourage this to happen. DBH needs to ensure that there is a robust messaging plan in place to help Medicaid and Alliance beneficiaries to understand the changes on the horizon as DBH certified providers move into that transition to managed care. So we appreciate the opportunity to talk and to present, and look forward to the opportunity to discuss. Sorry, I went 30 seconds over.
Thank you.
I was given some time from some of the other people.
All right. I asked the same thing of all of the public witnesses, if you can make sure that we do have a copy of your written statement, because some of you were speaking very fast, even though you had a lot of information to share. We want to be able to make sure that we can assess that very quickly before next week. I do have a couple of follow-up questions. Ms. Richardson, if you're still with us, I believe you said in your testimony that you'd inquired to DBH if someone could come do an event on a weekend, but they said that they couldn't be available. Can you speak to that?
Yes, ma'am. I'm working in 3 communities in Ward 7 and Ward 8. And because of people just seem to be angrier and more violent as a result of the pandemic. So we wanted to have them connect with DBH so we could figure out how they could get some mental health services. I don't remember who I talked to because this happened last year. We were planning it during the summer. And I was just a little taken aback when I was informed that they just didn't have staff to do anything on the weekends.
Yeah, we'll follow up on that. I know that a lot of agencies, particularly in the public health space, they have most certainly do that. And it's just a little surprising that no one didn't even, did anyone recommend another organization that might be willing to help?
No, ma'am.
Okay. All right, we'll follow up on that.
Thank
Thank you
you.
for being here.
Thank you.
Mr. Miller, good afternoon to you. You know, I don't know if we do a separate hearing specifically for the long-term care ombudsman, but I think the last time that you testified at a hearing I was at, I found your testimony to be incredibly valuable. So I was curious in general, as it pertains to DBH, are there 2 or 3 top issues that are coming to the forefront from residents who are reaching out to your office for support?
Yeah, I think, well, certainly when you look at the issues that we've been handling, the most frequent is the discharge. There's an issue and then the facility sees the first step they take is to immediately issue a discharge notice without going back and looking at, well, do you need to change the care plan? And as I mentioned in my testimony, what we're seeing is sometimes when the persons wind up either in a crisis bed, which isn't all that frequent from what we can see, but they wind up at PIW or CPAP, and then they return, the care plan isn't adjusted. The discharge planning back to the facility isn't happening. And so they just go back into the same cycle. And that's a huge issue. And it's not the DBH, it's interesting. I've done this for quite some time, and it's not always like you need new regulations or anything else. You need to enforce what you've got or to use the resources that are already available. And there are resources available. And as I mentioned, what we're seeing is, as opposed to calling the crisis team, the ACT team, or any of the other, the DBH line, what they're doing is just immediately calling, the providers are just immediately calling the police. And then that just leads to, just this continual cycle for residents. So I think that's a huge issue. And it's just, there needs to be some way to break that and to help train, which I mentioned, some of these facility staff at the basic level, at the staff level, to know what to do when you've got a crisis on your hands. It doesn't always have to escalate into, a violent situation or calling the police. So it's a huge issue, but it's not like the services aren't there. It's just they need to be utilized. And I think there needs to perhaps be a little better training of DBH staff.
Okay, thank you for that. Ms. Verner, I wanted to ask a follow-up question about your testimony, particularly as it relates to PIW. So my understanding is that DBH and DC Health have been meeting with them monthly, along with DC Health, and they've done the unannounced visits. They've gone to try to do some additional oversight, but you're saying that there's still issues. What do you feel like should DBH be doing differently?
Well, so, and I can say our office also does outreach at PIW. So we enter into the facility and do outreach on a few of the units there. And we do have started quarterly meetings with PIW's administration again to discuss ongoing concerns. When it comes to DBH's position has for a long time been that they are only contracted with the involuntary beds there. And so they see their responsibility as they see themselves as only having oversight authority over the FD12 admissions that come in. There's a lot of beds there that are not FD12 admissions. And also there's a lot of people that come in involuntarily that then sign in as voluntary. And so it gets very tricky as to like who there they actually feel like they have responsibility for. And so we've always argued that DBH absolutely should have a oversight authority over that entire hospital. It's a behavioral health facility. And so that's always that's always a concern of ours. It's really DC Health that they say has the ultimate responsibility because they're the licensing authority.
Okay, thank you. And thank you again to all the witnesses who testified. I'm over my time on this round. Councilmember Gray, do you have some questions for these witnesses?
No, thank you very much. I appreciate the witnesses testified. I've worked with all of them at one time or another. And we look forward to continuing to work with them, Councilmember.
All right, thank you. Thank you to all the witnesses. Many of you have done this Zoom thing with us before for hearings. You'll be put back as an attendee, and then we will call up the next panel of witnesses. But again, if we don't have your written testimony, please make sure you submit it to the committee. Okay. Next 5, we're calling up Rachel Johnston, Jennifer Ubira, and I apologize in advance if I am butchering your name. Shara Greer, Amber Reiki, and Quabilla Huddleston. Just a moment as those folks come into the room. Okay, Ms. Johnson, you are here. So why don't you go ahead and get started for the interest of time.
Of course, no problem. Good afternoon, Chairperson Henderson and members of the committee. My name is Rachel Johnston, and I'm the Senior Director of Operations and School Support at the DC Charter School Alliance, the local nonprofit dedicated to ensuring all students in DC receive the great public education they deserve. The DC Charter School Alliance is also an active member of the Strengthening Families Through Behavioral Health Coalition, and we fully support the coalition's recommendations. There is no question that the pandemic has exacerbated students' mental health needs. Trauma from instability at home and increased violence in their communities do not simply disappear when students enter their school building, and it significantly impacts their ability to learn and succeed. Charter schools are doing all they can to provide the supports and are prioritizing their funds to staff these roles, but it must be supplemented by trained clinicians and resources from community-based organizations to help families with issues that fall outside the scope of school services. For example, housing instability and food insecurity. We understand schools, CBOs, and the Department of Behavioral Health are struggling to source qualified clinicians. So I'm here today to share ways DBH can improve students' mental health supports given existing constraints. First, families need personalized wraparound case management supports. Navigating access to the wide breadth of services the city offers through the variety of agencies and organizations can be overwhelming and burdensome. While each CBO a school partners with has its own case manager, too often struggling families are directed to agencies through a one-pager rather than with start-to-finish support. They are expected to figure out complex systems and processes without proper assistance. In the past, the neighborhood-based Strengthening Families collaboratives provided personalized wraparound case management services, but their funding and scope of services has narrowed over time. We encourage the council to support provision of additional funding and more widely accessible case management services to the families that need it the most, and hold a focused discussion dedicated to the school-based mental health program to allow schools, students, families, educators, and CBOs to share challenges and opportunities. Second, our schools need more high-quality clinicians to meet students' mental health needs. While we're grateful more schools have access to DBH's school-based mental health program than ever before, CBOs are still struggling to fill vacancies. We therefore encourage the city to invest in innovative recruitment strategies that grow the pool and pipeline of clinicians, such as funding higher education and licensure programs for DC residents to pursue careers in mental health. If enacted and funded, the Pathways to Behavioral Health Degrees Act of 2023 would support this effort by financing the Master of Social Work degrees specifically. More immediately, though, the city can grow the pool of qualified clinicians by pursuing reciprocity agreements with surrounding states. Allowing clinicians licensed in these nearby states to practice in the district has the potential to enhance the pool of providers quickly, and we recommend DBH and related city agencies explore this option. Third, and lastly, it's important that all public schools have equitable access to life-saving overdose drugs like Narcan. DBH provided Narcan along with a process for administration to DCPS schools in November, but systematic access has not yet been provided to public charter schools, and yet we're aware of several overdose instances at or near our charter schools this year. We did hear of one charter school who received a delivery of Narcan last week, for which we're grateful, but in lieu of systematic access, many have had to resort to picking up Narcan from CVS, as any district resident can do at any time. We understand from DBH and OSSI that the city is working to develop a template memorandum of agreement between DBH and each charter school that will memorialize expectations for the training, administration, and storage of Narcan provided to charter schools. We appreciate the cross-agency collaboration, but we're concerned that schools serving nearly half the district's public school students were an afterthought. We're eager for an update on the issue and would like to work together with the committee and relevant agencies to ensure good systems are in place going forward to effectively plan for all schools so that all students are equitably served. As always, the DC Charter School Alliance is available to support this collaborative effort and mitigate the challenges of our 69 charter school organizations individually. In short, charter schools are committed to ensuring their students' mental health needs are well cared for. We hope we can work together to provide better coordination on connecting families to services, grow the pool and pipeline of high-quality clinicians, and ensure all public schools get access to Narcan to save lives within their school communities. Thank you for your time and attention to this matter, and I welcome your questions.
Thank you. Jennifer?
Good afternoon, Chairwoman Henderson, and Councilmember Gray. My name is Jennifer Ubiera, and I am a Ward 4 resident, Senior Policy Counsel at the Council for Court Excellence, CCE, and a member of the Strengthening Families Coalition. I will omit CCE's organizational background in favor of time. First, I will provide oversight feedback related to DBH's school-based behavioral health program. Then my colleague, Anya Creeder, in the next panel, will speak about DBH's work providing substance use disorder services to justice-involved residents. The Strengthening Families Coalition is a body of district organizations, advocates, parents, and behavioral health providers organized to advocate for the improvement of DC's behavioral health system. The vision of the coalition is every DC child reaching their full potential with timely access to high quality, consistent, and culturally responsive behavioral health care that is available through a fully implemented, sustainable system. The district has made enormous progress towards this vision with the implementation of the school-based behavioral health program, including restoring grant amounts for school-based behavioral health clinicians and securing funding for a comprehensive cost study to assess the long-term sustainability of the program. However, the program currently suffers from a few challenges that are disrupting the massive effort to serve youth in what the American Pediatric Association and the Children's Hospital Association have declared is a national emergency in children's mental health. Currently, there is a significant challenge in filling much-needed positions to meet the program's preliminary goal of staffing at least one full-time clinician in every DC public school and public charter school. As a nation, the United States is currently experiencing workplace shortages, and the district is no stranger to this reality in sectors ranging from retail to technology, but especially in our healthcare sector. While the Strengthening Families Coalition applauds the Department of Behavioral Health for increasing the per clinician funding amount and finding creative solutions to resolve workforce development challenges in fiscal year 23, we also encourage DBH to be aggressive in its efforts to fill these positions and sustain the investments being made. We would also encourage the council to request regularly updated information from the agency about their recruitment and hiring efforts of clinicians, especially Black clinicians and clinicians of color who share the cultural experiences of the youth they will be serving. Without a doubt, the pandemic has worsened DC's behavioral health crisis and has also delayed implementation of the school-based behavioral health program. To address this disparity, we need to do everything in our power to remove the barriers students are facing in accessing services. For example, many families are still unaware of the resources available and referral practices vary greatly by school. DBH needs to make clear efforts to promote and publicize the program, and can and should also partner with community organizations like the Strengthening Families Coalition to do multifaceted outreach. We are here and happy to help. Additionally, the agency would likely increase its reach by partnering with district agencies and council member constituent services staff to incorporate messaging about the presence and availability of the program into their promotion of virtual and in-person events. Lastly, we wanted to address the delays to commencing the cost study. We recognize that these delays have largely been out of the agency's control, but we look forward to seeing the results of the cost study and program evaluations that will support DBH in building a strong, sustainable program. I yield the remainder of my time to my colleague, Anya Creeder, in the next panel. Thank you, and I'm available for questions.
Thank you. Shara Greer.
Good afternoon, Chairperson Henderson and Councilmember Gray. I'm Shara Greer. I'm the Policy Director at the Children's Law Center and a resident of the district. I'm testifying today on behalf of Children's Law Center. Our more than 100 staff work with DC children and families, community partners, and pro bono attorneys towards a future where every child can grow up with a strong foundation of family, health, and education, and live in a world free from poverty, trauma, racism, and other forms of oppression. I appreciate this opportunity to testify regarding the performance of the Department of Behavioral Health over this past year. I've submitted extensive written testimony, and I'm only going to touch on a few points here. In DC and the rest of the country, as the panelists before me just mentioned, there is a crisis in children's mental health. The American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association all declared a national state of emergency in 2021. The pandemic has accelerated trends in worsening health. Tackling this crisis will not be easy, but there are important steps that we have taken as a city and that we can take to address it. I want to direct you to the report that we presented last year, A Path Forward, Transforming the Public Behavioral Health System for Children, Youth, and Their Families, the District of Columbia. This was a collaborative effort that detailed specific recommendations to improve the children's mental health system. As we continue to pursue these reforms with our partners, both in and outside the district government, I want to highlight a few key ones for this committee. DBH has made some very important investments in several key programs for children and youth. One of the most significant has already been mentioned, the school-based behavioral health program, and my colleague Amber Reiki will be addressing that in her testimony. Another important program is Healthy Futures, which integrates behavioral health services in settings where children are already present, at development centers and home providers. Healthy Futures creates a collaborative relationship between a professional consultant with early childhood mental health expertise and one or more caregivers to build the capacity of staff, families, and systems to prevent, identify, treat, and reduce the impact of mental health problems among children and their families. Healthy Futures has recently grown in the number of child development centers and home providers it operates in, from 58 in FY20 to 97 in FY22. Additionally, Healthy Futures has made progress with implementing a pilot program providing on-site mental health services, including direct clinical support to children at 8 early learning programs. We're looking forward to the planned evaluation of this program and its continued expansion. Another vital program helping children is the DC Mental Health Access and Pediatrics Program, DC MAP. DC MAP has improved mental health integration within pediatric primary care, providing help where children and families already are, the doctor's office, and expanding capacity. Pediatricians who have mental health related inquiries about specific children can have real-time phone access to psychiatrists, psychologists, social workers, and care coordinators. Beginning in November 2020, the program transitioned to a new provider. And as with any significant change in an essential program, it's important that there's a smooth transition and continued quality service provision. We hope to see DC MAP continue to serve as a valuable resource and ask the committee to focus oversight on the program's implementation. These programs, unfortunately, are not enough to meet the behavioral health needs of children and their families. DC lacks an adequate supply and range of behavioral health supports. Services are often fragmented and inaccessible due to a scarcity of a particular provider or service, treatment locations, inadequate transportation. There's long wait times and often insufficient care coordination. These shortcomings were prevalent before the pandemic and have only been exacerbated since. Far and away, the biggest obstacle to our clients accessing critical services is the lack of behavioral health care professionals practicing in the district. Our clients consistently report being unable to find providers offering the services they need, or if they manage to find a provider, the wait list for the appointment is prohibitively long. Now more than ever, there's an urgent need for system-wide strengthening and reform. There are significant changes in the work. DC is moving to an exclusively managed care model in the Medicaid program over the next 5 years. A key element of this reform is the addition of behavioral health services into the district's managed care contracts as a carve-in. This carve-in effect should serve to improve care coordination and bolster whole person care for DC Medicaid beneficiaries. DC's also applied for a federal planning grant to implement certified community behavioral health clinics in DC, a promising model to expand the behavioral health care capacity. These and other reforms must be pursued to make progress to meet the important behavioral health needs of children in the city. We look forward to continuing to work with DBH in this committee. I'll welcome any questions.
Thank you. Amber?
Good afternoon, Chairperson Henderson and Councilmember Gray. My name is Amber Reiki. I'm the Path Forward Project Lead at Children's Law Center. Our more than 100 staff work with DC children, families, community partners, and pro bono attorneys toward a future where every child can grow up with a strong foundation of family, health, and education, and live in a world free from poverty, trauma, racism, and other forms of oppression. We are also members of the Strengthening Families Coalition. I appreciate the opportunity to testify about the school-based behavioral health program and how, in order to fully implement a sustainable data-driven program so that every DC child has access to high-quality, culturally responsive behavioral health care, the district must ensure stable compensation for clinicians into fiscal year 24, use and share reliable, actionable data as the foundation for planning and payment, and improve communication with DC students and families about services available in schools. In 2021, as you've heard, the American Academy of Pediatrics with others declared a national state of emergency in child mental health, warning of soaring rates of depression, anxiety, trauma, loneliness, and suicidality. It is important to remember that the pandemic is not the sole driver of these troubling trends. Mental health symptoms, including depressive symptoms and suicidal ideation, have been steadily increasing among American youth for over a decade. However, only 1/5 of children who need this specialized care ever receive it. This unmet need is worse for children of color. Early intervention can change lives and improve health. The district has been rising to the occasion with investments like SBBH, with a licensed clinician in every public school in DC. This co-location model lowers barriers to care, so kids are getting the help they need right where they spend most of their day. This program is meeting a critical need, but it is still working up to its service capacity. As of January, 61% of schools have staffed a full-time CBO clinician. CBOs are struggling to recruit and retain behavioral health professionals amidst a nationwide shortage. We applaud DBH for responding, increasing compensation by more than 40% to meet the market demands. We ask to continue these investments. Anything less would take us backwards. It is also important to understand how the program is functioning, to see where adjustments are necessary. It is our understanding that the program evaluations conducted by Child Trends are completed for school year 20 to 21 and 21 to 22. We look forward to the release of these evaluations as well as the 2022 cost study. We also encourage the council to hold a public roundtable on the program. And finally, we would like more consistent and intentional communication from DBH and schools. With successful outreach, we can feel more confident that the kids who need services can utilize them, with the added potential for more reimbursement from insurance. Ensuring the school-based behavioral health program is strong and sustainable will help us realize its long-term potential and the potential of DC kids. This will require adequate compensation, actionable evaluation, focused oversight, and effective communication with stakeholders. Thank you for the opportunity to testify, and I welcome any questions you might have.
Thank you, Amber. Ms. Huddleston?
Chairperson Henderson and members of the committee, thank you for the opportunity to testify. My name is Quabila Huddleston, and I'm a senior policy analyst at the DC Fiscal Policy Institute. DCFPI is a member of the Strengthening Families Through Behavioral Health Coalition, a coalition committed to ensuring that DC children and families have access to a fully integrated behavioral health care system. Today, I am testifying about three main issues. First, DC must address the behavioral health needs of students of color and girls. DCFPI appreciates the mayor and DC council for having consistently invested in the SBBH program within recent years. Those investments have helped the district make more progress toward placing at least one full-time behavioral health clinician in every DC public school and public charter school. Policymakers should continue to invest so that the SBBH program is stronger, more sustainable, and well utilized by DC students and families. The district should also ensure that investments are leading to more culturally competent care. Data on DC from the 2021 Youth Risk Behavior Survey show that Black and Latinx and Indigenous students bear the brunt of violence and trauma in their communities and face greater behavioral health challenges. 40% of Black middle school students that were surveyed and 43% of Indigenous students who were surveyed reported having seen or heard people where they live be violent or abusive, compared to 28% of white students who were surveyed. 1/3 of surveyed Black, Latinx, and Indigenous students reported seriously considering taking their own lives, compared to 20% of white students. Disturbingly, Indigenous middle school students were 4 times more likely to report that they attempted to take their own life compared to white students. Data among DC's high schoolers are equally troublesome. Nearly 48% of surveyed high school girls reported feeling sad or hopeless, a proportion that has increased since the pandemic. Higher percentages of girls and students of color also reported that their sadness and hopelessness caused them to stop engaging in everyday activities. These disparities in behavioral health outcomes in the district are unacceptable and demand urgency and an explicit focus on boosting culturally competent care. Second, the Committee on Health should host a public roundtable on the results of the SBBH cost study. In the current fiscal year, the budget season for the current fiscal year, our coalition successfully advocated for DBH to conduct a cost study to estimate the true cost of operating the program. SBBH relies on a blended funding model of a DBH issued grant for CBOs, federal Medicaid reimbursements, and any funds that participating behavioral health CBOs raise on their own. It has become clear that the typical CBO grant amount that DBH awards is inadequate to address the demands and needs of the program. By law, DBH was required to share the final cost study with the DC Council no later than December 31st, 2022. However, the consultants conducting the study recently shared that they are still in the data collection process. Our coalition strongly urges the Committee on Health to host a roundtable with public and government witnesses once DBH publicly shares the report. This roundtable would provide the opportunity for students, families, educators, and school leaders and CBOs to share their experiences with the program and for the Committee on Health to investigate the bright spots and challenges of the program. Such context can inform important next steps that DBH, the mayor, and the council should consider as they take further steps to improve the financial sustainability, quality, and utilization of the program. Lastly, the current funding for SBBH reflects the reality of needed investments, although work remains. As Amber just mentioned, DBH has increased the grant amount that it is providing to CBOs in the current fiscal year. And they've largely done that to support recruitment and retention efforts among an acute workforce shortage locally and nationally. We applaud DBH for proactively taking that action, but we were disturbed to hear DBH assert that they've lowered the local recurring funding amount that they are providing to CBOs. Especially after our coalition successfully advocated for a permanent increase to that amount. And so, and we did that following DBH's own conclusion that grant amount at that time was inadequate. And so we are strongly encouraging the Committee on Health to ask DBH about the recurring portion of the grant, but also to just further investigate how much the agency is investing in school-based behavioral health grants for CBOs. Thank you for the opportunity to testify. I'm happy to answer any questions.
Thank you to this panel of witnesses, and thank you for always advocating on behalf of district residents, particularly for this group, those who are more young in spirit and young in age. I do have a few questions. Ms. Johnston from the Charter School Alliance, thank you for your testimony. I wanted to ask about, I guess, what you mentioned in your testimony about the back and forth around charter schools accessing Narcan. And you said that there were, I believe you said something to the effect of an MOA is still being worked on. Have you all been provided a timeline of when you can expect that to be completed?
Yeah, we heard from Aussie either last week or the week before that, sometime in February, schools would get an update on that through the Dr. Grant's monthly meeting with leaders. So we hope that it'll be a very simple pathway forward from there.
Okay, great. Well, I think I have Dr. Bazaran soon, and then Dr. Grant will be later in the month. Well, actually, I believe she's the beginning of March. So if it's not resolved by then, we will ask her about that there.
Great,
Thank you.
thank you.
For Ms. Greer or Ms. Reiki, either one of you, thank you so much for your testimony and always for Children's Law Center's continued advocacy. Where, in your opinion, and be mindful of my time, because I'm trying to do my best to stick to the clock. Where are the gaps do you feel like are the largest in terms of the our behavioral health system when it comes to children and youth? Is it the referral process, or is it the consistency in terms of slots for treatment?
I think it's really the available providers. There aren't enough people providing the services, and there are places where the services are even more difficult to get. Child psychiatry is definitely one of them, but across the board, there just aren't enough people providing services in the district. And so workforce development is one of the key things that has to be done in order to be able to fix the problem.
Amber, I don't know if you want to add something there.
I would always echo the need for more behavioral health providers, and also more venues, more locations, more kinds of places and kinds of services. There's a whole spectrum of kinds of mental health conditions and needs, a whole spectrum of the kinds of services with different levels of acuity. You might be stepping down from a service or stepping up to a higher level of service. And there are just many, many gaps. And if we could have more mental health providers, that would certainly help.
Yeah. I was having a conversation earlier this week, and it came up that what our system, particularly Medicaid, will cover for young people from a therapy standpoint is very limited. So for instance, let's say you have a young person who doesn't necessarily feel comfortable with talk therapy, but they want to pursue music therapy or art therapy or another venue, but we don't necessarily have the ability for them to pursue that based on their insurance coverage now. Do you have any thoughts on that?
I think we could do more to expand the kinds of services that our Medicaid state plan covers. Department of Healthcare Finance has actually been working to put in some waivers to allow us a little more flexibility. And it'll be interesting in this transition to having the MCOs be providing all the mental health services. That should allow for some more flexibility as well. But it's a really important issue that we have the ability for Medicaid to pay for the appropriate therapies and services, because we are still in a situation where the majority of children in the city are on Medicaid.
Right. I'll ask this for all of the witnesses, and Jennifer, again, feel free to chime in here. What do you think should be at top of mind as we think about what is going to happen in the next couple of months between behavioral health moving to the Medicaid MCOs, but also redeterminations happening around that same time? What should we be laser focused on to ensure that there's continuity of care available?
I would say ensuring where you can, good care coordination, communication between providers, types of providers, limiting the time that kids have to wait for their services, and creating what could be called warm handoffs between service types, especially if they are going to a new provider and they have to start up that trust relationship all over again. So I would think care coordination would be one of the most important, and I know that health providers feel the same way.
Okay. Anyone else? I'm over my time. Okay. Well, I'm going to turn to Councilmember Gray. I do want to say, Ms. Huddleston, I definitely heard you and your testimony. When we have more information in terms of the costs this cost study, I'd definitely be open to holding a hearing on that to get some feedback from the public. But also, one of the things I'll be asking the government witnesses is a more firm timeline, considering we've missed the one from December. So just hold on a second here. Councilmember Gray, do you have any questions for these witnesses?
I really don't, Councilmember. I want to thank them for their efforts and the work that they've done. Some of them have worked with us very closely and will continue to do so, as I know. And we'll look forward to them doing that. So thank you very much.
All right, thank you. Thank you to the public witnesses, and please make sure that we have a copy of your testimony. I'll go to the next panel. We have Mark Lavoda, Anya Creeder, Sarah Barclay Hoffman, Carrie Savage, and Shinola. I'm going to say A because I don't want to be disrespectful and get your name completely wrong. Again, you have to actively accept our invitation to be elevated to a panelist. Give us just a minute. We're still trying to get folks elevated as panelists. Okay, well, we're still working on that. Mark, I see you here and you're next on the list. So why don't you go ahead and get started on your testimony?
Thank you. Chairperson Henderson, Councilmember Gray, and members of the council, thank you for the opportunity to testify today. My name is Mark Lavoda. I'm the Executive Director of the District of Columbia Behavioral Health Association and a Ward 2 homeowner. The District of Columbia Behavioral Health Association works to advance high-quality, whole-person care for all district residents with mental illness or substance use disorders, including the 30,000 district residents that our 31-member organizations serve annually. This hearing's focus on the Department of Behavioral Health is an important opportunity to reflect on the status of the community behavioral health delivery system in the district. District residents need additional behavioral health supports. The district is on pace for a third consecutive year of over 400 opioid overdose deaths and a third consecutive year that opioid overdose deaths occurred at double the rate of homicides. The district also continues to see over 50 suicide deaths annually, many among younger adults. In addition to these deaths, 28.1% of district residents reported symptoms of anxiety or depressive disorder in a January 2023 survey, approximately 10% greater than before COVID-19. Despite significant improvements over the past few years, 14% of adults and 20% of children in 2022 had unsuccessful attempts to access care from DBH certified provider organizations within a month of enrolling for assistance, and only 54% of adults discharged from involuntary psychiatric hospital care had a follow-up service within 30 days. DBH is working with the provider network to meet these challenges. DBH operated services like the community response teams and new intensive care coordination teams are connecting with some of the people who are the hardest to connect to care. DBH has also expanded services at the Access Helpline, and launch of the district's new Stabilization and Sobering Center and renewed leadership in other DBH crisis services show promise to address other unmet needs. Unfortunately, DBH and the DBH Certified Provider Network share a behavioral health workforce crisis. DBH has dozens of frontline vacancies and has experienced gaps in management and leadership roles. A point-in-time survey in 2022 showed a 20% vacancy rate among community behavioral health provider organizations. Vacancies have required increased use of overtime, and the strains of turnover, illness, and disability in the wake of COVID continue to compound. DBH certified providers cannot meet performance expectations or workforce demands without payment increases. Provider payment rates are based on cost data from 2016, and a 6.2% inflationary adjustment arranged by DBH and DHCF over the course of 2022 is still 17.5% less than healthcare inflation since 2016. Helpfully, DBH and DHCF have shared that a cost study underway will include updated payment rates, switch some services to a more effective billing method, and add important services to Medicaid. Distressingly, the most recent report on that study omitted plans to update substance use disorder residential treatment provider payment rates, despite known severe financial difficulties for those organizations. The provider network faces substantial additional demands to prepare for plans to move DBH certified provider organizations into managed care effective October 1st, 2023. Provider organizations have been asked to purchase or upgrade electronic health records, to complete national accreditation, and to implement new level of care evaluation tools. Each of these projects is good. Each of these is also technically complex, requires financial resources, and demands management time and staff retraining. There are also remaining significant unresolved issues that provider organizations need resolved to know how to prepare for the transition to managed care, including information about enrollment and disenrollment from DBH certified services, the specific mix of services and eligible providers and supervisors for those services, and the process for credentialing licensed and unlicensed staff members, among others. DBH and DHCF need to accelerate formal publication of rulemaking, policies, and other guidance, and to continue to offer technical and financial assistance. Provider organizations appreciate Dr. Bazran's leadership and the efforts undertaken by DBH staff over the past year, and we look forward to continued work together to improve the district's community behavioral health delivery system. Thank you again for the opportunity to testify today. I look forward to answering any questions that you may have.
Thank you. Anya Crater.
Good afternoon. My name is Anya Kreiter, and I am CCE's Open Horizon Criminal Justice Fellow. I am continuing from where my colleague Jennifer Ubiera left off. I will be using the remaining of her time. This portion of CCE's testimony is informed by the recent progress evaluation we did on our 2020 report, Everything is Scattered, the intersection of substance use disorders, SUD, and justice involvement in the district. That 2020 report offers 39 recommendations for policy and practice change with the goal of better health and reduced incarceration for DC residents. At the end of 2022, and at the request of the auditor, CCE chose a subset of 11 of those 39 recommendations to evaluate DBH's progress on recommendation implementation to date. Recommendations were selected to capture a variety of topic areas and in consideration of what data would be most readily available. Our goal in evaluating progress is not simply to compliment the agency on their successes or ding them for stagnation. Rather, ensuring our audit's recommendations are implemented is a critical step towards our shared goals of providing excellent care for all district residents and decreasing the racial disparities embedded within the district's criminal, legal, and health systems. In the district, 91% of incarcerated individuals are Black, but only 46% of residents are Black. Additionally, 95% of instances of incarceration considered in CCE's 2020 report involved a Black person. Of these 11 recommendations, 9 were found to be in progress or not started by DBH. One recommendation was fully implemented and another had no plan to be implemented. For example, CCE recommended DBH establish a protocol for real-time sharing of clients' authorized SUD information with the Department of Corrections and the Department of Healthcare Finance. DBH is in the process of entering into an agreement to fulfill this recommendation. Additionally, I'm happy to say that DBH has fully implemented the recommendation to establish procedures by which people and organizations can alert the agencies to violations of client rights. CCE also recommended the district continue the pre-arrest diversion PAD program between DBH and the Metropolitan Police Department. PAD is a type of diversion that occurs before an individual's arrest and is designed to break the cycle of justice involvement. However, PAD is no longer considered an independent initiative and it instead has been folded into the Community Response Team program. With this consolidation, it is unclear the extent to which the PAD goals are being met. As another example, DBH also has not implemented our recommendation that it track the time in between referrals and care initiation for people seeking new SUD services, including those who have just been released from incarceration. We are encouraged that DBH has taken some steps to address the issues identified in Everything is Scattered. However, particularly given the racial disparities among those incarcerated in DC, it is evident that additional work is necessary to achieve our shared goal to adequately support DC's justice-involved residents with substance use disorders by ensuring that they have continual access to high-quality care. Thank you for this opportunity to testify. CCE looks forward to continuing to work with DBH, and we remain available to this committee to discuss our findings. Ms. Ubiera and I look forward to answering any questions.
Thank you. Sarah Barclay Hoffman.
Henderson and members of the committee. My name is Sarah Barclay Hoffman, and I work in community mental health policy at Children's National Hospital and the Early Childhood Innovation Network. We are members of Under 3 DC and Strengthening Families Coalitions. Thank you for the opportunity to share testimony. As our city and nation grapple with a behavioral health crisis among children and families, it is critical to continue to bolster access to high quality and timely care across all ages and settings. I will focus my testimony on early childhood, integrated and school-based behavioral health, intermediate care, and substance use disorder services. My written testimony contains further detailed recommendations. One of the most efficacious interventions for all children, especially infants and toddlers, is to support the safe, stable, and nurturing relationships that buffer adversity and build resilience. An example of this is Healthy Futures, which Shara Greer also discussed. We commend DBH for continued steady growth by serving more child care facilities and continuing to collaborate and innovate with stakeholders. We also appreciate DBH's decision to implement the Attachment and Biobehavioral Catch-up Evidence-Based Intervention, also known as ABC, which strengthens parent-child attachments. A critical component of ABC is that it can be delivered by non-licensed individuals after appropriate training. ABC aligns with our recommendation that we continue investing in early childhood and enabling integration of peers and other non-traditional behavioral health professionals across settings, including in early childhood. Meeting children and families where they are to address their behavioral health needs is a proven and effective strategy, which is why both integration of behavioral health and primary care and school-based behavioral health care are essential. We commend DBH for applying for a federal certified community behavioral health clinic demonstration planning grant. This type of integrated care model has shown strong outcomes, including for children and youth, and we look forward to DBH's continued focus on advancing high quality integrated care. Similarly, we support the continued expansion of the school-based behavioral health program. We applaud DBH for increasing the per clinician funding amount and finding creative solutions to resolve workforce development challenges, and we encourage them to continue these investments. We recognize the importance of ensuring all families are aware of these services available through the program. We support having more ways of communicating and sharing information with families, including posting services, referral, and contact information to each school's My School DC page. This would also support other stakeholders who are interested in sharing school-based behavioral health information with children and families, such as pediatricians, who have noted difficulty accessing this information. The district does have areas where service availability can be bolstered. For intermediate care, such as intensive outpatient and partial hospitalization programs, we are not aware of any programs for youth in the city that accept DC Medicaid. Our clinicians are also seeing a high number of Black youth being admitted for suicide attempts and ideation. A standard of care for suicidality is dialectical behavior therapy. And unfortunately, most of these programs in DC only accept commercial insurance or out-of-pocket payments. Children's supports DBH and DHCF, including partial hospitalization and dialectical behavior therapy as billable services at competitive rates on the Medicaid fee schedule as an initial step. Finally, Children's National Emergency Room and addiction clinicians also report increases in youth presenting with substance use disorders, including opioid overdoses, and simultaneously noting that more youth are voluntarily seeking treatment. Unfortunately, for youth with DC Medicaid, community-based options for SUD treatment have recently diminished. Of the 3 DBH certified SUD providers for youth, we are aware that 1 recently stopped providing services. We commend DBH on partnerships to provide stakeholder education on youth drug trends and service availability in the district, and also recommend expanding the number and type of youth SUD prevention and treatment services. We thank DBH for their continued emphasis and implementation regarding children's behavioral health services. I appreciate the opportunity to testify and would be happy to answer any questions you may have.
Thank you. Carrie Savage.
Good afternoon, Chairperson Henderson, members of the Committee on Health and committee staff. My name is Carrie Savage, and I'm the Director of Policy and Advocacy at PAVE. PAVE is also a member of the Strengthening Families Through Behavioral Health Coalition with many of my colleagues here today. So we've seen our students' outsized mental health needs daily and have for some time. It shows up in chronic absenteeism rates and academic performance, the increase of youth crime, and more. And we know we cannot propel as a city without first addressing the individual needs of our children, the future of our district. Although we should celebrate that more DC children and families are experiencing the benefits of the school-based behavioral health expansion and DC schools initiatives to center the mental wellness of their students, we must continue to invest in this crucial work to ensure the needs of our students are fully met. Today, you will hear from many community partners and PAVE parent leaders. Many have been advocating for school-based mental health for nearly every year. And parents have come together in many meetings to discuss their policy solutions they see as foundational to lasting and systemic change around school-based mental health and would address the biggest gaps and needs in our current system. So today I want to amplify their top priorities, and they will share with you about them as well. So first, to build and sustain a pipeline for diverse, competent mental health professionals. We're thrilled the district was awarded the federal grant to support the recruitment and retention of school-based mental health professionals in the coming years. And we hope that the planning for that work will include and center the voices of key players like students, parents, teachers, clinicians, and school leaders. In the meantime, we need to make sure our current providers are compensated well. So we applaud the mayor and council for being responsive to the fact that in recent years, we've seen the cost of staffing increase and in return have invested the necessary funds to increase grants to providers. We encourage DBH to continue these investments moving forward at the current funding level, adjusted for inflation, and making sure that funding is recurring, not one time, as anything less would take the districts and therefore our students backwards. We also look forward to examining the results of the upcoming cost study that was mentioned earlier today and program evaluations. However, we do want to note before any revisions are made to the model in terms of improvements, we urge the Committee on Health to hold a public roundtable dedicated to school-based behavioral health so all stakeholders can share their insights with implementation challenges and opportunities for improvement. Second, we need to expand school staff support to respond to the needs of all children. We know that supporting mental health and behavioral health is not just therapy. Organizations like Transcend, Turnaround for Children, and Restorative DC have done amazing work partnering with schools to implement a whole child model. And we want to make sure they are able to continue and scale that work via increased grants and are meaningfully engaged as part of the districts and the Coordinating Council on School Behavioral Health's work to expand comprehensive care in schools. Lastly, we want to improve families' access to mental health support information. We can continue to strive to build the premier model of school-based mental health in our country. However, if we do not prioritize connecting students and their families to these resources at their schools, we will continue to fail to meet their needs. Right now, too many families are not aware of the supports available at their school or how to access them. And in my written testimony, which I'll send over, we'll send a summary of our school-based mental health survey that gives you those exact numbers. So in order to address some of those information challenges, parents are calling on DC leaders to create a comprehensive and citywide approach to information sharing. This includes, but isn't limited to, requiring information about mental health services offered at each school on the My School DC website, ensuring schools have a clear and differentiated plan for sharing information about available mental health supports with families, including the school strengthening tool and work plans. And there's a centralized portal of resources for families across the district on how they can support their children at home or outside of school. This upcoming budget and oversight season is truly an opportunity for us to show our values, a DC that takes care of its people, especially when times gets hard, and one that will courageously act to right the wrongs of the historic injustice and set up with bold, innovative action to meet this moment with investments in our future and our children. This work is only possible with leaders on the council, the Department of Behavioral Health, who also believe in the power and promise and community voice. So we're very grateful for the opportunity to testify today. I hope we can count on your leadership, and I welcome any questions. Thank you.
Thank you. Shaniola, I'm just going to say A. I don't want to butcher your last name, but do tell me how to say it.
Arolaju.
All right. It's your turn. Go ahead.
Good afternoon, Councilmember Henderson and members of the Committee on Health. My name is Shaniola Arolaju, and I'm a proud parent of 3 children who attend KIPP DC, AIM, and Heights Academy at the Douglas Road campus in Ward 8. I also serve with Parents Amplifying Voices in Education on the Ward 5 PLE board. I would like to start my testimony by first thanking the council and the mayor for your support of our school system in fiscal year 23. We are on the right track and moving in the right direction. The $3.8 million in additional funding for school-based mental health, $2.4 million to increase grant sizes for community-based organizations, as well as the $150,000 for a comprehensive study to determine the true cost of school-based mental health programs presently and in the future. So thank you. Those investments are important not only for our students, families, and the school communities, they are important for the city as a whole. I'm testifying today because I want the stigma of mental health in schools to be eliminated and for the importance of school-based mental health to be on the front of everyone's mind. I would like all kids, teachers, and school staff to have access to quality mental health supports, regardless of their background. To make my dreams a reality and address the issues around the lack of quality and availability of school-based mental health in DC should prioritize both providing and improving the support given to school staffs to equip them with the ability to respond to the needs of all DC children. While I know that is a loaded statement, some ways to accomplish this is by allotting additional funding to expand teacher and staff training. This includes increasing the UPSFF at the very least to keep up with inflation and adjust to the recommendations of the new adequacy standard in the upcoming study. This would afford LEAs the ability to manage expanding supports based on their specific school community needs, providing more grants to expand partnerships with community-based organizations like Turnaround Children and Restorative DC. As a DC native and a graduate of the DC public school system, I have experienced and witnessed firsthand what the lack of available mental health supports look like. The council needs to work to build and sustain a pipeline of diverse and competent mental health professionals. The mayor and the council should provide additional funding and incentivize mental health professionals to serve in our schools. Incentivize DMV graduates to come back and serve the community they lived and grew up in. Pass legislation to widen the network of potential service providers in DC schools to accept MD and VA licensure and certification. And in my humble opinion, most importantly, improve engagement in school-based mental health. It is not enough to make these services available if the community isn't aware or feel they are put in place for them or don't see the necessity of them. The city can leverage websites that are already utilized and frequently visited by parents to share information on school-based mental health. For example, My School DC. Empower schools with resources and manpower to be able to meet families where they are and build an open line of communication surrounding the needs and wants of our students and school staff. DBH should share the results of the cost study publicly and make it easily accessible. The mayor and council should provide funding to match the findings of the cost study and work to implement these recommendations in all schools. These are just a couple of the ways we can work together as a community and as a city to ensure our future leaders grow up and be well-rounded citizens. These priorities are especially important to me after watching the world we live through COVID-19. COVID wasn't something any of us asked for, but it highlighted the inequities that exist in many facets of our community, especially mental health. We all suffer trauma that each and every one of us needs support to help work through. The most vulnerable being our children. We adults had and are still having a hard time navigating this new normal after COVID. We must work twice as hard to figure out the best ways to navigate this new normal. This is why the needs assessment is so important. Therefore, engaging families, students, LEAs, the communities are important.
You are almost a minute over your time. Do you want to say your last sentence?
I'm almost done, yes. Who better than those of us on the front line witnessing everyday needs of our students and community? The council should work together to ensure stakeholders are part of the development to ensure mental health supports in our schools are sufficient, quality, and equitable across all wards. Thank you so much for your time and attention and providing me the opportunity to share what I would like to see for our kids in the city. Sorry.
All right, I'm gonna keep this in mind for your PAVE sister and who are coming after you. No, thank you so much to the witnesses in this panel. I just want to mention, my staff reminded me, so in terms of the cost study, DBH anticipates having the data from Child Trends and the rate study contractor by the end of February. And then hopefully to get that information out shortly thereafter. So from a timeline perspective, we're thinking about March. The question mark is how this can or cannot impact the budget season going forward for the next year. But I do have a couple of questions that I'd like to ask. Let me pull this up. Okay, Ms. Creeder, can you make sure that we get a written copy of your testimony? I feel like I need like a acronym cheat sheet next to me in terms of the acronyms that everyone is using. Some of them are familiar and some aren't. Did you describe a program as PAD? Did I hear that correctly? And if I did, please tell me what that stands for.
Yes, absolutely. I feel like I need a cheat sheet as well sometimes. So PAD is the pre-arrest diversion program.
Okay, I got that right. All right. I was just like, maybe she might be talking to something else that we're not sure of. So you said that PAD had been folded into the community response program at DBH?
Yeah, and PAD is in cooperation, or was originally when it was a pilot program in cooperation with MPD, but now it is folded in to CRT, like you said.
Okay, and in your or NCCE's opinion, that folding in is not working well, or you feel like there should be other improvements that happen there?
Yeah, so based on the information we received from DBH, it's unclear to us whether or not the original PAD goals are met in its current form now that it's folded into CRT. And we followed up with DBH about this in particular, and unfortunately we didn't receive a response in time to incorporate that into our audit.
Okay, all right, thank you. Ms. Barclay Hoffman, you mentioned youth drug use and that Children's National was seeing more youth coming in with these particular issues. My understanding is that DBH has these prevention centers. I think there are 4 in the city that are part of the central aspect of DBH's strategy to addressing substance abuse with young people. Have you heard anything in terms of the patients or individuals who are coming through your program about their interactions with this program, or whether or not you are even referring folks to this program?
Thank you for that question. I would like to loop in our clinicians. I personally do not know if they have had interaction. Based on my conversations with our physicians, we would be happy to follow up with you to provide more of that information if that would be beneficial for you and your staff.
Yes, that would be great. If you could do that in the next few days here so that we can definitely incorporate that as part of our follow-up.
Yes, thank you.
With DBH. Thank you so much for that. Mark, thank you so much for your testimony. As always, full of great information. And, we just had an hour-long meeting. So I'm not going to ask you any specific questions because I do want to talk a little bit to some of the PAVE representatives who are here. Miss Aro, I wrote it down. Arolaju?
Yes.
Hey, all right. Okay. So the pandemic pushed many services into virtual formats. And I can ask this of some of the other PAVE parents as well. But from what you're hearing from folks in your school community, is this a format that they are more comfortable with as opposed to going in person somewhere? Or do families have concerns? Do children have concerns? I'm curious how you all feel about the virtual format going forward.
I think it is difficult. I think if that's all you have, then, definitely we want to go with that. But I think it's hard to get the attention of the kid, the parent, to keep them, entertained, or not entertained, but like focused on, what's going on in the session and things like that. So while it's difficult and hard, some people prefer it because of COVID. Some people missed it when we weren't in COVID. So it really depends. But I think the option should be made available for both options, for people for both options.
Okay. And in terms of during breaks, so obviously we know what is happening during the school year with school-based mental health, but are school communities communicating what services may be available either over winter break or spring break or even summer break?
I think some do. It's like my school does, my kids' school, but it's on a case-by-case basis. Some don't, some do.
Okay. All right. Well, I'm trying to keep myself to be mindful of the time because I know we have a lot of witnesses. I think Councilmember Gray had to pop off. He might be back and I might be joined by some other colleagues. So I want to thank this panel of public witnesses, but we're going to move on to the next panel. So just please make sure you submit the written testimony to us so that we have it for the record. Thank you so much, all of you, for being here today.
Thank you.
Okay. The next group, again, you have to proactively accept our request to be promoted to a panelist. Sherry Newsom, Sharnetta Boone-Ruffin, Lakeisha Myrick, Simone Scott, and Gail Avent. Okay. Again, you have to accept our request to be promoted as a panelist. And I don't see Sherry Newsom. Ms. Sharnetta, do you know if she's planning to attend? I hate to put you on a spot, but y'all from the same organization.
I will reach out and double check.
Okay. But you are here now. And so why don't you go ahead, because you would be next on the list to testify. So why don't you go ahead and present your testimony?
Okay. I just received a text. She would not be able to make it.
Okay, great. All right. Go ahead, Miss Boone-William. Oh, excuse me. I have Boone-Ruffin.
That's fine. That's
okay.
My name.
All right. Whatever works. Go ahead.
Good afternoon. My name is Sean Boone Ruffin. I'm a PAVE Citywide and Ward 8 Parent Board member and a multi-generational Washingtonian. In fact, Lawrence E. Boone Elementary School was named after my grandfather. My daughters, Shauna and Shanice, attend Jefferson Middle School Academy and Eagle Academy Public Charter School, Capitol Riverfront, both in Southwest Ward 6. I chose Jefferson because of the rich culture, history, positive student reviews, and the positive support. I'm also an alumni of Jefferson at the time, junior high school. We are in a mental health crisis all over the U.S. However, here in the nation's capital, we see and hear about killings multiple times a day, particularly in high poverty wards such as Ward 7 and Ward 8, where I currently reside. In fact, this morning there was a shooting at Potomac Avenue Metro Station where a person got off the bus and started shooting people on the way to the train platform. He shot 3 people and one unfortunately passed away, which was a Metro employee who was protecting a customer from being robbed. Again, we are in dire need of mental health support and trainings for all. This includes school-age children all the way up to 100, 120. It doesn't matter. Everybody needs to know something about mental health. Social and emotional learning has been a huge focus since returning to in-person learning after COVID. However, some neighboring school districts added social emotional learning to their PBIS or positive behavior interventions and support plan before COVID. By training teachers, staff, administration, and security personnel on the importance of tending to social emotional needs, it creates a positive mental health wraparound service to all students. Having school-based mental health is essential, sadly, due to a lot of students unknowingly who live in DC are living with PTSD, anxiety, and other mental health disabilities. The everyday violence, lack of positive parental guardianship, stigma in the community for mental health assistance, as well as just receiving mental health in the school base will help a lot of students. School-based mental health also includes group therapy sessions as well. This helps to reduce suspensions, expulsions, fights, and even help mediate peer-to-peer issues. An overwhelming response have seen when we are using student-based mental health services as well as social emotional needs in the schools by helping these people or helping these students conquer absenteeism as well as truancy and reducing suspensions and expulsions, even helping with meltdowns and issues in the classrooms. Let me see my time, 15 seconds, okay. So with the pipeline, I wanna thank you, Councilmember Henderson, with the pipeline for reciprocity. With Maryland, we also need to get Virginia involved as well, and this will hugely cure our gap between mental health support. Thank you.
Thank you. Lakeisha Myrick? Okay. Simone Scott?
Thank you, Councilwoman Henderson, Councilmember Gray, and fellow members of the Committee on Health for joining other leaders of the district who met with PAVE this last week of Voice and Choice Advocacy Week. During this time, Councilwoman Henderson, due to time, you were able to briefly share with us how your office is tackling the school-based mental health pipeline. As a Ward 7 board member with PAVE for over 4 years, currently we are addressing the issues of legislative policy and funding priorities focused around out-of-school time programs, in addition to the same for school-based mental health. Again, my name is Simone Scott, and I come to you today wearing many hats. As a mother of 2, a 15-year-old son academically thriving at Digital Pioneers Academy, and my 5-year-old daughter enthused at I Dream, both public charter schools east of the river. In addition, over the past 5 years, have uniquely acquired experiences over only until now believe was necessary for this moment. Thus, I hope my testimony is concise and time respected. As I've already mentioned, 2 of my hats, as a mother and also a PAVE Ward 7 leader. The third hat I would like to highlight is my current position as a parent board member of my son's school, DPA, as an engaged member of our school community. I regretfully share that we have lost 3 extended family members within a 65-day period. 2 of our students to gun violence weeks apart from one another, and shortly following the worldwide release of the brutal killing of our English teacher, Keenan Anderson. Regardless of personal and or public opinion, these 3 lives were very special to us. adding to the more severity to the already present challenges around our school community. Is an immediate need of successful solutions to aid in our healing. So at this time, I advocate on behalf of our school and our principal, Michelle Ashton, in which that DBA would reach to her ask in regards to these present challenges. Unfortunately, this is just one condition of our district exemplifying our urgent need for a further call of action to increase school-based mental health programs, professionals, and funding to properly service every school environment in our city. With short of time, we have already spoken in regards to the wellness wins that we have received. However, as we are seeing an increase of virtual mental health services for students, parents, professionals, factors such as affordability, insurance coverage, weeks to long wait lists, and more positions than bodies to fulfill the eligibility demand are just a few factors still needing resolution, which brings me to my final hat that I would like to share today. Even though I have small time, a few years ago, I had a near-death experience during my pregnancy with my daughter that resulted in 3 out of 3 members of my family needing and receiving mental and behavioral health services. Most importantly, changed the trajectory of how I needed to address my housing and employment. Thus, at a time, I just want to share with you, it is important that we begin to utilize TANF recipients, as well as other government individuals, 503c corporations that can begin to spearhead and immediately place services that are needed right now until the the SBMH program is fully rolled out and effective for professionals to be enrolled in our schools. So with my time up, I thank you very much. I look forward to continuing my testimony at another time.
Thank you, Ms. Scott. Gail Avent?
Yes, good afternoon. My apologies, I was trying to use 2 systems to get on camera, but I'm sure we're going to have an opportunity in person or on camera in the future. So thank you, Chairperson Henderson and the distinguished members of the council. My name is Gail Avent. I'm the Executive Director and founder of Total Family Care Coalition, TFCC, a nonprofit organization. I'm a resident of Ward 7, and I'm happy to provide testimony before this committee today. TFCC is a family-run organization located in Ward 6. We are specifically in Potomac Garden Housing Complex for over 18 years, and right down the street where the shooting took place this morning at Potomac Avenue Metro Station. TFCC was founded by 5 parents who had a common goal of finding community-based mental health and substance use services for our children. We provide person-centered services for nearly over 20 years. And over the years, we have evolved into a peer operating center, and now we are a certified peer support provider. Total Family Care is a leading provider of family advocacy and support for parents, children, and youth with serious emotional disturbances in the District of Columbia. We work closely with families to help them overcome their obstacles. We provide holistic services to families and children. Our mission is to keep families together for a better and safer community. We accomplish our mission by using trained peer support workers, individuals who have lived experience and who are determined to help families, youth, and individuals find innovative ways of finding opportunities to help resolve families' concerns. As a peer operating center, we provide substance use services and support the family experiencing challenges with deciding to get in recovery and to stay in recovery. We work with families in crisis every day. TFCC received a phone call from a family in need. One of my concerns come from a family. DBA sent the rapid response team to the home where there was a 12-year-old and a 7-year-old. A mom was experiencing a family crisis. Correct me if I'm wrong. The crisis response team is usually for adults. CHAMP usually respond to children in crisis. Over the years, we have served over 5,000 children with parents, caregivers, and natural support. We have many diamonds in the rough and parents and returning citizens who are committed to giving back and want to make a difference in somebody else's life through much reflection and understanding of their own need. We was talking about peer certification training in this city. To my knowledge, there's only been 2 peer certification training since COVID. It's my understanding that the last class already won, but one individual passed, but they still haven't received their certification. So that's 12 or 13 individuals who's waiting in the wing to come into the workforce. My other concern is around coordinated care when it comes for children being discharged from children's psychiatric facility. I sit on a committee that review every child has been recommended to leave this city to receive psychiatric treatment facility treatment, but it doesn't include parents, who is the most person who needed support to understand how to improve their parenting skills and to also make that successful transition back into the community after they receive this wonderful service from these facilities. Lastly, TLCC service and portable. We go where the need is. If it's in the home, if it's at school, community, or courts. Our approach is to coach, educate, and support families and not to blame and shame them. Mr. Rogers, the person who do Mr. Rogers' neighborhood, he said his mom always told him, if you get in trouble, or if you have a problem, look to the helpers. We are all helpers. The families in this city look to you, the council, city leaders, and agency directors to help them. Are you ready to help? Thank you for the opportunity to testify before this committee today, and I stand ready to answer any questions.
Thank you. And thank you to this panel of witnesses for taking the time out of your schedule to testify here today. Again, it does provide us a good, fulsome picture, or I don't say fulsome, but a better picture of how residents and the public see the work of an agency throughout the year when folks come to testify. So I want to say thank you for that. For the PAVE parents, I'm going to ask a slightly different question than I asked the panel before. But has your child's school engaged with you all in terms of the implementation of the mental and behavioral health program, the school-based mental health program? Has it been a proactive communication? Because what I'm hearing from some folks and even from some providers is that it varies based on the school leadership in the building. And on the one hand, I have school leaders saying they need more support, but on the other hand, I have families saying, we're not hearing anything about this from school leaders. So I'm curious what your experience has been.
I can go first. So for me, my daughter is at Jefferson Middle School Academy. She's in her last year, and she's had, some challenges with mental health since coming back into the building. However, the school definitely has mental health supports for her and her classmates. The parents, we receive weekly newsletters, Jefferson newsletters, that houses all mental health supports that are available in the school as well as in the community. This has been very helpful for not only myself, but other parents, which I've spoken to as well. Just getting the information out there to the community, knowing what's available. Now, my littlest one, she's only 3. So, so far, I've heard very little, but I have seen the psychologist as well as the school counselor in the school.
Okay, Ms. Scott?
I might follow. With Digital Pioneers and iDream, we do have a transparency and we do have to, from my understanding, professionals, one in each location. However, we are finding that the amount of students to service in regards to the one professional is making it very difficult for every student and for the school to service properly. And so I'm finding in my schools where we are provided the information, however, what information is provided and how that professional is able to interact efficiently with us, I can understand that would be a challenge.
Yeah, I remember this came up last year where there's some schools, either your enrollment is larger or the particular traumas and issues that are happening in that school require more people. But from a staffing standpoint, we still hadn't met 100% of schools having even one person. And so the question was, do we add another person to some schools, even though someone doesn't have any? And what happens there? But, the workforce challenges are certainly one that I have heard a lot. And we're going to be exploring not only with DBH, but also with DC Health and the particular boards that license these individuals around what more we could be doing from a recruitment and retention standpoint. But also, are there other ways that we can get other qualified, qualified individuals to help out our young people? Because I definitely hear you, Miss Sharnetta, like our kids are definitely in need. And it's just a question of, do we have enough people to make sure that we can meet the need? Thank you for your testimony. Ms. Abbott, thank you so much for your testimony as well. And I look forward to seeing you in person too. I am going to follow up with DBH about the CHAMPS issue that you raised.
Yes.
Because I even remember when I was committee director for the Committee on Education years ago, there were lots of concerns around CHAMPS in terms of how quickly they are deployed, even to schools, right? During the school day, that a school may make a call, but it may take 3 or 4 hours in order for CHAMPS to respond. And therefore that's, way too late after the fact. But your point around if a family calls after hours, who is the one who responds? Is it CHAMPS? Is it CRT? And so what is the appropriateness there? So I'll follow up with DBH on that. But thank you all for your testimony and for being here today. And for the PAVE folks, it was great to see you guys in person last week.
Thank you.
Thank you. All right, we're moving right along here. Okay, our next 5, Melissa Wade, Melissa Millar, Rachel White, Chris Charles, and Thaddeus Bradley Lewis. Commissioner Thaddeus Bradley Lewis. All right, and for those who are just joining us, we are switching out panelists right now. If you are in this upcoming panel, please look on your screen because you do have to affirmatively check that you want to be elevated to be a panelist so you can present your testimony. Okay, I see Melissa Wade here as everyone else is coming into the room. So Ms. Wade, if you want to go ahead and get started, please do. Just need to unmute. There you go.
That would be helpful. Hi, hello everybody.
Oh, good afternoon.
All right, thanks for having me. I'm gonna go ahead and get started. So my name is Melissa Wade, and I serve as Managing Director of Mental Health at KIPP DC, where I work closely with mental health clinicians, partner organizations, and school leaders at our networks, like 21 schools, and our virtual learning program to provide students with meaningful access to mental health services and supports. So today, I'm here to thank the Department of Behavioral Health for their ongoing collaboration. Because of the collaboration that we've had with DBH and the resources that this particular council has put behind school-based mental health, there are more students receiving needed services now than at any other time in my tenure at KIPP DC. I'm also here to go ahead and recommend a few ways that we can strengthen the school mental health program in the coming year. The number of referrals for mental health services from our school-based clinicians and our partner CBOs has doubled since students returned back to in-school learning after the pandemic. At the same time, every clinician at every one of our schools has a full caseload with a wait list. So basically there's an expanding need, but not so much expanded licensed clinician availability. So that kind of speaks to the point that you were making earlier. KPDC collaborates with DBH in a range of important citywide efforts to improve services for children in DC. And these activities include our participation in the citywide Coordinating Council on School-Based Mental Health, the Project Aware federal grant, and Project Aware Community of Practice, as well as the school-based expansion of mental health supports led by DBH. Over about the past 6 years, KPDC has invested heavily in our internal team of mental health practitioners. However, even with that expanded capacity, we cannot serve every single student in need of support without DBH's help. We're proud to partner with DBH, which has expanded its school-based mental health services to support our partnership with community-based organizations, Mary Center, and Catholic Charities since 2018. These partnerships are contracted to supply full-time mental health practitioners at 12 of our schools, and they provide valuable individual and group therapy to over 200 of our most vulnerable students at no cost to our students or schools. These practitioners also provide full school Tier 1 trainings and connect them with mental health programming and community wraparound services. So as the council and the executive look towards next year's priorities, I'm here to reiterate that the need for mental health services at KPDC and across the district remains very high. So I have some specific asks and recommendations, right? So the first is essentially to expand access to DBH school-based mental health services so that we can expand and give supports to more students. Right now, the program is concentrating efforts on those schools with the highest documented need, but this means that only 12 of our 22 schools and programs receive direct support from DBH. So as I mentioned before, the need is getting higher, and it's not only concentrated in some of our schools, it's occurring in all of our schools. In addition, we're seeing a high need district-wide on educator mental health and wellness with more adequate resources to address those needs. A lot of our teachers are struggling and they need our help so that they can remain in the classroom and serve our students. We also would like to create a stable funding stream for the school-based mental health program. We want to increase the number of available clinicians. This is kind of like our biggest thing. Some of the reasons that we want to actually address is streamlining and improving the process and reducing the lag time to certify mental health clinicians so that student supports are not held up by any kind of processes. For example, a professional counseling licenses the time that it takes to kind of get their licenses. It seems that there's a backlog in terms of like the board's capacity to approve licenses also affects how fast our students can get services from those licensed professionals. We also want to continue funding LEA administrative supportive services. Currently, that work is primarily funded by the Project Aware federal grant, but as we know, that grant ends in September, and so we're going to be without that training and professional development support that we've been used to for the last 5 years. We also want to expand school-wide training for school staff on trauma-informed practices and responding to adverse childhood experiences. So in summary, I can't stress enough that in the midst of a global health pandemic that has altered nearly every structure that our students have known, this increased access to mental health supports has been a critical component of the return to in-person learning. We thank the leadership at DBH and the council for your support. And thank you to the council for allowing me to speak today.
Thank you. Melissa Millar.
And members and staff of the Committee on Health. I'm Melissa Millar, Ward 7 homeowner and consultant for the Coalition for Nonprofit Equity, a coalition of approximately 1,000 DC nonprofits advocating for full funding and implementation of the Nonprofit Fair Compensation Act of 2020. The law, effective since March 2021, seeks to ensure consistent application of overhead or indirect cost rates across all grants and contracts made by DC government agencies to nonprofits. This fiscal year is the second of 5 years of a phased-in implementation period for the law and attaches to all nonprofits, grants, and contracts valued at up to $5 million each, with the exception of hospitals, universities, and foundations. This law, allowing 5 ways to calculate and use an indirect cost rate in negotiations with the district government, is an important step in right-sizing and adequately compensating nonprofit partners for their actual costs of doing business in and with DC and elevating nonprofits' financial well-being. The passage and implementation of this law is an equity issue. Nonprofits diligently serve district residents, often literally at their own expense. At just one of the 1,000 nonprofits advocating with the Coalition for Nonprofit Equity, the gap in indirect costs on district grants and contracts was over $400,000. This gap in government funding must be raised from other sources just to continue providing the government services and programs. While the implementation of this legislation remains problematic across DC's grant and contract making agencies, we do want to give kudos to DBH. We are spot checking FY23 solicitations for inclusion of references to the law and for standard language about calculating the indirect cost rate and negotiating or renegotiating payments with the district. We have found 2 FY23 solicitations, one a grant for recovery residences and one a contract for temporary nursing staffing, both of which correctly included all the ways a nonprofit could effectuate a rate pursuant to the Act and named the Act. We will caution, though, that budgeting for indirect costs may yet not be sufficient, as we have heard from nonprofit partners that contract and grant administrators have informed them that their organizations may take the rate, but at the expense of providing fewer services and or programmatic offerings. The law is meant to provide funding for the grant or contract's activities as well as the indirect costs for the nonprofit provider. It should not be either or. As the government continues to fully implement the Nonprofit Fair Compensation Act of 2020, the Coalition looks forward to grant and contract personnel training across all agencies and offices, standardized language for all solicitations similar to what DBH is using in their solicitations already, and a detailed cost analysis of the extent to which indirect costs have been retained from nonprofits on local and federal grants and contracts, assisting the government in its FY24 budgeting process. Overall, we're pleased to see DBH naming the Act and its processes and its solicitations, and look forward to working with the agency and the committee on ensuring proper budgeting for nonprofit grants and contracts in FY24 and beyond. Thanks for the opportunity to testify, and I'm happy to answer any questions.
Thank you. Rachel White.
Good afternoon, Committee Chair Henderson and members of the Committee on Health. Thank you for the opportunity to address the Council today by providing testimony regarding the performance of the Department of Behavioral Health. My name is Rachel White, and I'm the Senior Youth Policy Analyst at DC Action. At DC Action, we use research, data, and a race equity lens to break down barriers that stand in the way of all kids achieving their full potential. Our collaborative advocacy initiatives bring the power of young people and all residents to raise their voices to create change. Through our Youth Economic Justice and Housing Coalition, we advocate with youth and youth-serving organizations in the District of Columbia for policies, funding, and programs that expand access to comprehensive supports and services that disconnected youth and youth experiencing homelessness need to successfully transition into stable and productive adulthood. We're also home of DC Kids Count, an online resource that tracks key indicators of child and youth well-being. One of our priorities is dismantling the pipeline from youth homelessness to chronic adult homelessness, which can only be done through intentional investments into positive youth development systems throughout the district. By investing early in helping young people find stability, we're cutting off a primary contributor to chronic adult and family homelessness. It's important to note that people living with impaired mental health and disorders are more susceptible to 3 key factors that can lead to homelessness, such as poverty, disaffiliation, and personal vulnerability. Behavioral issues may lead them to withdraw from friends, family, and other people, creating a vacuum of support and fewer coping resources in times of trouble. Mental illness can also impair a person's ability to be resilient and resourceful at times. It can cloud thinking and impair judgment. And for all these reasons, people with mental health illnesses are at greater risk of experiencing homelessness, which is why it is imperative that they're able to access support. We are pleased to report that in the past year, we have held quarterly meetings with the Department of Behavioral Health, resulting in DBH representatives meeting with youth homelessness providers to educate them about the services that are provided through the Department of Mental Health and how youth can access them. These conversations also highlighted the existing gaps in service access for youth experiencing homelessness, and DBH committed to working to close these gaps if allocated the appropriate funding. Existing behavioral health supports are missing the mark and not meeting the mental health needs of youth experiencing homelessness. According to youth, their service providers, there's a lack of accessible, youth-friendly, culturally competent mental health services throughout the district. This gap acts as a major barrier to youth achieving long-term stability. Per the 2019 DC Youth Count Survey, over 1,300 youth unaccompanied reported experiencing homelessness. Keep in mind that this is pre-pandemic, so we infer that this number is substantially higher today. Service access data received from DBH indicate that only 288 transition-age youth between the ages of 16 and 24 experiencing homelessness receive mental health services. So not only are we hearing from youth, their providers, that they cannot access mental health services, we have the data to back it up from DBH. As a coalition, we are currently researching a mobile mental health model that will provide mental health services where youth physically congregate, bringing the services to them, making services more accessible. This model will be detailed in the upcoming budget hearing. Recognizing that the children, youth, and families served by the public behavioral health care system in the district are primarily individuals of color, improving our system is a matter of equity. Improved access to behavioral health services is proven to be transformative for children and families and can boost long-term overall health and productivity in communities, as evidenced by workforce outcomes and reduced crime rates. In addition to securing funding during budget season to create a mobile mental health unit to meet the needs of unaccompanied homeless youth, we're asking the Committee on Health to ascertain specific information from DBH during the government witness performance oversight hearing regarding their 2021 mental health and substance use report on expenditures and services. Guiding questions are included in my written testimony that I have submitted, so I won't go over them today for the sake of time. But receiving this data will paint a clear picture of which subset of youth in the district are receiving mental health services through DBH, what the services actually are, and how consistent the services are, which will give us the tools necessary to advocate for greater access to mental health supports. Thank you for your time and consideration, and I will be happy to answer any questions. Thank you.
Thank you. Chris Charles. Chris Charles, if you are speaking, we cannot hear you. We still cannot hear you. Okay. While we work out that technical issue, I'm just going to go to the next witness. That is Bradley Lewis, Commissioner, ANC 3A01. Go ahead with your testimony.
Thank you. Good afternoon, council members. Thank you for the opportunity to speak today. My name is Thaddeus Bradley Lewis, and I am an ANC Commissioner for Single Member District 3A01. I am speaking as a representative of my single member district and not the commission as a whole. Commission Area 3A includes the Psychiatric Institute of Washington, or PIW. While my single member district does not include PIW, its northern border is less than a block south on Wisconsin Avenue. I am speaking to you today because it is my understanding that DBH has direct oversight over some of PIW's services. I also believe there are issues and concerns about PIW that should be of concern to DBH in this committee, regardless of what DBH currently oversees. I and many of my constituents, as well as others in the neighboring area, have witnessed or heard about public safety incidents involving patients discharged by PIW. After learning more about those incidents, I became concerned about the care being provided. Some of these incidents seem to be related to PIW's discharge policies. Patients appear to depart without adequate means or capability to return home. This is troubling because PIW's patients come from all over the district. Also troubling on many levels, some constituents have told me that they have seen patients discharged without adequate clothing. One constituent reached out to me about their experience working for PIW. They considered its discharge planning to be dangerous. Here are some of the concerning details they provided. 1, little was done to assist patients who were resistant to post-discharge services, and after Medicaid funding had run out for a given patient, that patient would be put on the street without a firm plan. Number 2, patients who claimed their belongings were lost somewhere in the process of being transported to PIW and staying there were often disregarded by the staff who thought the patients were trying to falsely obtain reimbursement. Number 3, bus tokens provided by PIW were often refused by WMATA bus drivers. PIW continued giving them to patients, though it was aware of this. And number 4, PIW did not adequately staff its facilities, which made them less safe and resulted in a high turnover for staff. These claims should be shocking and dispiriting to anyone who considers how important PIW's services are and the impact any deficiency, let alone a number of them, has on a very vulnerable group of people. It is my hope that DBH and this committee can work within existing contracts and regulations to address these issues. But if PIW cannot be compelled to change how it operates, it is still imperative that we identify other ways to change the status quo. People in need of mental health care in our city should not be subjected to a system that endangers them or contributes to them being perceived as a danger to others. Thank you for your time today, and I welcome any questions.
Thank you. Okay, we're going to try it again for Chris Charles. If you are speaking, we still cannot hear you. Oh, it says that you are mute right now. Nope, we still cannot hear you. Do you want to, I'm assuming that maybe, Chris, you can hear me. And if you can, perhaps you want to sign out and sign back in. And we'll be sure to let you in. Okay, we are still waiting for Chris to come back, but I'm going to ask some questions of the public witnesses who are already here in the interest of time. Great. All right. Thank you again to all of the panelists for being here today. Ms. Wade, I want to start with you. In your testimony, you mentioned that the number of referrals has doubled at KIPP DC, and that your clinicians have a full load with a wait list. Mm-hmm. What is the definition of a full load, just for context in terms of what we're talking about here from a volume standpoint?
Yeah, sure. So first, I want to distinguish between general education students and SPED students, right? Because SPED students were required and prioritizing their services based on their IEP. So I'll speak specifically to gen ed students. So we would consider a full caseload anywhere between 20 and 25 students. And that would go for our school-based clinicians as well as our CBO clinicians as well.
Okay. And how many does KIPP DC have amongst all the various campuses that you also have?
For our school-based clinicians, we have 45. And we have 12 schools that should have CBO clinicians. But of those 12, we've only been able to staff 4 just because of the general shortage in clinician availability. Yeah. We also still have some vacancies at our actual schools for the school-based clinician roles as well.
So how are you finding recruitment for these positions? Because for you to say, yeah, we got 45 clinicians, to me, that's like, whoa, that's a lot. I mean, obviously you have a lot of
kids. Right.
But I'm curious, like, I've met with some charter school leaders who will say, just give us the money and let us do it. Mm-hmm. And I'm curious, like, how are you guys able to hire more than perhaps the CBOs? Is it a different, like, is it a benefit structure that you're offering for them to be as part of the school staff? Like how does that work?
Well, how much time do I have?
But I mean, we can have an offline conversation too,
Yeah.
because I am genuinely interested in this, because I do hear, you know, I talked to some charter leaders about this last year as well. But I'm just curious, you know, how does recruitment go for you all?
Oh, recruitment. So we do put a lot of energy into recruitment, right? So for my team, I consider my team to be like 70 deep, right? So not only do we have social workers and counselors on staff, we also have clinical psychs and behavior analysts. So one of the things that we kind of incentivize candidates is that we offer supervision, right? So like I'm an LI, we're going to offer in-house supervision to people who are LGs, right? For both our professional counselors as well as our social workers. We also offer in-house CEU professional developments, right? So if we have blocks of time for professional development on the calendar for our teaching staff, like in-house PDs, then we're also going to use that time for our clinical staff to come together and take advantage of that. So that means I have to go the extra mile and like request different CEUs from the Department of Health and our Board of Social Work.
Wait. What was that last acronym that you used? CEUs?
CEUs. So our licensed clinicians have to have CEUs, continuing education units, in order to
thank you.
Right? And for lots of different places, if you have a license, you have to pay out of pocket to get those CEUs. So one of our incentives is like, hey, we're going to do our best to provide those 40 CEUs that you need every 2 years in-house in order for you to renew your license. The other incentive we do is there's fees accrued when you have to renew your license and when you apply to take your test, we reimburse for that through our organization, right? So there's lots of different things that are not necessarily like written in the job description that we promote when we interview to say like, hey, like we're gonna give you X number $1,000 in credits towards license renewal, CEU professional development, in-house supervision. That kind of adds up for you as a clinician individually. That kind of puts us, you know, a little bit others.
Yeah,
but it's still not enough then. I'm just letting you know.
Well, yeah, I mean, obviously, right? If money were no object, we'd be talking about something completely different. But when we're talking about putting together a package, I can definitely see how this is like something that folks will find attractive as an option. But if you don't mind, I'd love for my team and I to connect with you offline to learn a bit more about how you all are approaching, you know, what you provide just in general. But thank you so much for being here.
No problem.
I do have some questions for Rachel. Okay. So you mentioned that DBH partnered with your coalition to discuss available behavioral health supports for youth and how to strengthen the partnership between DBH and homeless service providers. Can you talk a little bit about the follow-up from those initial conversations and how you all are working together going forward?
Right. So we, our relationship now with DBH and who we've been speaking with, it's very productive. Representatives from DBH came to the coalition to, like I said, explain services and how you can access them. And then during that conversation, they learned about the gaps that exist. So since those meetings, we've had several meetings afterwards to see how we can work together. And we've shared how we are interested in the mobile mental health unit, and DBH agrees that it's a great idea because they want youth to receive services who aren't receiving them and understand the unique needs that youth experiencing homelessness have and are willing to work with us. They even applied for a federal grant to do the work as well, but they did not receive it. And so they are supportive of me advocating for additional funding for DBH to provide such a program.
Okay, thank you for that. Commissioner Bradley Lewis, I think you've spoken with folks in my office, and so I want to thank you for your testimony here. I agree with you in terms of some of the things that you mentioned being very disheartening to hear, even down to tokens for WMATA, which I don't even think that the newer buses are even equipped to accept tokens. Like the machines are not equipped for that. And so one of the things though, just for transparency's sake, right? When I talk to DBH about PIW, they'll say, oh, we are only responsible for like the little piece that we have in terms of the number of beds that we use with them. I haven't had an opportunity yet to get into it with DC Health, but it sounds like what you're saying is someone in the district government should be responsible for how this organization is providing services, just even as a licensed facility in the district, regardless of who's contracting with who, but literally just because you exist here and you're not necessarily, as you feel like, are doing full up to par in terms of how you manage discharge. Is that accurate?
I would say that it is. I mean, in speaking to other stakeholders, just as some background, PIW was part of ANC 3E prior to the redistricting, and 3A itself did not exist prior to the redistricting, and I'm a newly elected commissioner there. I attended a 3E meeting where they had somebody from PIW present and ask questions. And it sounds like these are sort of perennial issues. And in speaking to lots of people who are more informed than I am, I understand that there are obviously limitations, even if PIW was offering the moon to patients or assistants, that, you know, you can't hold somebody indefinitely. If somebody is prepared to be discharged, you will discharge them. And what happens thereafter, you know, there maybe is a limitation, especially for PIW, to what it can do to avoid a tragic or undesirable incident. However, I do think that in speaking with 3E commissioners and communicating with businesses in the area, there seems to be a bit of a feeling of deja vu when it comes to these issues and what PIW says it's prepared to do to address them. And I think their discharge policies and the assistance that they do provide, whether that be bus tokens or any other means of assistance, is something that they've either been vague about or they've been limited in being able to kind of provide an ongoing sort of account of how effective their policies are.
Right.
Unfortunately, just to finish my thought, I think that this is also a larger issue because we do have an entity that's providing a service to a very large city, and PIW is not necessarily located in the most accessible location in the city. It's more than a mile from, well, it's at least half a mile, 0.7 miles from a metro station. There are bus lines, but they aren't necessarily going to get you very easily to areas east of the river. So I think that's also just a larger issue that we're faced just by the status quo.
Right. Have you or your other commissioners, to your knowledge, expressed some of these concerns with DBH? Like, have you raised them from a commission standpoint, and what has the response been?
Well, I will say that 3A has only had one official meeting in the entirety of its existence. So
that's right.
We've yet to really have an opportunity to really on an official level. I mean, I've spoken to your office, and I've kind of started to feel out liaisons at DBH and other agencies. I'm trying to work with our MOCR as well, so that we can kind of approach this in a holistic sense, because unfortunately it has become, you know, an NPD issue as well as, you know, a behavioral health or a mental health problem or challenge in our community. So I really would appreciate the assistance in making these connections so that we can really kind of start to generate that record, because otherwise I do kind of have to rely on people telling me, oh, this is what we've spoken about with PIW. This is what PIW or DBH has said in the past, but it's all going to be hearsay for my commission until we have more time.
Got it. Okay. Well, we'll definitely follow up, and not just with DBH, but also with DC Health as well, because I do feel like there's some intersection there in terms of, them as a licensed facility, and what happens there. I am way over my own time. And so I want to thank, I don't have any further questions for this panel. I want to thank all of the public witnesses. And again, please make sure that we have your written testimony. Chris Charles, hold on. You will be first on the next panel, but I'm going to excuse these folks who've already been here. And so give us a minute while we transition.
Thank you.
Okay. Chris Charles is going to stay with us, and then I'm going to call the next panel and we'll get started there. And then I'm likely going to need to take a break here in a minute. Okay. Carla Reed Witt, Mestwet Dejin, Anne Chauvin, Betty Gentle, and I have a note that Ike Noe Chi will be testifying on behalf of Marie Morlis Black from MBI Health Services. Okay, while we make that transition, again, for folks who are just joining, if you are coming up to a panelist, you do need to affirmatively accept our invitation. Chris, why don't you go ahead and go off mute and go ahead and get started. Chris Charles, are you there? We cannot hear you. Hold on one.
Hear me now?
Yes, we can hear you now. Hello.
Thank you. So sorry about all that. So I will jump right in. So thank you, council members and city council. My name is Christopher Charles. I'm the director of the Prevention Center at Latin American Youth Center and over our DBH program. The DC Prevention Center for Wards 1 and 2, DCPC, and the program DC Opioid Response, DCOR. I am representing LAYC and here to speak on the importance of our role in combating substance use disorder and reducing fatal overdoses by empowering and assisting partner organizations to address the challenges faced by our community. I will be describing some of our achievements in ensuring positive health outcomes to navigate out of the pandemic. LAYC has been in the community for over 50 years and has served over 5,000 youth in the last year. Our work includes health and wellness programming made possible by the funding of DBH. The Substance Use Disorder SUDS Prevention Program of DBH oversees 4 prevention centers, each serving 2 wards within DC. LAYC is responsible for DCPC wards 1 and 2, and DCPC serves as a dynamic hub that engages and supports and helps connect the many community elements that are needed for promoting healthy children, youth, and families, as well as the drug-free District of Columbia. All strategies implemented by the DCPCs are based on the Substance Abuse and Mental Health Services Administration, SAMHSA, Strategic Prevention Framework. The DCPC is designed to strengthen and mobilize communities to prevent substance abuse among youth in wards 1 and 2 by conducting outreach and events, conducting community conversations, and organizing community prevention networks, or CPNs as we like to call them. For outreach events and trainings, we focus on providing individuals and communities with critical substance abuse information such as trends, policies, and risk factors. Each year, the DCPC partner with DBH hosts a DC citywide drug prevention symposium. For our community conversations, we provide insight to DCPC into what individuals see as issues affecting their communities. We use this information to serve as a qualitative data to inform DBH on community trends. Community conversations also allow the DCPC to identify community leaders to perform prevention networks. This work has led to the creation of multiple awareness campaigns, such as the K2 Zombie, Blunt Truth, and the Vaping campaign. Community prevention networks, or CPNs as we call them, are community organizations and or members trained in the SPID and implement strategies to reduce substance use within their communities. Currently, we have 10 active CPNs and 20 active community partners to include businesses, faith-based organizations, and community-based organizations. LAYC's DCPC network, along with the prevention centers, have become Narcan and fentanyl test strip distribution sites, and it is important to note that the prevention centers are restricted to distributing to individuals. We look forward to our community mobilizer facilitating more Narcan workshops and hosting quarterly Narcan distribution events. In closing, the work of DBH, SUDS, LAYC, DCPC is critical to providing substance abuse prevention resources to the community and in providing regular updates regarding drug use trends. Through our work over the last 10 years, we have focused on alcohol, tobacco, K2, synthetic, cannabis, opioids, marijuana, and most recently, the opioid epidemic and vaping. We hope that the district will continue to fund this component of DBH prevention work. I'm free to answer any follow-up questions. Thank you so much.
Thank you, Chris. And thanks for sticking with us. All right, Carla Reed, Witt.
Can you hear me?
Yes, ma'am.
All righty. Good afternoon, Councilmember Henderson and members of the Committee on Health. My name is Carla Reed Witt. I'm co-founder of Decoding Dyslexia DC. Decoding Dyslexia DC is a member of the Strengthening Families Through Behavioral Health Coalition, as is Parents Amplifying Voices in Education, or PAVE, where I serve on the citywide Parent Leadership Board. I am testifying today to support the school-based mental health priorities of PAVE and the Strengthening Families Through Behavioral Health Coalition. Those priorities, along with some others, are included in my written testimony, but for the few moments I have your attention today, I want to emphasize the urgency needed to create a sustainable, efficient, well-funded, and meaningful school-based mental health system, because we need to move on. There are huge and gaping holes in DC's overall children's mental health system. Within our city, children only have access to short or long-term acute mental health services or regular visits to a therapist, but nothing in between. Stays in the hospital are the most intensive level of care. Seeing a therapist is the least intensive level of care. Within DC, there are no step-down or intensive outpatient services for children. In fact, the Department of Behavioral Health was sued in 2018 on behalf of Medicaid-insured children for precisely this reason, in a case titled MJV, the District of Columbia. Without intensive outpatient services, a cycle begins. Children leave inpatient services, go back to school and home, struggle, go back into crisis, and end up in the emergency room over and over again. As a result, the district's children suffer drastically, curtailed life opportunities, cycling in and out of psychiatric hospitals and psychiatric residential treatment facilities that are often hundreds or thousands of miles away from their families. In MJV-DC, the plaintiffs are requesting community-based intensive outpatient services. However, even if their lawsuit is successful, it will only guarantee these services for Medicaid-insured children. If at some point DBH does provide intensive outpatient services, children without Medicaid would not be eligible to receive them. The private medical industry model for these services is partial hospitalization programs and intensive outpatient services. No DC hospital or DC private behavioral health group offers these services for children. According to a 2021 Kaiser Foundation report, 41% of DC children are insured by Medicaid, while 48% of DC children are insured through their parents' employer. We have to fix this. The mental health needs of DC kids are at an all-time high. As we work to build a system to address gaps in our children's private health system, I want to suggest that we create an easy and quickly accessible process to allow privately insured children to easily access services which DBH provides, but which do not exist privately within the city. It is imperative that intensive children's mental health services be available within the city limits so that children can access them while simultaneously attending school. This idea is not meant as a substitute for building a complete private children's mental health service continuum, but as a stopgap, so that all children, no matter how insured, can avail themselves of the appropriate level of mental health services as soon as possible. We need to think of school-based mental health as the backbone of a DC children's mental health continuum. In order for school-based mental health programs to be successful, we have to fill the gaps in the continuum. We need a landscape analysis, a plan, and funding. Thank you for your time. I look forward to further discussions regarding these issues and working with you to create solutions and see them through.
Thank you, Ms. Reed-Witt. Ms. Watt Dejin? Oh, okay, not here. Ann Chauvin. Oh, and before you go, Ms. Chauvin, I just want to recognize we've been joined by Councilmember Zachary Parker from Ward 5. Councilmember Parker, we're in the middle of a panel. I think we have maybe about 2 more witnesses, and then I'll turn to you for an opening statement or any questions that you might have. All right, Ms. Chauvin.
Good afternoon, Chairperson Henderson and Councilmember Parker and other members of the committee. My name is Ann Chauvin. I'm the CEO of Woodley House. Thank you for the opportunity to submit this testimony today. Woodley House has been providing supported housing and related services to residents of DC with behavioral health disorders for 65 years. Woodley House has a strong, long-standing partnership with the Department of Behavioral Health, and we enjoy collaborative and productive relationships with many of the department staff. We recognize that the department has many areas of service to DC residents to oversee and that all are important. We have been asking for several years and continue to ask that residential services be given adequate attention. Housing is a proven intervention for improving health outcomes, and those who qualify for DBH residential services deserve adequate, safe housing with support services to maintain their stability. The residential service area we are focused on today is mental health community residential facilities, or mental health CRFs, that provide a high level of care and services in group homes that are staffed 24/7. As a behavioral health services and supported housing provider, we are advocating for 2 areas today. One, to have a system for rate adjustments developed, such as annual cost reporting for mental health CRF services, to ensure sustainability for these critical beds for DC's most vulnerable residents. And 2, for the workforce crisis, asking for DBH to develop incentives for behavioral health staff to work in the community. Currently, there is no system in place to consider annual rate changes for mental health CRFs, which again are therapeutic living environments staffed 24/7. Our request is for DBH to develop and implement an annual cost reporting or other annual rate setting system for mental health CRFs. DBH has said it would look into an annual cost reporting system for for mental health CRFs a couple of years ago, but we have not heard about any progress. Meanwhile, our service rates are based on a rate study conducted in 2016 and implemented at the end of 2018. Many DC residents with behavioral health disorders are living in poverty and need access to a mental health CRF level of care. The rate study that DBH had completed by PCG recently did not include mental health CRFs. We provided our data regardless and had hoped that in the absence of any other system being in place for determining rate increases, that the study would show what rates are needed to care for the DC residents entrusted to us. It is not just the cost of staff salaries we are concerned with. Inflation costs impact everything we do: food, utilities, maintenance and repairs, household supplies, client assistant needs. Our request for help from DBH, our funder and oversight body, seem to have not been heard. Our second request is regarding the workforce shortage crisis, which is crippling our behavioral health system of care. We have seen and heard that DBH has provided grants to some providers of a few service areas to assist with recruitment and retention. We have not seen or heard of any efforts to assist and support mental health CRFs or for case manager or community support workers recruitment and retention. Mental health CRFs are similar to nursing homes or other like communal living facilities, and we are all struggling to hire and keep adequate staff. We at Woodley House have increased our direct service staff salaries by 25 to 45% over the last few years, and we are still struggling to hire. We are unable to give COLAs this year and only surviving because of a COVID era loan. I am uncertain as to how long we can sustain our service to the community without adequate funding and assistance from our government partners. Thank you for allowing me the space to comment.
Thank you. Betty Gentle.
Greetings, Chairperson Henderson and members of the committee. My name is Betty Gentle. I'm the Senior Advocacy and Community Engagement Specialist at Summit Incorporated, also known as So Others Might Need. Thank you for the opportunity to testify. Since 1970, SUM has been working to break the cycle of poverty, homelessness, and hunger in the district. Our comprehensive continuum includes a full range of high-quality healthcare services that are people-centered, trauma-informed, and grounded in equity. This includes behavioral health services where our staff supports adults in stabilizing and maintaining their mental health and a range of SUD treatment options that empower adults to break the cycle of addiction. Our partnership with DBH makes it possible to offer these mental health and SUD services. For SUM's testimony today, we will focus on two areas where improvement is urgently needed for our clients and for providers. First, to maintain mental stabilization and recovery, many clients need in-person services. Pivoting from in-person services to telehealth services during the pandemic was no easy feat, and transitioning back to serving the needs of clients face-to-face also poses many challenges. However, the stability, the sobriety, and even the lives of our clients depend on strong communication between DBA certified providers within the network and between providers and the social services programs that help those clients meet their daily needs. For example, SUM's residential housing staff have reported that a lack or delayed response from some community providers and ACT teams have resulted in negative direct impacts such as increases in community challenges and violence when they have not successfully been able to connect the resident to their provider. Our direct services staff have also been unable to get providers to our main office on O Street Northwest to meet their clients who are predominantly unhoused. Furthermore, staff in our recovery program's ability to provide effective SUD treatment is also significantly challenged by the mental health decompensation of clients who have not been seen by their ACT team provider for quite some time. Because SUM is a healthcare provider, we understand the ongoing workforce challenges and know that many job candidates prefer teleworking, especially considering the salaries that community providers can offer in comparison to private and even government employers. In addition, we also know that updated regulations do support telehealth services. However, there are clients who need in-person support and consistent communication with their DBH community provider. We believe that DBH level setting with all DBH certified providers and ACT teams on what the expectations are for community-based services and response is urgently needed and requested. We also suggest adding a clear community feedback protocol for DBH and the provider network to better understand the experience of partner providers. Second, provider rate increases arrive slowly while administrative burdens grow rapidly. In 2021, SUM and other SUD providers expressed during the budget oversight hearings that the financial viability of SUD programs were in a critical position and that providers needed financial support from DBH to sustain programming. Today in 2023, we're still operating on 2016 rate costs. Low reimbursement rates impact the quality of services, how quickly a client can be enrolled in services, recruiting and retaining workforce to offer those services, the number of providers operating in DC, et cetera. SUM recommends that this committee compel DBH to follow the practices of other healthcare services that abide by an established schedule and protocol for reviewing and updating rates. Currently, there is no established procedure for behavioral health services. Rate studies do not occur on a specific schedule and are conducted through no particular methodology, and there is no name trigger to start the process. Establishing a planned and formal schedule with additional identified emergency triggers will help prevent perpetually outdated rates and will support much more sustainable financial and operations planning for providers and for DBH and other relevant agencies. A second major barrier to offering services in DC is DBH's practices have added administrative burdens in an unpredictable and unsystematic way. For instance, rulemaking may be issued one date, but it's listed as being effective several weeks earlier. Another major example is the requirement that provider organizations bear the cost and time to become nationally accredited without removing the DBH certification process. In other states, this accreditation replaces other state or local certifications or reduces the requirements where areas are duplicative. Larger organizations such as some have had to hire additional staff solely to manage the many complex documentation pieces and will need to hire more persons, not to offer care, but to process paperwork as providers continue to move to managed care and obtain a new electronic health record, as DBH's current system is scheduled to sunset at the end of September. We continue to ask DBH to work with providers on how to make these documentation processes more efficient and helpful for clinical care. Though we appreciate the time that Dr. Badger and her staff take to meet with us, it is essential that our concerns are acted upon and that our feedback is solicited and systematically integrated into the decision-making process. Some appreciates the opportunity to offer these comments. Thank you.
Thank you. Okay, I don't see Nike. No, okay. All right. Thank you to this panel of witnesses. We're on a 5-minute clock. I want to ask a couple of follow-up questions as well. For Ms. Gentle, I'll start with you since you were the last one to go. What do you believe are the services or support that's critical to serving the clients that some serves but aren't reimbursable? If that made, I could rephrase that if that didn't make sense. Are there
some services that aren't reimbursable?
But you find to be critical? Yes.
Yeah, so a lot of one of the big ones is outreach, which has definitely become, as the opioid epidemic continues, and even like during times when there are spikes in synthetic marijuana, forgot the name of it. And yeah, so outreach isn't reimbursed, but it's something that's so essential to get people into programming, especially when you're working with unhoused residents the way that we do at some. And there's just a lot of indirect costs, like Ann spoke to in residential, that aren't covered, like when you look at like transportation and things like that are essential, especially when you're trying to provide essentially like a wraparound type services that aren't reimbursable, but that are essential for somebody that's trying to, recover from addiction.
Right. And I feel like in some of these instances, there is an opportunity for us to use local dollars to fill the gaps for something as critical as this, as you say, right? The outreach piece is just critical to sort of getting someone in the door. Thank you for your testimony. Mr. Charles, if you're still with us, I wanted to ask about the prevention centers. I think I asked about this in the earlier panel. It feels like very few people know about these centers, that they exist. What are your thoughts in terms of how they are promoted or the outreach that takes place to let people know that these exist?
Yes, because we work with, one of the issues that we're trying to face is we are trying to actively get into schools and work with a lot of our other school-based programs. LAUSC is very fortunate to have mental health providers that are working under the SUS program of DBH. But I think one thing that would benefit all of us as providers working under DBH, if there was just a larger, maybe a conference or something like that, where more providers can really understand what we do as prevention centers. Typically, I think when people come to us with concerns or with questions or trying to see how we can work with them, a lot of the times, they want us to provide that mental piece, mental health piece, and that's not really our focus. Trying to, we do a lot of outreach in the community. We do a lot of our work under DBH and under SAMHSA. But I think it's really just trying to working closer to some of the other providers so that way we can help promote our services. And then also really trying to make sure that just DC residents know not just the services under DBH, but all of the health services that are within the district. Where is that located? I think a lot of people don't really know how to access any of the health services in the district. Does that answer your question, Council Member?
Yes, that did. Thank you so much. Thank you for that. Ms. Reed-Witt, I think you spoke a little bit about the gaps that Sarah Barclay Hoffman also spoke about earlier in terms of the lack of intensive community-based treatment options for both Medicaid and non-Medicaid youth in the district. I don't think there are any of these centers in the district. Is that accurate?
Yes, it is for privately or through DBH.
Where's the closest?
There's the services are available at Innova, and I know at Adventist in Rockville, and then there's some smaller private groups like out in Bethesda that offer these kinds of services.
Right. Okay. I definitely think that is a challenge, right? Especially if you have young people who are, ideally they would receive these services after school. For those who have trouble getting all the way out to either Rockville or Bethesda or Fairfax, that impedes their ability to receive these services. And sometimes telehealth is not enough. So we'll ask about that in terms of, because that's one of the things that I am interested in the committee exploring further, is how do we strengthen our healthcare infrastructure and all that means, right? So that also means that having every service option available for folks right here in the district, that they don't have to travel, upwards of an hour to get that service. So we'll ask some further questions about that, but I'm over my time. Councilmember Parker, do you have any questions for this group of witnesses?
Yes, I will. I caught a part of it, and I do want to just acknowledge I'm jumping in between hearings and meetings. But first, Ann Chauvin, you discussed a potential solution to workforce issues and having DBH incentives for their workforce to be out in the community. Can you just detail or say a little bit more what this could look like in your sense of how DBH might dispatch their team members to support providers on the ground?
Well, actually, what I was thinking about was having some kind of incentive program for community-based organizations to be able to hire behavioral health staff. That one of the problems is that when we hire people, they don't want to work in the community.
I see. So it's okay, I misinterpreted that. So it's not so much DBH sending staff, it's more so about the incentives to be able to compete and attract talent.
Yes, because it's really hard to get people that are willing to do community work.
No, that makes a lot of sense. And then I believe you touched on this in terms of the rate reimbursements and the outdated cost analysis there. But can you just also speak more to the strains that is putting on services that providers are able to provide?
Yeah, I think one example is that because it's challenging to, like you just brought up, it's challenging to hire, it's challenging to compete with folks that are able to offer higher salaries. And if we don't have the rates that would allow us to offer competitive salaries, then there's simply not the staff, which so many people today have been testifying about. There's simply not the staff to provide the services that are needed. Like,
I get that.
Yeah.
Go for it.
So I was just going to say too, like, for instance, for our crisis programs, and some has a crisis program too, but so does Woodley House. And we are hearing directly from clients that they don't have case managers. And it's not that the providers don't want to provide the services, they simply can't hire the case managers to do the work. So, getting people to our underutilized crisis beds is especially challenging. And so they're, going to the hospitals where they're maybe not getting as good care. And the recidivism just keeps cycling.
No, I thank you for that. And then Betty Gentle, I caught your testimony. You talked about like some of the hardships with documentation processing, as well as how some of the rulemaking and communication is not always synced. How many FTEs or how many people are focused on this documentation process? Because you're saying instead of working on providing services, you all are having to dedicate individual work time to compliance measures.
So I do not know the specific number of FTEs, but I can get that and email it to you. But I'll say that we have definitely had to hire more people to specifically work on that, and anticipate a need to hire more because of upcoming changes that are happening. And like I said, SUM is a big organization. We have a lot of other programs and streams of income. So we're able to do that. But for smaller providers, especially like the small SUV programs, that's much more difficult to just hire staff to handle all that paperwork. And so what it does, it ends up taking time away from people actually offering care.
Absolutely. And if you could follow up with that, I would love to just get a sense of how many people are you having to hire to focus on that? And I would also just like to say I'm a big supporter of all of you all's work, but especially SUM and the work you're doing in Ward 5. One of the things that I'm going to focus on later in today's hearing is just the need for intense focus with the district's opioid crisis. And so something that really resonated with me that you spoke to was the ways in which that programming that you're conducting, the outreach that you're doing is not being reimbursed. And I'm hoping that we can change that in the future. So thank you for your time, and thank you all for your testimony today.
Thank you, Councilmember Parker. And again, thank you to all the witnesses on this panel. We are going to move you guys back to attendees and then go on to the next group. For, those who are watching, so we're going to do one more panel of 5, and then we're going to take a 5-minute break. And then we'll come back, and then we will finish it off. All right, so Queen Adedusi, Tamika Spellman, Reagan Dunham, LJ Sislin, and Dale Klatzker. Apologies, Dale, if I am butchering your last name, which I believe I am probably. Again, for those who are just joining us, you do need to affirmatively accept the invitation to be elevated as a panelist for you to join us. Okay. Councilmember Parker, did you want to do an opening statement? I kind of skipped over that, but
no, it's all good. For the sake of time, I'll save it for now, but just to say that I'm really excited for this hearing because this speaks to the crisis that we're facing in our schools, but on our streets. Of particular note of importance for me is our opioid crisis that I think in many ways is not receiving the attention that it deserves. And I'm really hopeful that under your leadership, Chair Henderson, that will change. So I'm looking forward to hearing from this panel and from hearing from district leaders later today.
Okay, thank you. All right, Queen, go right ahead.
Thank you so much. Good afternoon, Chairperson Henderson, Parker, and all other council members. My name is Queen Adasui. I'm a proud Ward 8 resident who has been living in DC for over a decade. I'm here testifying on behalf of the Drug Policy Alliance as their Senior National Policy Manager. I will be emailing over a more fleshed out written testimony, but for the sake of time, I'll keep my oral remarks concise. The Drug Policy Alliance appreciates the opportunity to submit oral and written testimony to the Committee on Health in regards to the Department of Behavioral Health. We are testifying today about the urgent need for the Council and DBH to authorize and fund 24-hour harm reduction centers to address the only worsening overdose crisis that we are experiencing here in the district. DBH is the city's leader in combating the overdose crisis, but the current strategies are not enough. We strongly urge the Council and DBH to follow the steps of jurisdictions like New York City and Rhode Island by supporting the establishment of harm reduction centers that includes comprehensive drug checking and safe consumption on site to prevent any more lives lost to overdose. Nearly 600 Washingtonians died from accidental overdose deaths in 2021 alone. That is over double the amount of community members that we have lost to homicide in the same time period. 86% of these lives lost were of Black Washingtonians, with Ward 5, 7, and 8 leading in fatal overdose deaths. The overdose death mortality rate amongst Black Washingtonians is the highest in the country. We have an adulterated drug supply and more of our neighbors are losing their lives to it. We are in a state of emergency that requires an urgent systemic change to how the district addresses drug use and addiction. In November 21, New York City became the first jurisdiction in the US to open sanctioned overdose prevention centers, which are harm reduction centers by another name. Since the opening of 2 OPCs in New York City, On Point NYC has successfully intervened in nearly 700 overdoses. On Point NYC has serviced nearly 2,000 participants and has had more than 40,000 OPC utilizations. That amounts to tens of thousands of times that drug use could have resulted in an overdose. On Point NYC has been able to intervene in more overdoses without a single casualty than the number of fatal overdoses that have occurred in DC last year and in 2021. The proposed 24/7 harm reduction centers that DPA and other community leaders are advocating for would host the same overdose prevention services as the groundbreaking New York centers, including safe consumption and drug checking services. Safe consumption and comprehensive drug checking services are vital and are the most significant distinctions between the harm reduction centers that 93% of DC voters support opening and the sobering and stabilization center that is set to be opening soon. OPCs bring drug use indoors, away from public parks, alleys, fast food, restaurant bathrooms, etc. It provides a community space where people do not have to fear judgment and can be attended to if there is a drug-related incident. As it is in New York and as we envision them here, these harm reduction centers will not only include full panel drug checking machines and space for safe consumption, but it will also include wraparound and dignifying services like showers, laundry, hot meals, connections to housing, a mailing address, mental health supports, a drop-in center, assistance with securing employment, legal services, ID documents, and more. We also envision these centers to have a strong street outreach and mobile services component to ensure that we are meeting people where they are and can offer support and resources in community beyond the areas near the physical buildings that we hope to have opened. This is harm reduction, evidence-based harm reduction. We applaud DC Council for previously moving to expand harm reduction supplies back in 2020 by decriminalizing drug use equipment previously criminalized under the district's paraphernalia laws and allowing for community-based organizations to distribute safe administration kits. DBH has been working to address the overdose crisis through implementing harm reduction tactics, including syringe exchange programs and providing residents with naloxone. However, these measures alone have not been enough to successfully curb the number of lives lost to overdose deaths. We urgently need to take advantage of the other evidence-based interventions in order to make a dent in our devastating overdose rates. With all due respect, and as this work is not easy, our efforts to embrace and fully invest in harm reduction must go beyond syringe exchange and Narcan. The district needs a much larger investment in public health infrastructure than exists currently, given capacity and underfunding of community groups. Harm reduction centers with authorization for safe consumption and drug checking services will save lives. New York City has been able to operate these facilities for over a year, and Rhode Island recently passed legislation authorizing these centers and have recently released regulations regarding the facilities. We desperately need our local officials to take the same bold but common sense strides on behalf of individual and community health. There's so much to gain in embracing our right to home rule and going further in our collective attempts to significantly reduce and eliminate overdose death in our city. The status quo will only result in more loss in our community. The time is now. Thank you for your time and your considerations. I'm happy to answer any questions related to the overdose crisis and the harm reduction centers that I spoke about. Thank you.
Thank you. Tamika Spellman.
Good afternoon, council members and the rest of the panel. My name is Tamika Spellman. I am the Policy and Community Engagement Manager for HIPS. I have nothing really scathing to say about the Department of Behavioral Health, but what I will say, we'll be talking about their making procurement contracts available to local community service organizations, the norm for engagement with extremely marginalized community members. Services rendered are always better when the folks running said services and staff are operated by people with experience from years of practice, not people who have never done the type of work needing to be done, especially if it is led by and designed by people with lived experience doing the work. We would not send a highly skilled baker from an esteemed bakery into a steel mill to work in a coke oven. So what makes us think that people who have not been homeless will respond to people talking to them about their homelessness when they have never been in those shoes, not having experience and understanding the nuances and circumstances their lives have? The same applies when it is drug users or sex workers. Being a person of lived experience in all of the above, I have the cultural competence and empathy for those living those circumstances and understand the nuances of their experience enough to be able to offer services, programming, connection to resources, and assistance without judgment and do no harm when doing so. If we as a city are to ever start meeting the NEAR Act and the Live Long DC recommendations, we are to center the community in the responses to dealing with the human experiences people live with in culturally competent ways, and it has to be led by those with lived experience. Those services and programs should be handled by those who are already doing the work and be funded by the city through procurement contracts awarded through the Department of Behavioral Health. One that comes to mind is what HIPS will be presenting during budget advocacy hearings. The 24-hour harm reduction centers DC so desperately needs to save lives and mitigate harm to our marginalized community members. We would like this to be offered up as a procurement contract to DC's community service organizations that have years of experience meeting the people of DC where they are at and offering them the services the city often cannot. The same would apply to other community suggested initiatives like mobile crisis interventionist teams to address issues police should not be dispatched to, like issues with sex workers or people experiencing mental health crises. We ask this because government-led initiatives typically have limitations on hiring marginalized community members and running programs that interact with severely marginalized communities. There is no amount of training on how to be culturally competent when engaging people who are marginalized that can be offered to folks who want to interact with the services being offered. It has been done before and did not work well. Remember the police-assisted diversion program that HIPS said would fail because it did not hire or utilize lived experience people, and many other community organizations balked at. A few years ago, that DBH and MPD partnered on, and it went south almost immediately. And how it strangely morphed into a referral-only program that still was not able to meet the people where they're at. The program MPD failed to execute that they willingly partnered with, whereas DBH also often reached out to community-led providers for tips on cultural competence when engaging marginalized people. Let's not go that route again and just make these cultural competence for behavioral health and safety to make available to community organizations already doing the work. We will gladly meet the demands of the community as we have always been evolving to meet people where they're at, where government entities tend to make you come to them on their terms. As We as community service orgs offer low barrier access, have decades of experience in harm reduction, have the cultural competence needed and lived experienced staff to carry out the work to keep critical programs intact and operating as designed. To summarize, DBH has run some programs successfully, and we commend them on their accomplishments, even the tries that did not go so well. It shows that they cared enough to attempt to serve the community's needs. But when it comes to rendering services to extremely marginalized community members, we are attempting to move towards healthy, community-led and based solutions that aren't policing or carceral responses in nature. We urge them to offer procurement contracts to DC community service orgs to handle these operations, services, and programming so they have longevity and continued success achieving the goals of addressing community concerns with community-led solutions. Thank you for your time, and I will be available for questions.
Thank you. Reagan Dunham.
One second, sorry. Okay. Thank you for the opportunity to address the DC City Council today. My name is Reagan Dunham, and I'm the Health Equity Manager at the Washington AIDS Partnership and a community organizer with the Decrim Poverty DC Coalition. I am here today to urge the City Council to address the overdose epidemic and promote racial equity by establishing 24/7 harm reduction centers with safe pre-obtained safe consumption sites across the district and decriminalize substance use. The overdose epidemic has increasingly devastated communities in DC over the past 5 years and has disproportionately impacted communities of color. According to the DC Office of the Medical Examiner, DC has lost 1,932 residents to opioid overdoses since January 2017. Black Washingtonians accounted for 84% of these deaths, highlighting significant racial disparities in the health outcomes of people who use drugs in DC. These disparities are due in part to the racial inequities in the criminal legal system. 92.6% of all Washingtonians convicted of drug possession in 2019 were Black. DC can address health inequities, support racial justice movements, and promote economic mobility among LGBTQ+ residents of color by establishing harm reduction centers and safe consumption sites around the city. Such sites have already proven successful in New York City, where centers operated by On Point NYC have prevented over 600 overdoses in their first year of operation. The criminalization of healthcare services obstructs access to care. Evidence-based harm reduction policies, on the other hand, have been proven to encourage and improve community health. For example, 2022 marked the 15th anniversary of DC's decriminalization of syringe exchange programs. Since decriminalization, new HIV transmissions are 85% lower than in 2007, and they continue to decline, particularly among injection drug users. It is clear that the DC government's investment in evidence-based harm reduction strategies works. In commemoration of this anniversary, we urge DC City Council members to support the District of Columbia Drug Policy Reform Act. The decriminalization of substance use, much like that of HIV, will allow clinicians and public health experts to appropriately address addiction as the public health crisis that it is, providing evidence-based treatment to communities that need it the most. Harm reduction centers and drug decriminalization will enable the district to transition addiction and substance use from criminal issues to public health ones. This change is more needed than ever as DC continues to lose hundreds of residents per year to overdoses. It is imperative that the fiscal year 2024 budget includes funding for a harm reduction center that offers safe consumption for our residents. We are confident that we, DC's local network of harm reduction service providers, advocates, and people with lived experience, can get this work done. All we are asking is that we have the funding to allow us the capacity to do so. We hope to turn the tide of overdoses in the district, and we are hopeful that we can count on your support to meet this goal. Thank you.
Thank you. LJ Sislin.
Hi, thank you.
Good afternoon, Chairperson Henderson and members of the committee. My name is LJ Sislin, and I'm a campaign organizer with Decrim Poverty DC. And I'm also a harm reduction outreach volunteer with HIPS, the local harm reduction organization. I have submitted a more detailed written testimony, but here I go with the oral one. The Department of Behavioral Health is the city's leader in combating the overdose crisis, but the current strategies are not enough. I'm urging you to authorize, fund, and legally support the creation of 24/7 harm reduction centers that includes comprehensive drug checking and safe consumption on site to prevent any more lives lost to overdose. These are all tested and proven strategies that positively impact the lives of people who use substances, especially criminalized and stigmatized substances, and successfully curbs the impact of drug-related diseases, ailments, and death, as you've heard from my colleagues earlier. I'm here today on behalf of my labor, the campaign, and to carry the spirit of my friends Nick and Duffy, who were rejected from abstinence-based communities and denied comprehensive, all-encompassing, compassionate public health resources due to their reoccurring substance use disorders, their mental health status, and their chronic pain. They both died from fentanyl contamination. Nick died while I was in a DBH partner naloxone training in 2020, when I started dedicating my time to harm reduction strategies and outreach rather than 12-step fellowships. I also do this for the countless community members who have died from accidental overdose, and I do stress accidental. They did not kill themselves, they did not deserve this, nor did the drugs that they wanted to use to medicate their various pains kill them. It was using alone. It was because the drug supply is contaminated with fentanyl and other things, adulterants that people don't know that they are ingesting or the amount that they are ingesting. It was from hiding their pain and hiding their drug use because of shame and stigma that is just compounded over years of the war on drugs politics. I also do this for myself, to be completely transparent. I was intravenously using heroin in 2015 when the fentanyl contamination was worsening. I narrowly escaped the road to drug-related death due to societally bestowed privileges, opportunities to get professional help, community care, and sheer luck. Let's be real, there's a lot of luck in there. After 6 years in an abstinence-based peer-led community fellowship, a master's degree in medical anthropology, and an opportunity to live a beautiful life, I can't ignore the facts. Abstinence-only programming as the standard, police rather than healthcare workers at the front line, and the criminalization of people who use drugs will continue to compound the misinformation, stigma, pain, and deaths of people using drugs, no matter what community groups try to do for each other. We desperately need more evidence-based support from the Department of Behavioral Health, in addition to what you all have been implementing so far. I'm urging DBH to authorize and support the well-researched evidence that harm reduction centers, also known as safe consumption sites, it's the answer. It's the answer to what our families, friends, and community members are facing. The center will be one component of a harm reduction public health infrastructure as proposed by our campaign, which is a coalition of nearly 60 organizations, from housing and food justice to faith leaders and mutual aid groups. It won't be one center or one program, but a comprehensive strategy that will address the health, safety, and well-being of Washingtonians who use drugs. You know this, there's an overdose crisis. You heard it before, nearly 600 Washingtonians died from accidental overdose in 2021 alone. We have a highest record every single year, and I'm tired of that. Again, 86% of those deaths were Black Washingtonians. The overdose mortality rate among Black Washingtonians is the highest in the country, which is nearly 10 times higher than the white overdose mortality rate in DC. Overdose crisis and drug politics are not only public health concerns, they are racial justice concerns. So Decrim Poverty DC is advocating for 2 harm reduction centers on each side of the river. You've already heard about that earlier. So I will continue with some other information that I understand. I'm familiar with the DC Sobering and Stabilization Center. I've read the RFP, I've heard about it. The proposed center is intended to divert publicly intoxicated individuals from emergency rooms or the police to a safe space tailored to their needs. That's excellent. However, we have proposals for 24/7 harm reduction centers, which are even more comprehensive than the DC Sobering and Stabilization Center, and backed by evidence from New York's On Point and centers in other countries. There are many shared services like low to no barrier access, peer support, crisis stabilization, trauma-informed care, case management, and a referral hub. But here are the key foundational differences between the centers. Sobriety is not a requirement for participation at the Harm Reduction Center, nor will it be the gold standard or the outcome of treatment. Positive change, a healthier self-determined living, that's the goal, however that looks. There will be a room for supervised safe consumption of pre-obtained drugs and drug checking services. These are the elements that will directly address the main driver of the overdose crisis, which is not addiction and substance use disorder. It's actually the contaminated drug supply and the lack of comprehensive harm reduction public health infrastructure, including the decriminalization of all substances. Evidence shows that this works. It shows that it gets people plugged into services, and harm reduction is addressing everything, including housing, including food, including getting hormonal therapies and everything else that we have at that center. So please use funds more efficiently and reimagine public safety and health. We're urging you to create and authorize these harm reduction centers. Thank you so much for this opportunity. I'm happy to answer any questions regarding the campaign, overdose crisis, or the centers.
Thank you, LJ. Dale Klatzker.
Oh, you did a good job that time. Thank you. Good afternoon, Chairperson Henderson and members of the Committee on Health. I'm very impressed by all the presentations you've had so far, so just felt I needed to say that. I'm Dr. Dale Klatzker. I'm the president and CEO of Gaudenzia. I'm here on behalf, testifying on behalf of my partner organization, Regional Addiction Prevention, or better known as RAP, which I'd like to also underscore based on LJ's testimony. We are no longer an abstinence-based organization. So there you go. Thank you for holding today's oversight hearing. Regarding the performance of DBH, I would like to begin my testimony by offering a very sincere message of gratitude to the district's Department of Behavioral Health, to its wonderful, excellent team of professionals led by Dr. Bazran. Past 3 years, we would all, you would have to be living under a rock not to realize that it's been challenging for everybody. This has been especially true for safety net organizations like RAP, which has served for more than 50 years as an indispensable provider of substance use disorder treatment services to residents of the district. Indeed, RAP is the only district entity that currently provides a full continuum of SUD treatment. So we provide crisis stabilization and 24-hour observation. We provide walk-in assessment and referral. We provide withdrawal management and detoxification. We provide high-intensity, clinically managed residential care. We provide low-intensity, clinically managed residential treatment. We provide intensive outpatient and standard outpatient treatment. And once more, we are not abstinence-based. Simply put, the pandemic represented an existential threat to all safety net providers, including RAP. As a residential provider, the combination of mandated social distancing protocols, the reluctance of individuals to seek treatment as a result of legitimate fears associated with the virus, meant that RAP was confronted with dual challenges in meeting the needs of the community and simultaneously remaining financially viable. On top of this, the COVID-19 pandemic imposed additional costs on the organization with supplementary staffing, personal protective equipment, and more. In short, fewer patients, higher expenses conspired to almost shut us down. Were it not for the financial support from the DBH over the past year and a half, RAP would have closed. It's not an exaggeration, it's a fact. On behalf of the residents we serve and our staff, we want to thank the department for all of its assistance. Particularly grateful again to Dr. Bazran and to its Chief Operating Officer, Michael Neff, for their diligence and personal involvement in this effort. Over the past 2 years, RAP has received significant direct support from DBH through U.S. Department of Health and Human Service Fund awards and through PPL federal funding. These funds have allowed us to retain our staff, to keep our patients safe, and to serve our community. Today, we're open, and due to a number of exciting personnel and programmatic developments, we're prepared to meet the growing challenges that the district faces. To be sure, there are challenges awaiting all of us. While COVID-19 produced incredible barriers to treating our patients, the pandemic certainly did not end the SUD epidemic. Since the beginning of the epidemic, rates of SUD relapse and fatal overdose have surged. You've heard a lot of stats. I'll throw the same ones out and some more. Between 2019 and 2021, according to the Office of the Medical Examiner, the district experienced a 52% increase in its monthly overdose opioid deaths. For the first 3 months of 22, total opioid deaths were 73% higher than the same period in 2019. Importantly, the impact of these opioid fatal overdoses continues to disproportionately devastate communities of color and underserved district communities. From 2017 to March 31, 2022, 84% of those who died were Black. That's 1,439 people. And more deaths occurred in wards 5, 7, and 8, 786 of those. RAP serves the population most at risk from the opioid fatal overdose. During fiscal year 22, we served over 1,100 people. Our clients are predominantly Black, 89%, males, 70%, and 57% over the age of 45. Additionally, 66% of the clients we serve experience polysubstance use. They use two or more illicit drugs. We have 1 in every 2 clients we serve is homeless, and 1 in 10 clients is HIV positive. So this doesn't capture also the people who have a co-occurring mental health disorder. Most of our admissions come from Ward 8, 31%, Ward 5, 21%, Ward 7, 18%, and Ward 4. I see I'm going way over. I will speed through the end here. If past is prologue, we can expect that the behavioral health impacts of COVID-19 are going to last for a long time, including enhanced need for SUD services. The district should credit the Department of Behavioral Health for the steps that it took during the pandemic, but notwithstanding those efforts, several SUD safety net providers didn't make it. They closed. Going forward, we look forward to working with the department and the Department of Healthcare Finance and this committee to increase the resources needed to meaningfully address the epidemic, including opioids. Cadencia operates in surrounding states. We operate in Pennsylvania, Maryland, Delaware.
Dr. Klotz.
I will, just 2 more sentences. We hope that the district will recognize what those other states are doing, which is given the difficulty of workforce, complexity of our clients, we wish to evaluate the rates that affect these challenges. We are in a partnership and we appreciate the partnership. Thank you.
Thank you. Okay. Thank you to all of the witnesses who have testified. I first want to say, LJ, I appreciate your testimony and I appreciate your vulnerability in sharing, and I'm sorry for your loss. I want to ask for you, Tamika, Queen, anyone else who wants to chime in, sort of 2 things. So first, when I met with Dr. Bazaran, one of the things that they talked about was the fentanyl testing strips and the deployment of those. And I'm curious to hear your feedback in terms of how you think that's going. Is it accessible? Do we need to make more available? What happens there? And then well, I'll start there and then I'll ask my second question.
Oh, LJ, go ahead.
I was just gonna say, so many of us dual our time as also being like outreach volunteers with the outreach department at HIPS. And one of the problems with the fentanyl testing strips is the fact that they aren't that accurate and it can't tell you how much fentanyl is in it. So regardless of whether there's enough on the streets, enough in certain organizations and at specific community hubs, it's just not as efficient or comprehensive as these machines that we're talking about, these like drug checking machines, which that are thousands of dollars, they're massive units, and they can test for all sorts of things. So we're talking about the worst of the worst right now when we're talking about death and fentanyl. But with these drug checking machines, we'd actually be able to talk about all the different things that are affecting our physiology, our biologies. And I'm saying our as someone that's been a person that's had chaotic substance use, but the people that of course are using drugs on all degree, not just saving lives from fentanyl. And also realistically, the supply is so tainted at this point that some people need fentanyl to get high. And I'm not here to pass any judgment or say whether that's good or bad. It's just facts on what's happening, is that sometimes people test to make sure it's in there because they will not be well without that. So without other community hub support systems, people sometimes need the fentanyl, which is just a matter of fact of like how tainted and how long it's been that the supply has been like this. And I'll pass that to Reagan.
Yeah, I echo everything that LJ said. I also want to add that harm reduction supplies themselves, like fentanyl testing strips and like Narcan, are not all encompassing of what harm reduction is. We still need lots more services like a robust drug checking system that can do more than just what the fentanyl testing strips do. Up in New York, they've got really good machines that can be really accurate in terms of testing for fentanyl. It's also just kind of harm reduction is about these supplies and these systems, but also more about embracing a mindset that adopts what LJ and Dr. Klatsker were talking about, not enforcing sobriety, not punishing people as they're trying to cope with substance use.
Okay, I want to ask about harm reduction centers. So I think you both, or not both, but many of you point to New York and Rhode Island. My question is decriminalization required before the coordination and creation of these centers so that they can work?
No, this is like the beginning step to decrim, and hopefully decrim will come in right behind it because it is a critical element in solving some of the racial justice issues that we are having here in the District of Columbia. The centers will be providing quite a bit of services. They'll be open 24 hours, 7 days a week. When it was first created, it was an ask that I was designing specifically for HIPS for the city to fund us to continue to do the work that we are already doing. I would like it to be made a procurement contract for us to apply for, so that we can continue doing the type of work that we're doing as we are now, and just increasing the amount of work and being in more places and more times, and having secondary site and more mobile vans and the drug checking equipment are critical elements to decrim.
And if I can add, and if I can just echo Sam Rivera, the executive director of On Point in New York City, he speaks about how the areas where they have the centers are effectively decrim because they've managed to build a relationship with NYPD because of their circumstances, because they don't already have decrim. So it operates as it's decriminalized in that area. So police bring people to the centers, or like instead of arresting people, they do that, and that's effectively decrim. But the issue with that gap, without having policy to back the want of making sure people can actually go to the center instead of going to jail, is it's up to the discretion of police. It's up to where you are in the city, and we want to make sure this is equitable and people equitably have access to the centers instead of jail if they are in a situation where they're caught in possession. So for us, it's a combined effort, and the infrastructure that the harm reduction centers would bring, along with drug checking, along with the additional funds and money for community groups, that would build up the kind of public health infrastructure to address drug-related issues that cancels out the need, or there was never really a need to lock up people just for using drugs.
Okay, thank you. I'm over my time. Councilmember Parker?
Yes, I want to pick up on that thread. Tamika, I want to first, before I get to the 24-hour harm reduction site, and let me take a step back and just thank you all for your testimony and what I would call a radical compassion for neighbors most vulnerable and in need. I am an individual that recently lost a friend to an overdose, and we're talking about college-educated individuals, and this is not something just impacting those people over there as some neighbors may see it, or just those that are on the streets. These are the crisis, the opioid crisis is affecting everybody in many different ways, much of it going unaddressed. So thank you all. Tamika, I wanted to circle on your call that the procurement that we do potentially with these 24-hour reduction sites, but also through DBH generally, would center the voices and the individuals that are doing this work on the ground. And can you just, practically speaking, what might that look like? Yes, theoretically, I hear you loud and clear, but what needs to shift in order for us to make that a reality?
Put people like me in those places to work so that the work can be done in a culturally competent way. I have no qualms on ever walking any street in the District of Columbia and being able to walk up to people and have a conversation with them. And that is because I'm a person of the streets. I've done drugs for quite a few decades and been a sex worker for a long time. I have the knowledge of how to get out there and meet these people where they're at. And HIPS does that so well. We have a great following. We are in virtually every neighborhood in the district, distributing safer using supplies, safer sex supplies. And if we could have 2 centers and then the mobile equipment that we need, we can bring those numbers down to virtually nothing.
I so appreciate that. And thank you for your transparency and honesty. I guess what I was getting at is perhaps there needs to be like a community panel, a board, or a vetting process where we can ensure that these contracts are going to the very individuals that you're speaking to. But I think that is a good push. I want to come back to these 24-hour harm reduction sites. I hear you loud and clear. I know that they do not come without controversy. And so for the sake of those watching, Queen, I'll come to you. And for those that may say, to have these sites or centers, you're incentivizing people to use. What might be a response to that based on the research and the facts?
Well, the fact is that people use drugs. People use drugs across race. People use drugs across socioeconomic status. People are using drugs, and accepting that as a reality allows us to actually be able to address issues related to drug use and any risk related to drug use and help reduce that, instead of just kind of making it seem like we can actually achieve a completely drug-free society. We have not been able to achieve a drug-free society. Prohibition has been the law on the books for decades, and that's not happened. I mean, people are unfortunately dying from overdose in our jails. People access drugs in maximum security prisons. So if we're not able to get drugs out of maximum security prisons, how are we able to get drugs out of our actual society? So with that acceptance, we can actually treat people and reduce the risk associated with drug use. And like I mentioned earlier, harm reduction centers actually are helpful for communities and, regardless if you use drugs, because it brings drug use indoors. We don't have to deal with drug-related litter in parks. And people can be met with dignity and love and in a space where they're not judged and stigmatized, and hopefully not criminalized either. And we haven't talked about how, law enforcement often makes the work of outreach workers more difficult. People are afraid of police, and that's just the reality. So the presence of police oftentimes complicates the work that outreach workers are doing. So we can just remove the criminalization aspect altogether and actually invest in services that help, keep people well. We can actually keep people safe and keep people alive. I think that's the goal. If we all collectively agree that the goal is to keep people alive, then that's the way to go.
In my last 10 seconds, Tamika, I want to come back to you, and then Dr. Klatzer, I'm going to, Chair Henderson, if you will bear with me, 30 seconds, I would love to get you into. Go for it, Tamika.
I just wanted to make sure that people are keeping in mind that everybody that uses substances are not addicted. They are not experiencing chaotic use. People do use recreationally, and just because they're using recreationally does not mean that they necessarily are looking to die from their use. And we need to be meeting those people where they're at as well.
Thank you for.
We're always, we get stuck in the chaotic use and forget about the people that use recreation. That's all I'm saying.
I hate to cut you off, but I'm already over time. Dr. Klatzer, I'm going to give you the last word, 30 seconds or less.
Okay. I've been a treatment provider for 40 years in multiple states, and I think it's time that we redefine what we're doing. Because to me, in order to be a treatment provider, you have to treat people who are alive. And to me, the issue is keeping people alive. Got to be alive, and then when you're ready, then there's treatment. So
thank you for that, and thank you for the extra time, Chair Henderson.
Thank you. And thank you to all of the public witnesses. Again, thank you so much for your testimony today. And please make sure we have your written testimony if we don't already do so. We have been going since 2:00. So I'm going to take a 5-minute break so that my staff can stretch their legs and take a break, and I can do so as well. When we come back, the first panel up will be Peter Wood, Sharif Shafi, Amanda Morgan, Bria Matthews, and Christy Respris. So thank you guys, and we'll be back in 5 minutes. Thank you. Okay, and we are back. All right. Peter Wood, Commissioner Wood, you are first up to go.
Hi, good evening. I hope you're doing well. So I just want to start off, the last panel was excellent. I'm not surprised. I'm familiar with decrim poverty DC, so it was really good. I'm going to basically reiterate a lot of the points they made, but from a commissioner's perspective. So my name is Peter Wood. I reside in Adams Morgan in Ward 1, where I serve as advisory neighborhood commissioner. And today I'd like to testify regarding DC's approach to the ongoing opioid crisis. More specifically, I want to address areas where the Department of Behavioral Health is doing great work and how more compassionate legislation can support DBH even further. Let's briefly review some statistics. According to the Center for Drug and Disease Control, over 500 Washingtonians died of drug overdose in 2020, also in 2021, and likely in 2022. According to the Office of the Chief Medical Examiner in DC, 96% of overdoses in 2022 involved fentanyl. That's up over 20 points since 2017. And over that same period, about 84% of those who died because of opioid overdoses in DC were Black residents. These numbers do not and should not feel good to hear. Last year, I testified before the same committee addressing the same issues. That's not to say DC in general and the Department of Behavioral Health in specific aren't making strides to reduce these fatalities. Expanded access to naloxone and fentanyl testing strips are two examples of important changes in DC's response to the opioid crisis. I've even been told by a DC fire chief that their access to naloxone for potential overdoses is so good that they wish something similar for insulin was structured so that they could have comparable access. Now let's switch to policy for a second. I do not claim to have advanced expertise in drug policy or behavioral health, but I can attest that a significant portion of my academic endeavors during about a decade in research university settings dealt with the insufficiency of iron-fist policies toward narcotics consumption and distribution. Portugal's 2001 decriminalization of many drugs is a commonly cited example of how treating drug abuse as a public health issue and not a criminal justice matter can reduce stigma, reduce overdoses, and save public expenditures in the long run. In the 20 plus years since Portugal's experiment, other countries and municipalities like New York City that we've heard of have revealed comparable findings. We've made a lot of progress in terms of reducing stigma towards substance abuse in DC. But to borrow words used before me by Shane Sullivan with HIPS and Decrim Poverty DC, criminalization is stigma. Compassion must be at the core of how DC government functions. People don't typically use drugs laced with fentanyl because of malevolence or ill will. They do so in many cases out of desperation to reduce suffering. Too much of the United States, and frankly, even Washington, DC, seems to believe that people who use drugs deserve to either go to prison or die. Rather than succumb to this toxic rhetoric, I want us to instead advance a moral, medically proven alternative to help prevent more overdoses. DC's Department of Behavioral Health needs to be equipped through decriminalization, training programs, funding community organizations, maintaining harm reduction centers, improving testing mechanisms, and further undoing the decades of harm we have seen come to a tragic climax in the current opioid epidemic. We're getting there, but the biggest changes needed are still ahead. All we need to get there is political courage. Thank you.
Thank you. Sharif Sharafi.
How you doing, councilperson? Assalamu alaikum. I want to start out with the occupational work hazards. I work for the Department of Behavioral Health, and I work in one of the most beautiful departments in the district, community response. We go out, everything that everybody's been talking about today, we are the cleanup people. We clean up. When you have a problem, you call us, we come and make sure that your client is safe. But we also go into these hazardous environments, infestation of needles, infestation of roaches, bugs, you name it. We go into these places. And I have a lot of brothers and sisters who are members of Local 2095 and Local 1199. And they are suffering. They are suffering in silence in the Department of Behavioral Health. Community response have served the District of Columbia in the most trying times in the history of the District of Columbia, I believe, outside of the Civil War the sniper shooting at Van Ness, the rooftop standoff with the individual who was shooting at the police, the January 6th insurrection. We were called to those environments as to caregive to our consumers in the community. But we are not compensated with the hazardous pay. And I'm gonna give you some of the hazardous conditions. My supervisor, Jim Van Neck, he went into the home of a consumer. Consumer decided to attack him because Jim saw the gun on the table. And he punched my supervisor several times, about 12, 13 times. And all this can be verified through these people because they asked me to use their name. One of my coworkers who were a contractor, her name is Kathy Ruffin. She was shot twice in a government vehicle. And she was told not to say anything about this because we don't do outreach at night. But that's not true. Another one of my coworkers, she was robbed at gunpoint. Her name is Rosetta Price. She also is a peer. And she's a very beautiful lady, but she suffers with some concerns. So I'm speaking on for these people. Also, I have another coworker who's a nurse, RN. She used to work at St. Elizabeth Hospital. She was beaten into a pulp. She was on national TV across this country, showing her face exploded, beaten by a patient. And I had another individual that was a coworker who she left her job. A client was denied services at CPAC. And this client was a loved one of this individual. This individual shot her 15 times because he was denied services at CPAC. Yes, he's a violent individual. We should have places for those type of individuals. So with that being said, those are some of the atrocities that have taken place. But we also have some atrocities that also at St. Elizabeth Hospital. Clients still dying. I talked about this 2012, 2013. COVID-19 came and is still here. In my workplace, every person in my workplace had COVID. And there's no tracking of the staff who had COVID or the vehicles that they're driving, and I wound up catching COVID. Then I was also denied workman's compensation because they said I contracted COVID from someplace else. No one knows where we contract COVID. So that's the second thing. Also, DBH has racism in his workplace. Just like the police department, we have major racism in DBH. That need to be addressed, right? And we also have trauma. I'm one of the person who suffer from trauma. I done found 2 dead persons as working for community response. This last person was 2 weeks ago. He was beaten very badly, bleeding from the mouth, laceration across the face and hands. And this individual was laying in front of Union Station. He wasn't hypothermia dead. He was dead from someone beating him to death. And I'm the individual who has located him. And to this day, no one from DBH have reached out to me or my coworkers to ask us if we okay. And I'll tell you, I am not okay. It's unfortunate that we can care and love the consumers of the District of Columbia. And when everybody else goes home and they shut down because of COVID, we, community response, we still gotta go. We do not get hazardous pay. We are not treated as such. We work side by side with the police. I wanna thank Dr. Tyrese McAllister, who trains the police. She also brings us on board to help train the police how to work with mental health clients. It's unfortunate that that DBH cannot see that we are injured and that we need financial support. We need more teams. And it hurts. It's very painful to see individual staff members who are scared to speak up for themselves, knowing that they are injured. This lady, Kathy, was shot twice, and she have not had no kind of representation from the District of Columbia, from the lawyers in this city who will not represent these people. You can look on your panel. I got one question, one more. The union that represents us should be here today because you are a new set of government that just came in. They should be here today. And I should not be talking. They should be talking for me. They haven't talked to this committee ever. The last time they talked, I forced them to come. It's unfortunate that this situation happened, and I'm very painful to have to do this. I'm asking for whistleblower protection, and I'm asking for protection for my coworkers and myself. And I thank you.
Thank you for your testimony, and please stay. We'll have some follow-up questions for you. Amanda Morgan.
Good evening, Chairperson Henderson and members of the committee. My name is Amanda Morgan, Trauma Response Division Manager at CASA for Children of DC. I am honored to have the opportunity to be here today to share more about the impact CASA programming has on youth mental health and the expansion of the clinical programs. For 20 years, CASA DC has provided compassionate, trauma-informed care for DC's court-involved youth. Nearly all of our youth have experienced complex trauma, from abuse and neglect to community violence. These experiences impact our youth's present and future well-being. They face lower academic achievement, high-risk behaviors, and increased risk of future unemployment, homelessness, and incarceration. An estimated 80% of foster youth have mental health challenges. CASA DC's core model of volunteer mentorship helps to mitigate the impact of trauma with the presence of positive adult figures and targeted well-being support. Our CASAs have a tremendous impact on our youth's well-being. In fiscal year 22, enhancing well-being was the #1 area of support provided to our youth. 92% of CASA volunteers supported youth well-being by providing enriching activities, education, and advocacy to promote youth's physical, emotional, and behavioral health. With the support of CASA volunteers in fiscal year 22, 186 youth were educated and empowered to practice healthy coping strategies, and 209 youth were supported in engaging and demonstrating positive communication skills. Even with this impactful work, it became apparent that for many youth, the support of a positive adult figure was not enough. More mental health support was needed to help our youth heal from these various traumas. You've heard from other youth serving organizations today, like the Children's Law Center, that more providers are needed. The youth and the families are facing barriers and gaps to these services. CASA DC's new clinical division seeks to reconcile this. Last year, CASA DC started offering behavioral and mental health services to youth and families. Since its launch, our individual therapy program has provided trauma treatment to 45 youth and families. Our programming is designed to reduce barriers created by historic racism and lack of access to care. This is particularly important to us as more than 90% of our youth that we serve are Black. We connect with youth and families in person and virtually during the day and evenings, and in our office and in the community. We also provide all of our services at no cost to families with the support of federal, local, and foundation funding. CASA DC strives to provide treatment and support without barriers. CASA's therapy services are offered to youth ages 2 to 21 who are involved with the court system, impacted by childhood traumas, including substance abuse and gun violence, and youth identifying as LGBTQ+. We offer dialectical behavioral therapy techniques, trauma-focused cognitive behavioral therapy, motivational interviewing, and play therapy. We are also serving youth in the community Monday through Friday every day with evidence-based peer circle support groups. Offered at Barge drop-in centers, DYRS achievement centers, and virtually, these circles based on the evidence-based one circle model incorporate motivational interviewing, cultural responsivity, strengths-based approaches, and trauma-informed practices. The circles engage youth in activities, dialogue, and self-expression while learning healthy and appropriate social interactions, self-care, cultural literacy, and relationships in a trusting and supportive environment. In just 3 months, CASA has served 75 youth through the groups held at Barge centers. We're also building partnerships to offer unity circles to LGBTQ+ youth and their allies with a focus on diversity, equity, and inclusion. We're very proud to offer no cost barrier breaking support that we are able to offer through our clinical program. We welcome collaboration and partnership with the Department of Behavioral Health and all community partners. Thank you, DBH, Chairperson Henderson, and members of the committee for the important work that you do and your continued support.
Thank you. Bria Mathis.
Hello, council members. My name is Bria Mathis. I am the Senior Program Manager for the CHAMPS program. I not only am coming to you today as an employee of Catholic Charities, but also as a DC Ward 7 resident. Two things that I really wanted to discuss today was the lack of programs in the city that provide immediate support for parents with children that have been either formally diagnosed with oppositional defiance disorder or children who engage in behaviors that mirror one who would be diagnosed with oppositional defiance disorder. I get a lot of phone calls from parents who state the specific statement, "I'm at my wit's end. I need someone to come and take this child out of my home." I know a lot of the time that the parent doesn't really want their child removed. They will call and say, how can I give up my parental rights? And speaking to them and just giving them an opportunity to vent, I learned that they don't actually want to give up their rights. They just need some immediate support and maybe just space for them and the child to go temporarily. So I just wanted to, encourage the district to consider having more respite programs. I know we have Sasha Bruce and things of that sort, but they only can hold a limited number of children at one time. So just maybe offering supports also for those parents when they're in that state, like I said, when they are at that moment willing to give up their parental rights. We also have the ACE diversion program that's through the police department. We have the STEP program, whose goals are really to support families that are in these moments. However, they're through the police department. And I also speak to a lot of parents who express, I don't want to go to the police due to being a Black or brown, family. And they are really just looking for mental or behavioral support in that moment. But like I said, we don't have any immediate supports, like I said, such as a crisis bed or respite care for our children right now. The other thing that I wanted to discuss was that, of course, everyone is experiencing a shortage in staffing in our mental health field. One solution that I have for this is to maybe have some type of team or group come together and meet about how to incentivize people to get into the behavioral health field and start to work with some of these higher risk populations. I meet with the police department about once a month, some of their crisis intervention officers, and participate in their training. And some of the feedback that I get from them is that there's recently been a spike in juvenile criminal activity, and they think that it's not really criminal activity, it's more mental or behavioral health activity. And they're saying, what can we do when we arrive and there's been no crime committed? So like I said, I think that as a city, we could improve in incentivizing getting people to work in this field and work with these higher risk populations. Also, we could increase the provider pay rate that we are giving to providers to work with these populations. As Mr. Sharif was saying, like we specifically working in the crisis field, we do enter a lot of high risk and unsafe environments. And if we had the proper funding to support hiring qualified candidates to complete these tasks, I think that we could potentially see a decrease in the number of children having to unnecessarily interact with MPD. Thank you.
Thank you. Christy Respris. Let's see, Christy. All right, but we have someone who was missed their earlier panel. Ike Noichi.
Thank you very much.
Yep.
My name is Dr. Ike Noichi. I'm currently the medical director of MBI Health Services, one of the community support agencies. I first want to thank DBH for working with DHCF to make RAP around services Medicaid reimbursable. This will help children and families with complex issues to navigate the system of care in DC and receive the needed services. There's been a serious workforce shortage that's affected the system and many agencies. The problem is that the rates of pay haven't changed since 2016, yet the salaries for clinicians has increased, making recruitment extremely difficult and cost prohibitive. So I've been a psychiatrist for the last 18 years. I've had the privilege of working in a number of areas of the mental health system, inpatient, outpatient, emergency services, and I've been on the front lines. I worked in Maryland, Virginia, and the district. I served as the vice president of the American Association of Emergency Psychiatry, and I was medical director of CPEP, the Comprehensive Psychiatric Emergency Program, in 2006 to 2008, as well as working inpatient United Medical Center, being medical director there, and a nursing home. So thank you to Mr. Sharif for his testimony. When I was the medical director of CPEP in 2006, 2008, it appeared to me that the mindset was different. At CPEP, it was clear that when everybody else in the city refused to take a patient, we knew we were the safety net and never sent anyone away. We took the toughest, most difficult, and dangerous patients because as part of DBH, we were always the last resort. There was no turning patients away, like the gentleman or the person he was talking about. It seems the mindset has changed and currently patients can be turned away from CPEP. And when I first heard about this, I was in disbelief. But I know that even as a psychiatrist, I have struggled at times to get patients into CPEP and for them to actually go on to admit patients, having arguments with their medical director about patients' risk levels and saying that this patient is clearly a danger to self or others, and going back and forth to try and get them into the hospital. When patients aren't admitted to CPEP, as you can see, you can have catastrophic results, which ends up leaving at-risk individuals in the community, and police themselves are less willing to bring people to CPEP. One of the problems in the city is the difficulty to get patients in the community involuntarily committed when they are a clear danger to self and others. This has been a problem from my days in CPEP, and part of it has been a reluctance of MPD to do FD12s. And I can go in later on to explain the reasons why. First of all, as an emergency psychiatrist, my threshold for involuntary committing someone is very, very high, so I don't take it lightly. When I was medical director of CPEP, FD12s at that time were done by police if they were the first ones on the scene, or they would call mobile crisis. If mobile crisis wasn't available, they were willing to do FD12s. Nowadays, it's almost impossible to get a police officer doing FD12. And when they arrive on the scene, and I'm sure a lot of the agencies will know this, police officer will tell you that they didn't hear the person say they're suicidal, or they didn't hear the person threaten somebody and just leave and say, well, we can't do anything because we didn't hear it, which is absolute, which is not correct, which is not correct because you don't need to hear that. The majority of the time they refuse to do it. If a patient told you were going to kill themselves, the police response is that they didn't hear it, which has been ongoing. They even get their sergeants to say the same thing when you call them back to the unit. So I'm asking DBH to work with MPD to help fill the gap in care. Maybe they can undergo training and go through the guidelines. To give you an example how bad it is, a few years ago after the mass shooting in El Paso, we had a patient at our agency who said he was going to break the mass shooting record. And after there's two psychiatrists, another acting manager involved to assess this guy. We saw him for a couple of times, then realized that the risk was too great for us to manage on the outpatient, and we called DC police. We called DC police, told them about this guy who we really and truly believed, and even now I still believe is a high risk. The DBH was good enough to help us with him getting out of our agency. But we called DC police, told them about the situation, and told him to be discreet about it. They sent a police officer over to his house, and they asked him, "Are you saying that? Did you plan to? Are you saying that you wanted to break the mass shooting record?" He said no, so the police officer left him. The next day, we contacted the FBI after getting a threatening email from the gentleman. We told the FBI. The FBI then called DC police, sent another officer over who asked the exact same question. And when the patient said no, he left also. I have another situation from nursing homes. A patient who had a traumatic brain injury and was violent, aggressive, and threatening. In the nursing home, we called mobile crisis. We called DC police multiple times. DC police were always the most reluctant and would never FD12 them. Anytime we did get into the hospital people would say, no, you're a nurse practitioner, you're a nursing home, you should be able to handle it yourself. And we had struggles repeatedly. Nobody wanted to take this guy into the system. He goes to CPAP, they discharge him the same day or the next morning. Eventually, the gentleman took an oxygen tank that his roommate had and smashed him in the head and killed him. And the nursing home and of course this goes undone. And there's a year and a half of calls to mental health agencies to try and get help for this guy. We never could.
Dr. Novici?
Yes, sorry.
Sorry, I don't,
No, you're right. I apologize.
For your time, and we still have a number of witnesses to go. But sit tight, have some follow-up questions, either between myself and Councilmember Parker, who is still here. Okay. I first want to start with Amanda Morgan. We're interested in sort of learning more about the services that DBH provides to youth in care. Do you know if there's a wait list for foster youth needing services, and then what type of services are available?
Yeah, I can speak to what I know from CASA. There's certainly a wait list. I know that we're frequently asked if we provide the different services, different behavioral health, mental health services, and we do provide them. We currently do not have an extensive wait list at this point in time, so we are more than able to accommodate some youth that need some services.
So what's the definition of extensive wait list in your opinion?
Yeah, I mean, certainly just being in the behavioral health field, I've heard people say, it's weeks and months. Ours is about a week to 2 weeks to get someone in, just depending on their schedule.
Okay, that's not bad, actually.
Right.
All right, we might follow up with you for more information on that. Mr. Chafee, thank you so much for your testimony. And if our memories serve us correctly and the records are accurate, this is not the first time that you have testified before this committee on this particular issue in terms of staff needing more support and a feeling of needing more protection as they're sort of doing their work. What do you think that DBH should be doing to provide support to critical frontline workers? Is it the, everyone talks about like, oh, we have an employee assistance program, but is it offering, therapy services, et cetera, to staff and contractors? What do you feel like would help you and your colleagues better?
Well, thank you for giving me the opportunity, Council Lady. First thing, I think that safety care is not a good apparatus for working with inmates. You can't use a nursing home safety care restraint apparatus to work with violent criminals. That's the first thing. Second, when your workforce is injured, DBA should be ready to encourage them to move forward positively, giving them resources where they can go and get mental health treatment, offering them maybe a day or something off so that they can get themselves together. My coworker, she tore all to pieces right now, and she still comes to work. I got coworkers who have been, robbed at gunpoint while sitting in the government vehicle. Ms. Rosetta Price is these are the type of things that no one even embraced them to say, are you okay? You know, people being stabbed with knives. We going in drug infested areas. I work at night. I go in the worst areas in the city. Wherever it's at, I'm going to go there. That's how we do. Community response is a beautiful program. It's just unfortunate that we don't have the leadership to run that program like it's supposed to, like it was when it was under Tyrese McAllister. You know, right now the program is tearing apart, and they don't have, you know, you can see the systemic racism that is being played out in it right now. And it's just unfortunate that people who put their lives on the line like this, we are not compensated financially or spiritually or emotionally. And it's just unfortunate that I don't know how DBH is going to do this, but I just think that something needs to be done, because I got too many people calling me. I'm just a person who love my people. And I don't like to see my sisters and brothers suffer. And it's just unfortunate that I see it all the time. And, you know, these people, Ms. Rosetta Price, she went out and got a master's degree. She's a peer, and she didn't get compensated for it. I don't understand that. You know, we do this hard work and there's no compensation for it. It's just unfortunate. Now they added another burden to us. Now we got champs, we got the little people. We have to learn how to deal with the little people, make sure that the little people safe, make sure, you know, they running away from home. We're the one going looking for them. And that's the hardest part now. We got the little people that we got to deal with. And it's just,
if I could, and Ms. Mathis, I don't expect you to speak for your entire organization, but I'm curious, is there a level of coordination between CHAMPS and the community response teams?
Yes. We actually meet on a daily basis. We conduct a time where we have shift reports, where we speak to the staff who went out maybe the night before or over the weekend. So yes, we try to coordinate on a daily basis with their leadership team.
Okay. And what about the training though? I mean, I'm imagining some of the folks on Mr. Shafi's team aren't used to dealing with young people, right? They're used to dealing with adults.
Absolutely. So we offered the opportunity for the CRT members to come over to the CHAMPS office and then stay here for the entire day and shadow us while we are in the field and see how we conduct an assessment with an adolescent.
Okay. And so I'm so sorry, Councilmember Parker, I see you. I'm coming to you. Give me a minute. I'm just trying to understand, is it a capacity issue in terms of now why we are deploying community response teams to some of these calls? I guess it's probably a more appropriate question for DBH. So you know what? I'm gonna put a pin on that. We're gonna ask Dr. Bazaran about that next week. I'm way over my time. Councilmember Parker, do you have any questions for this panel? Okay, I see his box here. Okay, I'm gonna ask one more question because I'm gonna just use the chair privilege here. Dr. Noichi, thank you so much for your testimony. You know, how can DBH and providers work better to address these serious situations where there's the likelihood of violence, right? So I recognize that there is an apprehension for individuals to call MPD, particularly in communities of color. But who is the appropriate entity here?
The appropriate entity would be the crisis response teams. And usually what happens is they come out of CPEP, and they would be the ones who would respond. And if there's any situation where they think there might be a risk or danger, then they will call MPD for support. And they will go in there as the lead to do the mental health assessment, and MPD will be their backup. So you have that mental health hand to see what's going on. I want to clarify too that, you know, when I was talking about MPD not wanting to do FD12s, this is the situation. This hasn't changed. So when I was there in 2006, 2008, the MPD officers were telling me that when there's, and sometimes in CPEP in the summertime, you'll see 6, 8, 10 officers waiting inside CPEP. And they would tell me, there's these 4 guys, these 6 guys are from my district. And that means if there's 6 of us here, that means there's 6 less officers in that district to protect the city. And that puts everybody at risk because now police are responding to crimes with less officers present, and that puts everybody at risk. One of the suggestions we had when I was years ago when we had Chief Ramsey was here and we discussed the same issue, was maybe using an auxiliary transport service, either protective services or another services. You don't necessarily need to be a police trained officer in order to transport somebody in a van to CPEP. Another issue, again, which hasn't changed from my time, was that the police did not like CPEP. When I first got there, and there was an issue, the conflict between CPEP and the police. And while I was there, we kind of pushed to make sure that the relationship changed. One of the issues, of course, was being told to wait in CPEP with the patient for ages. So what we made a point to make sure that when a police officer bring a patient, unless they're extremely dangerous or violent, then we will make sure that the police get out and back onto the street as quickly as possible. And that improved our relationship. And we made sure that people weren't, they were very polite and cordial to the police. So we became part of the same team. I worked in Fairfax County in their emergency services, and that was the kind of relationship they had there, where if we called them back again, 2004, 2005, if we called them, they would rush to if we called 911, they were there within minutes. But we would call DC police back then when we had the bad relationship, they would come 25 minutes later. So that relationship is very important for the police, for them to make sure that they want to come and bring patients, and also for CPEP too. CPEP needs to be able to be more willing to send patients onto the hospital. I mean, the criteria is very simple, which I know is danger to self, is clear danger to self or others. And they were sending patients who were dangerous back out. And I'd have that discussion and have to be very diplomatic, but that which is, when you put people back in the street, then anything can happen.
All right. Thank you so much for your testimony. Thank you to all of the witnesses for your testimony and for being here today. Please, if you can make sure that we have a copy of your written testimony. I don't have any further questions, and I don't see Councilmember Parker, so we're going to move on to the next panel. Thank you.
Thank you.
All right. We're making progress. We're making progress. All right. We're going to call up the next 5. Sandra Seekers, Johnny Howard, Marissa Perella, Ambrose Lane, and Sal Selvagio. I hope I got that right. Okay. For those folks in this next panel upcoming, again, if you are just joining us, you will need to affirmatively accept our invitation to become a panelist so that you can be elevated. Okay, Ms. Seegers, I see you. So if you want to go ahead and get started with your testimony. And if you are speaking, you are on mute. We cannot hear you.
There, how's that?
Yep, I can hear you now. Thank you.
I was saying hello and congratulations on your committee.
Oh, thank you.
You're welcome. Now let me go to my statement here. It's not gonna work. Okay, let's see. 'Cause I've been here all day listening in. Let me get to my statement. It's very short. I'm speaking from a community aspect where I deal directly with Dr. Bezron and the Chief of Staff, Phyllis Jones. I'm Sandra S.S. Seegers, a member of Concerned Residents Against Violence and a Ward 8 resident. I am testifying about how well the Department of Behavioral Health engages with the community. The Director, Dr. Barbara Bezron, and the Chief of Staff, Phyllis Jones, always listen to suggestions and recommendations. They never decline an invitation to attend a community meeting where they can inform the residents and listen to their concerns. In talking to them and reviewing their website, they have services to cover every behavior health imaginable. They launched a 3-digit phone number for people in crisis, which is 988. We often say people who break the law have mental issues. I would like to see the court order more mental evaluations. I would like to have more money in the budget so DBH could issue a contract to an advertising company to design and run public service announcements in the newspaper, local TV, radio, buses, and trains. From all I can see and have heard, DBH is an agency that's serving the community well. And I'm speaking from a community person who deals directly with the director and Ms. Jones. And that's the end of my statement.
Thank you, Ms. Seegers. Johnny Howard. I don't see him. Marissa Perella. Right. Mr. Ambrose Lane. There you are.
Yes, how are you, council member? Good to see you again.
Good to see you.
Before I begin, I want to lift up the prior testimony of Queen, Tamika, and LJ. I also want to lift up the testimony of Sharif and Dr. Nawuchi. I think those are extremely important. My name is Ambrose Lane Jr., and I chair the Health Alliance Network, which is DC's largest community-based health advocacy organization. Back in April of 2021, I was asked by a colleague that works at PIW to get involved in the opioid crisis. Prior to that, the Health Alliance Network was focused on chronic disease and other health issues related to the social determinants of health in Washington, D.C. At that moment, we created what is called the Opioid Solutions Working Group. The Opioid Solutions Working Group is made up of recovery coaches, peer recovery specialists, community groups, recovery training organizations, physicians, family-run organizations, and some of the organizations that are a part of it are Prestige Health, Howard University School of Pharmacy, PIW, DC Recovery Community Alliance, Oxford House DC, HIPS, Family Medical Counseling Services, Ward 7 and 8 DC Prevention Center, R1 Learning. We have about 55 persons and about 19 organizations that are part of the Opioid Solutions Working Group. In 2022, early 2022, we created a resolution for advisory neighborhood commissions that we actually went and presented to all of the commissions in Ward 7 and 8. 8 out of the 10 commissions in Ward 7 and 8, and we had all of them adopt the resolution unanimously with no dissent. And the resolution called for certain things to happen in the opioid space. In June of 2022, I issued a letter to Mayor Bowser and Chairman Mendelson, and it was CC to all members of the council, as well as Dr. Barbara Bazron, Director Turnage, and the Chief Medical Examiner. And it called for additional steps that the city can take to try to mitigate the opioid crisis. I'm going to read for you some of the things that were contained in the resolution, but I will send the full resolution to you in my testimony. Since 2017, or between 2017 and 2022, that's 6 years, there have been 903 homicides in the District of Columbia. By contrast, there have been 2,036 opioid overdose deaths. That amounts to 26 to 27 deaths per month, almost one per day. In 2022, there were over 10,000 calls for non-fatal opioid overdoses. In 2021, there were increases in opioid deaths in 6 out of the 8 wards, with a notable 26% increase in Ward 7. The District of Columbia ranks first in the U.S. in all drug overdoses and second in opioid overdose deaths. The Opioid Solutions Working Group adopts the position for the need for a DC opioid use disorder infrastructure that includes harm reduction centers that was mentioned earlier by Queen and others, youth residential and adult residential models, sobering centers, and adequate integrated hospital treatment. There is no 24-hour adult residential treatment center located east of the river where the main problem is. The Opioid Solutions Working Group adopts the Rhode Island model of residential treatment, and we do distinguish between residential treatment and harm reduction centers. They're almost the same, but they're not exactly the same. And this residential treatment centers need to have on-site wraparound services. It is recognized and maintained that the Opioid Solutions Working Group that the District of Columbia has an inadequate workforce for opioid use education. And so some of the things that we are asking in the resolutions call for that a full service 24-hour residential SUD model to include outreach, treatment, and recovery be financed and located in Ward 7, as the hospital will handle some of that in Ward 8. That 2 substance use disorder, opioid use disorder residential treatment models be financed and located east of the river in Ward 7 and 8. That treat co-occurring disorders. That's another thing that was not mentioned during this hearing, is co-occurring disorders and how that impacts the opioid space. We also are demanding that healthcare finance eliminate prior authorization use following the path of other states and is recommended by the National Society for Addiction Medicine and the AMA. There is no excuse why the District of Columbia has not eliminated prior authorization. I just did a presentation earlier today at SAMHSA and CACA conference over at the National Harbor, where we talked about the elimination of prior authorization. It is critically important for the specialists and the doctors that treat opioids and other substances to have the expertise and free will to recommend the type of dosage that is needed. We also want to demand that DBH create a personal health information case review model that integrates and addresses co-occurring disorders. In other words, when a person has an overdose that's non-fatal, how many times prior have they had a non-fatal overdose? Do they have any co-occurring disorders in mental health? These are the types of things that we need to ascertain. And then lastly, that the healthcare finance create a second 1115 CMS waiver to address the additional needs in the opioid space. We know that in 2024, they're going to be re-upping the current 1115 waiver, but they can add a second 1115 waiver just to deal with the opioid workforce that is absolutely needed. And I certainly have more. I don't want to take up too much of your time, but I am open and available for comments and questions.
Thank you. Thank you, Mr. Lane. And Sal Savigo? No, Sal. Okay. All right. So Ms. Seekers and Mr. Lane, you are two on this panel before we get to some of our students. Mr. Lane, I just want to mention in terms of the prior authorization. So I met a couple of weeks ago with the Medical Society of DC, and they brought this up as one of their priorities. My understanding is last council period, Councilmember Mary Che introduced legislation on that. And that I believe that Councilmember Pinto plans to reintroduce that legislation. And so we'll take that up once that happens. So thank you so much for being here for your testimony. And I totally understand and hear where you're coming from. Ms. Seegers, thank you so much for your testimony as well. And for being here all day to sort of hear the feedback. I certainly appreciate the emails that you send us in terms of the work that your organization is doing in the community. And so we'll keep your remarks in mind.
Thank you.
Councilmember Parker, do you have any questions for these witnesses?
Yes, I also wanted to just echo thanks for you all sharing your testimony. Ambrose Lane, if you could share that resolution. At the time it was transmitted, I wasn't on the council, but I would be interested. You noted the difference between the residential treatment centers that you're calling for and the 24-hour harm reduction sites. How would you characterize their differences, and how might they coexist in an ecosystem here in DC?
Well, you use the word, council member, it's ecosystem. We need a harm reduction infrastructure, not just one thing or another thing, but many things. And so I've met with Queen and LJ, and we talked over the harm reduction centers that they are trying to advocate for. And I 100% agree and support the advocacy for that. A residential treatment facility is a little different. It's like the difference between PIW and a hospital. Even though PIW is designated as a hospital, it's not exactly the same as a hospital. And so when you're talking about residential, you're really talking about 24-hour residential where the treatment can take place over a 24-hour period. It also has to include wraparound services that are on board, that are there at the time, because what often happens is that a person will go somewhere to get treatment and then they're given referrals to go to another place. And often those that are within the OUD and SUD space don't necessarily go and get referrals. So they can get access to whether or not it's housing that they need, whether or not it's food that they need, whether or not it's something, whether or not it's behavioral health services that they need. They can get that on site before they actually leave the premises. In bed, and when I say residential, that's in bed. So that's a little bit different than a harm reduction center where a person can go and safely use, and that there's nothing wrong with that. We need those as well. This is not an either or, this is a both and. And so we are adamant about an infrastructure in the District of Columbia that addresses both needs. So we need both, especially when you're talking about residential treatment for youth. We know that there's an increased use. If you talk to anyone from Mary Center, they'll tell you that young people are coming in addicted to opioids. And so you need a treatment center for young people, but you can't mix a youth residential treatment facility with an adult residential treatment facility. That is just nothing, you cannot do that. And so these are the types of things that we're talking about. So that's why I advocate for this, and that's why I support what HIPS is talking about as well. They're both needed.
No, thank you for that. And that point is well made and taken. Is it fair to characterize these residential treatment centers as more of a preventative step? And so I know you're talking about the wraparound approach, and the harm reduction sites could be characterized as a preventive step for death. But I'm thinking, assuming that we accept that individuals are using, and that is just a fact, we want them to be safe so that we can cut the very large numbers that you cited between 2017 and 2022, these residential centers perhaps could provide services, supports, also targeting those co-occurring disorders so that few people have to utilize the harm reduction sites. Am I thinking about that the right way? Or how would you encourage us to think about how these two might coexist together?
Well, they will coexist because they address certain elements of the opioid crisis. Neither one of them address all elements of the opioid crisis, but together they do. So, for example, the harm reduction centers address users. As Tamika said, there are people who recreationally use. They don't necessarily need treatment, so they're not going to be ones that are going to go into the residential treatment facilities. They're going to go into the harm reduction centers. So there are differences, and it might seem like they are minor, but they're not minor. They're major, but they both are part of the ecosystem that is needed. And when we talk about infrastructure, we talk about the whole bag of infrastructure. And quite frankly, council member, the district needs to spend some money on this. And if we really want to, I mentioned the figures of 2,036 opioid deaths, which is more than double the number of homicides. That's what we're not wrapping our head around that. It's more than double the number of homicides. And as you know, homicides are at a 16, 17-year high. So when we're talking about dealing with opioids, which is the silent killer, we have to have an infrastructure to be able to do that. So we need both of them for sure.
No, I really appreciate it. And in my last seconds, I would just say, what I really appreciate that you're talking about is creating a plan for the district. And so instead of addressing this in a piecemeal fashion, we can create a coordinated approach to how we're going to face our crisis here in the district, but also target those that need the support the most. So thank you again for sharing.
And Councilmember, I'll just add one thing, and that is to not leave out the importance of the workforce. We do not have an adequate workforce that pays peers the adequate amount of money. We need the 1115 waiver to be allowed to get the reimbursement rates up to living wage. And there are states that are doing this. There are examples where this is happening. Florida has a wonderful example of how they use peers to attack this crisis. And we are just dragging our feet, it seems, when it comes to the innovations that are happening all over the country.
Thank you. I'll schedule some time to follow up with you.
Thank you.
Thank you to this panel and thank you for being here. We converted back to attendee and then we're going to move on to the next panel of students. So always a good way to end the hearing on young voices. So I'm going to call up 5. It might be more than that in case everybody's not here. So Sophia Posner Brown, Juliana Lopez, Amara Tran, Marinella Riveras, and Asher Thornton. See where we get with that. As a reminder to the public witnesses, you need to accept our invitation in order for you to become a panelist. Okay. Is here. Is here. Amara's here. Is here. Asher here. Asher is not here, so we'll bring up Silas instead. Okay, great. All right, Sophia, if you want to unmute and begin. Thank you for being here.
Thank you. Good afternoon, Chair Henderson and members of the committee. Thank you for the opportunity to testify today. My name is Sophia Posner Brown. I'm a Ward 3 DC resident. I am a sophomore at Jackson Reed High School. I'm a brain cancer survivor after a 6-year battle. I'm now 8 years treatment-free. Today, I want to bring your attention to the lack of mental health support and education in our public high schools. This issue of mental health and support is important to me. School is at least 6 hours a day, and we typically only get an hour break in the middle, and even then, kids are stressing over the schoolwork. It's not a surprise that in YWP's recent survey, Jackson Reed students reported a high level of stress. 22% said their stress was unbearable, and 27% said it was too much. 28% reported high but manageable stress. Teachers always say go to the school counselors if you are struggling with your mental health, but counselors are never around or there are just not enough for all the students. Many kids go to their favorite teacher when they are feeling down, which can work, but most of the time teachers do not have the resources or capability to help kids through a serious mental breakdown. 63% of students reported having a trusted adult to talk to, but 37% did not. Only 53% of students said they were comfortable talking with counselors, and 30% said they were comfortable with DBH clinicians. DC public and charter schools do not educate students on mental health. A student surveyed at Jackson Reed, 72% of students said they received no mental health education and 18% said they received an hour or less of instructions. The COVID-19 pandemic worsened students' conflicts. There are a couple of solutions that can help students' mental health. Schools should hire more guidance counselors. Almost 71% of students at Jackson Reed who took this survey say they have never received check-ins or help from a counselor. Mental health should also be taught in schools as a required class. I believe mental health is a necessary course for high school students. As many as 81% of students surveyed at Jackson Reed said they have never or rarely received mental health support at school. Schools should educate teachers on mental health. Many students have a teacher they feel they can go to in hard times, but more often than not, a teacher is not prepared to help the student. I believe that if teachers were better equipped and trained in mental health support, they would be a more appealing resource for students. Thank you for taking the time to listen today. I hope these ideas prove useful.
Thank you. Thank you so much for your testimony. Juliana?
Hello, Chairwoman Henderson and members of the committee. Thank you for the opportunity to testify today. I am Juliana Lopez, a senior at Columbia Heights Educational Campus and a resident of Ward 4. I plan to attend college to study political science and education, so this time to testify is sincerely appreciated. I've been a youth advocate with the Young Women's Project for the past 2 years. Last year, we created SOS centers, also known as Student Online Support Centers, and this year we have continued to expand the participation of the annual survey distributed to all DCPS and DCPCS students. I joined the Young Women's Project to help my community combat the mental health issues within DCPS and DCPCS and to uplift the youth voice. I am testifying today to raise awareness on the mental health of youth and to call on the committee to reconsider what the actual needs of the youth are across the district. I will also share some of the preliminary results of our recent 2022-2023 youth mental health survey. Mental health and wellness education is crucial for the youth to understand what they're going through and how to take care of themselves. Poor mental health affects your overall health, just like a domino effect. I've experienced the consequences of poor mental health and seen students suffer academically and personally over it. Getting connected to someone can be an issue for some, and a lack of resources can be another. This year, I learned through an annual youth mental health survey with the Young Women's Project that about 60% or more of students don't know the names of their mental health counselors. For Czech specifically, that is 75% of students who don't know the names of mental health counselors. Most of the responders were 10th graders, and it's concerning that those in their second year don't know such important information. My school has taken the initiative to help their students by creating mental health surveys, partnerships with organizations, having advisors check in with students to make sure that they have the resources they need. However, these previously mentioned initiatives all seem wonderful and sound like they should be quite effective, but that's not always the case. Surveys are not taken by all students, and they may give inaccurate data because they're not properly used or taken seriously. The youth don't want to only be heard or listened to. The youth would like to see more qualified clinicians. The youth want to see sincere change. I am not only asking you to provide more resources for our schools, I am asking you to provide good quality mental health resources, to take real initiatives. Don't just slap a name to a program and a representative and meet to talk about it, but never follow through. Figure out what the youth need, not what you think we need. The reason why we may not know what we need is because we don't know what is happening to us, and giving us resources that we don't need is unnecessary, which is why proper mental health education is needed. Mindfulness is not enough. Having students participate in mental health activities that they don't understand or know the purpose of is not enough. I am more than glad to connect and talk about initiatives. Thank you for your time. I hope you consider what I've shared today and that you reflect on the needs of the youth.
Thank you. Amara?
Thank you, Chairwoman Henderson. Good afternoon, Chairwoman Henderson and Councilmember Parker and members of the Committee on Health. I appreciate this opportunity to testify today. My name is Imara Tran. I'm a Ward 2 DC resident, and I attend Basis DC Public Charter Schools as a senior. I will be attending college in the fall at Johns Hopkins University with the intended major on behavioral biology. I've been a peer advocate with the Young Women's Project since September, which is an organization that builds the leadership and power of youth so we can solve community problems, and an issue that we are dealing with is the lack of mental health supports in schools. I will also be sharing some of our results from our recent 2022 to 2023 Youth Mental Health Survey. A system issue that exists within our schools is that many students do not know who to go to when they experience poor mental health. In the BASIS survey, a question asked, do you know the name of your mental health counselor? To which the majority of the 67 surveyed individuals, 53.73% responded with no. This data shows that a large number of BASIS students do not know the name of their counselor, meaning they've likely never met with them or received resources from them. At Basis DC, we have a psychologist who is on campus only for 2 days of the week. This makes the psychologist very hard to get in contact with. This is very troubling because students are not able to talk to their psychologist when they need to. So I have several recommendations, and here's a summary of each of them. Schools should have mental health professionals on campus more often. This would help students with more access to mental health resources in case students experience mental health emergencies. In our BASIS survey, we asked if lunchtime one-on-one sessions would be something students would be interested in. What we found was a majority of BASIS students surveyed said they were interested in one-on-one lunchtime with a mental health professional at 37.31%. It is evident that students want more time with mental health professionals, and by keeping these professionals on campus, we can improve the support for students in regards to mental health. Additionally, schools should encourage teachers to check on their students. In the BASIS survey, we asked, in the last 3 months, have you received a teacher check-in? To which the majority of BASIS students surveyed at 65.67% responded with never, and always at 0%. This data shows that BASIS students are not getting checked in by teachers and do not feel their mental health is cared for by the BASIS facility. To assess this problem, it would be extremely beneficial that schools train teachers on student mental health and encourage teachers to check in on their students. Thank you, Chair Henderson, Councilmember Parker, and the members of the Committee on Health for your time and consideration.
Thank you. Look at all of you within your time. I love it. Marinella. She here. Okay. Asher Thornton. Oh, there's Marinella. Hold on one second, Asher.
Good afternoon, Chairperson Christina Henderson and members of the Health Committee. Thank you for the opportunity to testify today. My name is Marianela Rivas, and I am a Ward 4 DC resident. I am a junior at Benjamin Banneker Academic High School. As a youth justice advocate at the Young Women's Project, my objective is to contribute to the resolution of issues that today's youth confront, such as mental health and well-being. As you may be aware, mental health is a big topic today. When schools began offering in-person learning in 2021, the topic of mental health was briefly mentioned in class for a while. When we returned to our normal everyday lives, however, such conversations faded. With the rapid evolution of technology and the internet, as well as the brand new educational environment, attempting to return to normal was difficult. This is particularly true for many students. I am testifying to you today to include mental health education in the school's curriculum. As a student at Banneker, our ability to overcome adversity gets challenged every day. However, these challenges are not so black and white. I struggled with constant academic burnout and social anxiety. In the beginning, it simply started out as just losing 2 to 4 hours of sleep and skipping a few meals a day. I was willing to sacrifice both of those academic validations. However, after being sleep deprived for many months and not maintaining a good diet, it eventually caught up to me. It was tough for me to talk about this with anybody since I felt that if I did speak out, I would be criticized or looked down on. Even though it is a common trend at Banneker, students should not be constantly concerned with their GPA or class position. Students should prioritize their well-being, character development, and other academic responsibilities. If a student does not feel comfortable talking to one adult, then there should be a different experienced adult that can help. Mental health should be taught because it is an important lifestyle one must have to thrive in life. I want to limit the number of students that must reach rock bottom to see this lesson. Banneker is a school that will provide you with the tools you need to succeed in college. It would be preferable, though, if they could couple those academic opportunities with healthy mental health skills. There is a limited number of options students can turn to when seeking help. Students from Banneker, a part of the Young Women's Project, conducted a survey for the school's student body. Our data shows that the youth at Banneker seem to struggle largely with hopelessness, with 51% feeling so sad and helpless that they stop doing regular activities almost every day for 2 weeks or more in a row. 30% struggling with low motivation. This is not comfortable information to hear, I know. I believe that mental health was implemented in the teaching curriculum, this data would improve. Implementing stress management strategies in the curriculum will encourage students to engage in open discussion about mental health and promote healthy lifestyle choices, such as exercise and proper nutrition. This will allow students to live better lives and have better academic progression. Thank you for your time, and I hope that you will consider these recommendations.
Thank you. Asher?
Hello, everyone. Thank you so much for allowing me to testify today. My name is Asher Thornton, and I am 15 years old. I have lived in DC my entire life. I live in Ward 3 and am a sophomore at school without walls, which is more colloquially known as just walls. I am a youth justice advocate for mental health for the Young Women's Project. The past few years have been especially difficult and have seriously impacted my mental health. I joined the Young Women's Project because my experiences with mental health services in DCPS have been far from ideal, and I would like to help change that. I am testifying today to bring to your attention the severe lack of mental health staff in DCPS and DCPCS. I believe that the administration of DC public and charter schools has not made enough of an effort to be accommodating to the needs of their students. My school began last year with 3 mental health staff. We ended the year with 1. This year, we have a full-time psychologist and a part-time social worker. I understand that the hiring process is long and arduous, but the assistance for students cannot wait. This challenge is not limited to walls. DC public and charter schools in general need more mental health staff. When the Young Women's Project conducted a survey of high schoolers around 2 months ago, 13.7% of students had considered attempting suicide in that past month, and 17.26% said they had considered self-harming in that past month. However, 90.3% said they had never received mental health support at school. There were 614 respondents. I myself have been very close to losing a close friend of mine to suicide. These statistics prove not only the critical condition of the mental health of students, but how little help they are receiving. The ongoing trauma of quarantine has severely impacted the mental health of many students, including my own. Although I'm sure it's not easy, the solution to this crisis is to hire more staff. Those in charge of hiring for DC public and charter schools must prioritize finding more mental health counselors and psychologists. The more mental health staff, the more assistance students will receive and the higher the quality of this assistance. The staff will also be less overworked. The Department of Behavioral Health leaders and leaders of the DC Council bringing up this issue with the leaders of DC public and charter schools administration could push them a step in the right direction. Students like me do not have the power to talk to those in charge of hiring teachers. However, the DC Council and Department of Behavioral Health, I assume, does have that power. Therefore, I'm appealing to you today to raise this with the DC Public Charter School Administration. It can make all the difference. Thank you so much for listening, and I hope you will consider my proposal.
Thank you. Silas?
Good afternoon, Chairwoman Henderson and the members of the Committee on Health. Thank you for the opportunity to testify today. My name is Silas Salamayu, and I am a Ward 8 DC resident. I am a junior at Dunbar High School who aspires to go to college, and I want to become a veterinarian or a writer. I have been a peer advocate with the Young Women's Project since September 2022. I became a youth advocate for the Young Women's Project to learn more about mental health. An issue that I am dealing with is the lack of mental health resources and education in public schools. Mental health is an important issue to me because many of the youth are unaware of the effects mental health can have. Plenty of youth, including myself, have dealt with toxic stress and anxiety with the workload, competitive college expectations, and spotlight of social media. Students feel as though they have to take on more responsibilities, and it can lead to a strain on their mental health. It's alarming that 47% of Dunbar students surveyed by YWP reported that they are sad and hopeless and that they have stopped doing regular activities. Dunbar has a website where students and parents can go to find and contact staff members like counselors and teachers, as well as look at academies Dunbar offers, creating an inviting first impression. My school is putting more effort into addressing student mental health needs with its youth mental health program as part of Dunbar's youth mental health team about raising awareness in the growing mental health crisis. We plan on educating youth on mental health and its importance. It's hard to address mental health problems when you were never taught what mental health is, and a lot of youth are never going to be college ready, facing the stress that they will get from studying, athletics, or college and job life. Most schools do not have mental health education, and 61% of Dunbar students report receiving no mental health education in the past year. I have made multiple solutions to helping to solve the mental health crisis. Schools should employ a mental health curriculum with a class about mental health. Students can learn ways to manage their mental health. It would teach them how if they are stressed, how it can affect their relationships, how what they see on the internet can influence how they feel and themselves and their peers. Schools can make a change to how it runs, adjusting the schedule to meet the needs of competitive students. College is now looking for students who don't just have good grades for what they have done. With a shorter school day, students would not have to worry about feeling stressed out about tests or deadlines because they will have the time to do homework, study for tests, and still take care of other responsibilities. My final solution is a change to elementary and middle school's ability to suspend students. Punishing someone by sending them back to the source, either home or community of mental disorders, and or the reason why youth could be having a hard time handling their emotions, resulting in them getting into such situations, only further grows the youth mental health crisis. Suspension is disregard. My idea includes school detention being put into place. The time range for detention can equate to cause, and during that time, students can receive sources relating to mental health from their counselors. Thank you for your time, and I appreciate you listening and hope you take these solutions into consideration.
Thank you. And thank you to this panel. I think some of your comrades had to drop off, but I do appreciate your thoughtfulness and the testimony that you've presented. This is for anyone. The survey that you all referenced that you did with your particular schools, did the in size vary? I imagine that it did. I think someone mentioned they had 60 people who responded. Someone else said another number. Do you have a number across the whole of how many students took your survey? I don't know if any of you know that. I could hold that question for Nadia.
I have the answer to that question, Chairwoman.
Oh, okay. Go ahead, Amara.
Over 270 students responded to the survey. I believe the number is around 273, but somebody can correct me on that.
But yeah, if you're asking about the total number of students who took it from across the district, it would be around 660 students. We had a little more over 600 students who took it. And numbers did vary between school to school because we have different amount of representatives or, YWP members who are at different schools.
Right. Thank you, Juliana. And this was only of high school students, correct? It wasn't of middle school students?
Yes, this was only on high school students.
High school. Okay, great. I think about sometimes when we talk about the school-based mental health program and what we're doing, as with anything, right? For elementary and middle school students, it is one way, but for high school students, I've always said that our approach has to be very different in terms of how we do the outreach and how we ensure that your peers are knowledgeable of the services that are available to them. And I think I want to say like maybe last year or the year before, one of the questions I had was whether or not any of this information is available on your websites or however you receive your intranet, your school intranet systems. Like if you were a student who was logging on or a student who was looking for mental health resources, where would you most likely find it at your schools?
I know I can answer for my high school, Jackson Reed. I don't know about the rest of them, but my high school, we do not have anything specifically listed on our website. There are a few little mental health websites that you can click on a link and it takes you to get immediate help, but nothing that displays information.
Okay. Anyone else want to sort of weigh in?
And just to add on, oops, go ahead.
So at Dunbar, we kind of do grade level town halls. So what the counselors will do is they will introduce themselves, and that is how we know who to go and talk to. And they're also on the Dunbar website, and they also tell us to go to them if you need any sort of help or resources.
Okay. So I think all of you testify that we need more people, and I agree with you. We need more people. The unfortunate challenge is layered. We need more people across the country. We need more people at our hospitals. We need more people at our nursing homes. We need more people at, a lot of the facilities in terms of the number of individuals who are interested in going into this work or pursuing this work. The demand is not meeting the need. Or rather, I would say our supply is not meeting the need in terms of what we have available. Are any of you interested in going into this field? Heard someone talk about maybe being a veterinarian, but no one said I want to go into psychology. I don't want to put anybody on the spot. I'm just
personally, I want to go into psychology.
Okay. All right, Sophia, I got one.
I'm majoring in behavioral biology in the fall, so I'm looking into that career field as well.
Right. So Amara's on that one side of too. Okay, great. So if you had to if I'm summarizing, it's 1, increase the number of people, and then 2, increase the amount of outreach that's available. Am I getting this right? Or is there anything else that you feel like we need to take away as a major takeaway from your testimony?
I think that pretty much covers it.
Okay.
One more thing really quickly. I think it's a matter of having accessibility to the resources. A lot of students don't know where to find the resources. And I'm glad that you asked, I only have like 3 seconds, but you asked the question before of how we can access resources. And the issue is that students don't know where to find those resources. And that's what we need to focus on, getting the resources out to students that they actually need, not just random resources that they found on a website from the school.
Got it. Okay. Sit tight. Councilmember Parker has a round of questions and he may have some questions for you. Thank you.
Thank you all for your testimony. And I just want to give a quick shout out, if I got this correct, to Jackson Reed, Columbia Heights, Bases, Banneker, Walls, and Dunbar for just having some dynamic students that you all that testified. I did want to follow up on the survey, but also have some specific questions. So it seems like more than 600 or perhaps 660 students across the city responded to the survey. And this is for anybody. Were there trends and what may have been some of the factors that were impacting student mental health? I know some of you reference like the intensity or the stress of like, let's say, high rigor schools. Like, for instance, I believe that was Ms. Rivas, you said 30% of students at Banneker had low motivation, but were there other factors of note through your survey that led to student health issues?
Well, for one, we don't have that many like fun, what you would say, like after school activities. We only have like academic basis opportunities. And then it also goes with having counselors that are there for us, or like that not many counselors that are really like specialized for mental health. Like I know at Banneker, we only have one counselor that is like dedicated for mental health there to help us, and she kind of like rarely comes in, so there's not like many options or people like we can really look to.
Thank you. Anybody else want to jump in there?
A lot of the questions on the survey, I know personally it was the same survey for all, but personally Jackson Reed, a lot of people said that there weren't like, they didn't know where to find their counselor or there weren't enough, because there are like a lot of people at Jackson Reed. So like over 2,000, and there's only 2 counselors per grade. So a lot of people said that that wasn't enough per grade, and that was a common theme I was seeing in the survey.
Yeah, that stood out to me. And I just would also acknowledge, I think for all high schoolers, mental health is an issue, right? Even when I was in high school, I think it's a lot harder now to be a high schooler, just given the pandemic, given the age of social media, the stresses that it is a lot. And I just want to acknowledge your testimony and just the challenges that you're referencing. Silas, you called for a mental health curriculum. And I just wanted to ask more about that. Is that something you think should be self-directed or peer-directed or actually taught by teachers?
Hello. I think it should be something actually taught by teachers. Actually, I think it should be both, because if it's actually taught by teachers, then people can learn about it. But if it's also peer-directed and self-directed, then it could be seen as, it can be brought into the community, right? Like if everybody was to take on this mindset of, oh, mental health is important, then it can bring in more people to actually care about it.
Absolutely. And I don't know if Asher is still on, but I did want to just appreciate your transparency and just extend condolences for, as you put it, almost losing a friend to suicide. That is a very real consequence of the mental health challenges that our youth are facing. And not to end on a negative note, but just well, let me flip that. What are some of the supports that are there for some of your friends or peers that are considering suicide, or are those even conversations that you're having in your schools?
In Jackson Reed's health class, we do a little bit, like, I guess, like, in health class, we do like once a month checking in on that type of thing, but there's never really a specific, this is where you go or anything. It's just kind of like a quick one-day topic.
I would say in Dunbar, the teachers are very supportive, but when it comes to the best support that we have, it would definitely be each other. Like I feel as though in Dunbar, the friends that you make are very important, and the friendships that are in there are very important. They are very important to each other. So if they were dealing with something, they would talk about it to each other and have those conversations with themselves.
Thank you for that. And that just underscores why that number of 53% of students not knowing who their counselor is a red flag, not only for themselves, but for the conversations that you're having with peers. So again, thank you for your testimony, and we will be sure to follow up.
Thank you. Thank you, Councilmember Parker, and thank you to this panel of witnesses. We're going to go on to some of your other colleagues, but thank you so much for being here today. I really appreciate your voices as part of this conversation. The next panel, Ulisa Canales, Sarah Sherlinder, London Heine, Araya Shelton, Jelani Easton, and we'll also do Janiyah Drayton as well.
Thank you for the opportunity to test today. My name is Julissa Canales Cerros, and I'm a Ward 1 DC resident. I'm a junior at Columbia Heights Education Campus. I've been a peer with the Young Women's Project since September 2021. I'm testing today because I want to bring to our attention how mental health continues to be an issue. Mental health is important to me because it affects me and my peers. Stress had impacted me in school because it can easily become overwhelming as you can try to keep it up and not fall behind. It often leads to late nights working and being stressed at school. I often don't feel supported in my school workload. I think our students do not know how to handle a busy workload, which it can have an impact on overall wellness. Resources or tools for me, this should be more need for students even when they're not dealing with a mental health crisis. The past school year, I worked out with a mental health survey in my school. What we learned was the 75 Czech students that took the survey, 47% had received any mental health education this year, and 43% had only an hour or less of mental health introduction. Additional, when we asked what will make it easy for students to assess mental health, 40% were somewhat interested in online appointments. Scheduling was 45%, so what interested in having contact information for mental health staff. The straight had meant of students that check are staying more away with mental health staff and counselors at their school. I think COVID-19 pandemic had impacted students in many ways. The transition for me personally from middle school to high school was difficult as my first year in high school was completely virtual. It means many young people likely do not learn about time and stress management and have to give up on the tools since we had been back then. This is a large gap. Resources given to students about mental health resource buildings. It has a negative impact on young mental health, and I ask Ray to work through bringing on more mental health staff to push more access to mental health resource students and older to learn more experience. Thank you so much for your time, and I hope to receive into conditions.
Thank you. Sarah?
Good afternoon, Chairwoman Henderson and members of the Committee on Health. My name is Sarah Sherlinder, and I'm a Ward 3 DC resident. I'm a senior at Jackson Reed High School, co-leader of the Jewish Student Union, a participant in the student-to-student program of the Jewish Community Relations Council, and as well as a peer educator with the Young Women's Project since this November. I plan on attending college in the fall and studying social work to become a therapist. I am here today to bring attention to the concerning amount of stress levels that students have displayed in the last few months based on our data. Also, the barriers of communication and outreach of mental health resources to students. In the last few years at Jackson Reed High School, I have noticed and discussed with my peers how stress has impacted their daily lives. The school has some smart and competitive students. We start taking honors classes as underclassmen, then as upperclassmen, we are expected to take APs. This can be good or even great. However, the pressure of constantly performing at a high level can create some drastic stress. The stress can be while partially from peers, the school system plays a major role in the pressure. In the last 3 months, YWP data, which was taken by 673 youth in 22 schools, of which 170 at Jackson Reed, reports that 57% of students say their stress is constantly high or unbearable. Plus, more than 1 in 3, that is 30% of students, said that they're so sad and depressed that they have stopped doing regular activities. Most DCPS schools have little to no mental health staff in forms of therapists, counselors, mentors, etc. At Jackson Reed, we are lucky enough to have some counselors and therapists. However, with overcrowding and understaffing, there's never enough time or resources for students to get the support and care that they need to perform at their best. There is a wall between students and faculty when it comes to outreach. Only 23% of students even know who our mental health counselors are, and no more than 8% know the name of the doctor of mental health DBH counselor. Not to mention the language barrier that many students face. Did you know there are no Spanish-speaking social workers at Jackson Reed? The school has a sizable Hispanic Latinx population, with many students who are not fluent in English, including many who face major challenges who could benefit greatly from these resources. So there are many layers to the solution. Chairman, you previously asked what resources are around the school, or one of you guys did. One of my recommendations is for teachers in each class to have a poster stating who and where our resources are for mental health. Students have voiced that they want to feel comfortable to go to someone at the school for help. Over 2/3 have agreed that they've been able to talk to a counselor. Over 2/3 have agreed that they want to be able to talk to a counselor at school. So by putting out information around school, we can support our community. Also, schools, I understand how many priorities that DCPS has to juggle, but at the end of the day, nothing is more important than the emotional health for our students.
Thank you, Sarah. London?
Hello all, thank you so much for the opportunity to testify today. My name is London Haney and I am currently a Ward 7 DC resident. I'm a year 1 at Bard High School Early College where I'm earning college credits towards my associate's degree. I'm the Vice President of the Bard Student Government Association and a member of various cousin committees. One issue that we are dealing with is the lack of mental health support in schools. I'm so thankful to be able to testify on this issue today and bring attention to this problem. Youth mental health and wellness directly impacts my peers and I. There have been many instances where my peers have complained that they are feeling extreme anxiety and burnout because of a heavy workload. No mental wellness support is being offered. As a mental health advocate with the Young Women's Project, I am learning about mental health and wellness and how to pass on this information to others. Although YWP is a tremendous space for mental health and education support, students should not have to search outside of the school building for this. It is imperative that we are taking proper care of ourselves and put our health first. We cannot do that when the outlying issues are not addressed, especially when the issue lives in school, where we spend most of our lives. After gathering information from students at Bard DC, it is evident that mental health and wellness are not being paid enough attention to. Students are lacking education on mental health just as much as they're lacking mental health support from adults in the building. According to a survey we conducted on school-based mental health, 68% of Bard students did not receive any mental health and wellness instruction. 19% said that they received only an hour or less worth of instruction. This lack of knowledge leaves our students more vulnerable to mental illnesses and toxic stress because they are not equipped with the tools they need to deal with situations effectively. 76% of students said that they did not use any mental health resources offered by their school. Over half of Bard DC's students have not reached out to any mental health employees for support. Only 9% said that they were comfortable talking with their school counselor if they needed mental health support. These people have not made themselves fully available to the students because they haven't created a safe space for them. I have a couple of recommendations below, but because I have time limits, I'll give you a summary of each. To increase the amount of time being spent on mental health and wellness, education, and support in schools, a mental health staff-led support group should be held weekly during students' lunch blocks or before or after school. This will allow students to have an opportunity in school to learn about mental health and how to upkeep it, as well as how to discuss any issues they're having and get the support they need. In order to make mental health and wellness information more accessible to students, a newsletter should be sent out monthly by Bard DC's mental health and student support staff. This newsletter should include a form for students to create appointments with the counselor if needed. It should also include a list of mental health and staff information and resources that students can access outside of school or online. Thank you for your time, and I hope you take these recommendations into consideration.
Thank you, Lyndon. Araya?
Good evening, Chairman Henderson and members of the Committee on Health. Thank you for the opportunity to testify today. My name is Araya Shelton. I am a Ward 8 resident and a sophomore at Dunbar High School. I have been a youth council member for DC Maker Challenge and the 2022 Soapbox finalist. I also attend Marymount University as a full-time undergrad student. One issue that we are dealing with is the lack of mental health support in schools. I'm so thankful to be able to testify on this issue today and bring attention to this problem. While I appreciate the current discussion on mental health, I believe that it is not enough. There is still a heavy stigma surrounding topics on mental health in schools. School-based mental health is important to me because I transferred this year from my freshman year. I was a student at Barr High School, Early College, DC, and I switched to Dunbar my sophomore year. Transitioning to a new school was not easy for me, but the support of my counselors made me feel comfortable at Dunbar. I received more support and resources than I did in my previous year. I'm grateful that that was a situation at my new school, but that should be the standard for all DCPS schools. While my experience at Dunbar was great, I cannot say the same for everyone else. 23.26% of Dunbar students said that their teacher has never checked in with them on their mental health, while only 9.3% said that their teacher always checked in with them. How can teachers and school leaders like yourself expect for us to be enthusiastic about learning when we feel as though our mental health isn't as important as a quiz or a test? At Dunbar, mental health discussions are very important, are kept very minimum. 60.47% of Dunbar students said they did not receive any medical health instruction. Schools treat us like machines, class after class, teaching us things that we will never use after high school. Instead, they should be teaching us different mental health illnesses and resources to treat them and what to do if someone we know is in a mental crisis. I have a couple of recommendations below, but because I have time limits, I'll give you a summary of each. Schools should make direct investments in mental health education of children and youth by training and educating them so they have information and skills they need for tangible challenge changes and develop resilience building practices. Schools should train teachers on how to deal with mental health, given that 75% of Dunbar students are comfortable talking to their teachers. Not all teachers are prepared to handle students who have mental breakdowns or how to properly address the situation in a case where the students might cause harm to themselves or others. This should be taught in training that teachers have to go through. There should be a quick lesson on the best way to approach students. Thank you for your time today, and I hope you take these recommendations into consideration.
Thank you, Araya, and I appreciate your dedication to doing this. I think outside wherever you are. So definitely stay safe, and we will have your testimony and we can reach out. So thank you. Jelani.
Okay. Good evening, Chairperson Henderson and the members on the Committee of Health. Thank you for the opportunity to testify today. My name is Jelani Easton, and I am a Ward 5 DC resident. I'm a junior at Jackson Reed High School and a member of my school's Greenhouse Club, a club that focuses on keeping the area outside and around our school clean by picking up litter around the school grounds and maintaining the school's plants. In September, I started as a peer educator at the Young Women's Project. The issue I would like to address today is the lack of mental health support in DCPS schools. Today, I would like to address the lack of staffing and emphasis on mental health within our schools, because this is an issue that affects me and other students. Today, I would like to share some of the results of our recent 2022 and 2023 survey. Right now, DCPS schools just aren't providing students with the support they need and require. The issue of mental health resources is important to me because as a DCPS student myself, I've experienced and observed these problems regarding mental health and the lack of support for mental health within our schools. This is especially true for Jackson Reed because right now we are overcrowded and understaffed. There just isn't enough time or resources for students to get the support and care that they need to perform their best as students. In our survey, 77% of Jackson Reed students reported they don't know the name of their mental health counselor, and 92% don't know their DBH counselor. Most schools have little to no mental health staff in the form of therapists or counselors. The schools that do have those resources fail to help students take advantage of these resources. This is a crucial problem that needs to be dealt with, as students are often left feeling alone because when it comes to school-based issues, there's no one that most kids can come to with their problems. There's already not enough education on mental health provided to students, so leaving them without the proper resources is causing unnecessary stress and headache. Now, because of time restraints, I would like to give you a brief summary of some of my recommendations on how mental health services could be improved within DCPS schools. Our schools should provide guidance counselors and in-school therapists that all students can meet with and seek guidance from. Students should be able to have easy access to guidance counselors and therapists because students constantly deal with stress in and out of school. And if we're expected to perform well and receive good grades, we need to know that we can have access to the services to help maintain a stable mental health. And if we're to give students access to therapists and guidance counselors, it's crucial that students are aware not only of where the resources are, but how they can access them. This problem is all too common within our schools. Almost every student is clueless on how to find and access these resources. Schools need to do a better job at advertising them, the resources that they provide to students. Schools should provide training, education, and support to students on how to manage academic workload and stress. That is all. Thank you so much for your time, and I hope you take these recommendations into consideration.
Thank you. And Janaya.
Hello, Chair Henderson and other council members. I am so appreciative of the opportunity I have been given today to speak to you. My name is Janaya Drayton, and I am an 11th grade student at Benjamin Banneker Academic High School. I live in Ward 8, making me part of the Anacostia community. I plan on attending college right after I graduate high school to pursue a career in marketing or business management. I am a YWP advocate because I am very passionate about helping the mental health of people my age. The Young Women's Project builds the leadership and power of DC youth so we can solve community problems. I know that students in DC, especially in my school, may not be open to listening to what adults have to say. So I want to be that person who is there to help. I am testifying today to share my experience and views on the increasing mental health needs of students attending Benjamin Banneker Academic High School. I will also share some of the results of our recent 2022 to 23 Youth Mental Health Survey taken by 74 students at Benjamin Banneker Academic High School. Mental health wellness is an important issue for me because I've had to learn to manage my mental health even in my darkest times. My dad passed away at the end of 2020, and it was very detrimental to my mental health. Luckily, I was open to receiving help from adults. There are lots of students who need some of my age to help them, whether that is by advocating for them or giving advice. I am there for them. My school has a high academic demand that puts a great stress on our lives. YWP surveys show that 50% of Banneker students report that their stress was too much or unbearable. Having to deal with coming back from the pandemic has been a challenge, not only for me, but also for my peers, especially trying to balance a social life with schoolwork. Levels of motivation, those seem to vary and reflect a struggle for Banneker students, with 42% having fluctuating motivation and only 1% describe themselves as highly motivated. The academic workload, community service requirements, and rules get stricter each year. In the past, it has felt like they put students against each other by putting our GPAs on display on the walls when showing the honor roll list. The administration has listened and has just recently stopped posting our GPAs, but the damage has already been done. The teachers address the issues by trying to limit the amount of homework we receive every night. They also have individual meetings with students if they notice an issue. To increase wellness and decrease stress, there are counselors for every grade and a therapist and a social worker available to talk. The issue is that most students are afraid to talk to adults. 69% of students report that they do not know the name of their DCPS mental health counselor. Even more do not know the name of their DBH counselor. I have two solutions that I want to present to the committee. The first one is to expand a space that is open to Banneker community where they can build knowledge on mental health and express their feelings to one another. The second solution is to decrease the amount of homework Banneker students are given every night. Students could then focus more on understanding the classwork rather than staying up at night completing homework. Students could then focus more on doing the activities that make them happy after school. Thank you so much for allowing me to speak to you today. I hope that you take my words into consideration.
Thank you, Janaya. And thank you to all of the witnesses. I know that some folks had to drop off, but really appreciate you guys sticking with us and being here and adding your voice to the conversation. One thing I wanted to ask, and anyone can sort of chime in here, to what extent, if any, have you all brought these issues up with your school's principal or school leadership? I think I counted 1, 2, 3, 4, 5, 6 different schools that are represented here. Obviously, the culture and climate at your schools are vary, but I think one of the solutions that someone brought up was to say like, oh, we should have access to mental health supports, or someone talking about it during a lunch period. I feel like that's something that your principals or APs can facilitate without the council getting involved, but it's perhaps they don't know that's something that you're looking for. Anyone?
At Banneker, we have a mental health ambassador club.
Okay.
And so we do little activities where we collaborate with the principal. And we recently did Take What You Need boards where we gave quotes to all the students and they could take it off and rip it like a lost dog poster. And like the principal allowed us to put those up. So we work in collaboration, but there's only but so much you can do actually like during this time.
Anyone else? If you've brought it up, what happened? If you didn't bring it up, why haven't you?
So I know that last year we had at Jackson Reed High School, we had a mental health like club for it was like students majority, but then or maybe not last year, but it was before COVID. And then after COVID, it kind of people left and it didn't happen. I was talking to a friend of mine and she said that she brought it up with our Mr. Bargeman, who is the in-between principal of some sorts. And that was this past year, and he was like, we'll see where it goes, but nothing has happened, which is totally fine. We got a new principal. He's great, but I have not personally asked him or talked to him about it yet.
Okay. I would make that suggestion / challenge for you all. I can certainly raise this in terms of the conversations I have with school leaders of like, hey, your students are saying that they need more mental health supports, et cetera. But I would say the conversations that your school leaders are having with council members in terms of what they feel like you all need to be successful, this isn't necessarily something that's on the top of their list in the conversations that they're having with council or with the mayor's office. And so we should just pursue that a little bit differently. But thank you all again for your testimony and for being here. Councilmember Parker, do you have any questions for this panel of witnesses?
Yes. Again, thank you all. I would associate myself with Chair Henderson's suggestion to provide feedback to your school leaders and to organize both with your peers and parents to make sure some of these recommendations are implemented. I think, like, for instance, the suggestion that there are posters throughout the school with mental health resources available to students, that is a low-hanging fruit opportunity that I think you all are probably better suited to actualize. That said, we're not off the hook. And you're coming to testify here is giving me ideas around how we can outreach to central office staff folk at DCPS and at the charter board to just elevate this concern. Janiyah, I also wanted to just extend my condolences. I also lost my dad when I was in high school, and I know what that is like. And the impact it can have on your mental health. And I wanted to just open it up and knowing that we're in a time when a lot of our young people are in harm's way, we're losing peers, and just like how are students dealing with grief, whether that's the loss of a loved one, a parent, or unfortunately a peer, which is becoming so common. What does that look like at your schools, and what impact is that having on student mental health?
Thank you so much for extending your condolences. My condolences to you as well. I did a program with the WIN Center that actually like reached out to my school. So they send out emails about like how they can help. And then especially when my dad died, it was during the pandemic, and they still managed to get in contact with me, and they had me join like team meetings, and I would talk to the social worker and to my counselor. But I know that my mom told them. I didn't tell them, and I'm not sure how many students will actually like tell anything about it.
That's helpful. Thank you.
I had one. At my school in the last year, a student of my grade, senior, passed away due to gun violence pretty recently, Akira Wilson, and the way my school reacted and tried to help support the students was bringing guidance counselors and outside therapists for I guess 4 days, which was great, and they helped us like grieve. However, inside our classrooms, where I think more of the students wanted to talk a little bit about, the teachers kind of disregarded because it was a tough discussion. And I think like putting 10 minutes into work or 10 minutes into your like schedule of class, whatever, would have been like great and beneficial to students. But, yeah.
Hi, I tend to side more with Sarah's share. When I was dealing with grief, I actually lost my mother, and when I came to my principal about it, she actually sent me to the college admissions counselor for some reason, because we don't have like the people that are actually meant to deal with those things are not always present in our building. So I was sent to someone who has probably no training on how to deal with grief or mental health or anything of the sort, and it wasn't very helpful to me.
Sorry for your loss, London.
I'd like to add on to what Sarah and London were saying, because I think, especially with my fellow student's death, Akira Wilson, it was really the school handled it in a more like a professional manner. We had resources provided to us, but within classrooms, like Sarah said, there wasn't a lot of like official like guidance or time to grieve or mourn or process. I can only think of one instance in which we actually had some time, which was my history class. Our teacher gave us most of the class to talk and, you know, get our feelings across and just process. But outside of that, there was no real like time to really just process everything that had gone on. And it's really, I can't really blame the teachers because it's really not their job to do that, to like help children deal with like grief and something as tough as death at such a young age. And it's hard to think about. And I feel like that's just another real issue of like not having enough staff, especially at our school with over like I think 2,500 students. There's just a lot that teachers have to handle on their own, despite not really being prepared or trained to deal with certain things, which I guess isn't really fair to them. And I just think that's something that like is really, really hard to like grasp. And sometimes we kind of forget just how much they have to deal with on their own, besides just teaching and grading.
No, I appreciate that thoughtful response. I'm coming down on time, but your reflections are just making me think that when we dispatch grievance and crisis counselors to schools, that in both needs to be at a macro level, but also support for teachers to be able to deal with students. And so I'm hearing you loud and clear. So thank you for your testimony today.
Thank you, Councilmember Parker, and Janaya and London, frankly, all of you. I appreciate your transparency and vulnerability, and to you all, my deepest condolences to you as well. I'm very familiar with the Wint Center, and I think that they do excellent work. And if I could replicate them and put them in every school, I would. Or if nothing else, get every teacher or staff member trained using their trauma-informed approach. But thank you all so much for being with us. And thank you. I hope you guys have a good rest of the night, and good luck, all the seniors out there, in terms of ending the school year. All right, we're coming to our final group. Gotta end strong because it is 7:43. And we've been here since 2. Okay, Monet Goodwin, Nyla Moore, Leah Millard, Anaya Thomas, Amanda Minvar, and Nadia Gold Mortis. Thank you, Councilmember Parker, for sticking with me.
Yeah, trying.
Okay, is Monet here? No. All right. I see Nyla. So go ahead, Nyla.
Good evening, Chair Henderson and members of the Committee on Health. Thank you for the opportunity to testify today. My name is Nyla Moore, a heavily involved Ward 7 resident, sophomore at Cesar Chavez Parkside Charter School. I look forward to majoring in architecture at North Carolina A&T as we need more female architects. One issue that we are dealing with is the lack of mental health support in schools. At my school, Cesar Chavez, we try our best to give everyone in our community a voice. I asked my peers why they believe mental health is important. A scholar said, mental health is important because it influences day-to-day decisions. We take health class every day. We learned about the health triangle, which consists of 3 categories: physical health, mental and emotional health, and social health, and how they influence our day. From my own experience, school stress is a common factor in most teens. I know the feeling of being worried about your grades and having a deadline. I recently broke completely. I was stressed and felt numb from everything I was expected to complete. I didn't want to let anyone down, and especially myself. So when I felt behind, I panicked and had a breakdown. I took a walk from class and called my dad. He ended up calling the school, asked for someone to sit me down to talk about my stress to see where my head was. It was a trusted person who I built a relationship with over the years, Ms. Solomon. I've heard of some of my peers that don't have a staff member in the school that has taken the time to get to know them rather than just give out work, instructions, and a due date. In order for students to learn, they need to have a trusted relationship with their teachers and staff. Since I had someone to express myself to, it boosted my great confidence and mental state. Over my time at YWP, I have heard experiences from my fellow youth advocates on the need for more mental health support. Some of my peers said they didn't know where to go, and some of my peers said that their schools didn't have a psychologist, which is outrageous. We surveyed DC students and found that over the last 3 months, 3% said they always receive mental health support, while 44% said never. Another piece of data we collected was what DC students thought was important. They said that being able to talk to a counselor at their school, receiving education about mental health, and accessing mental health information online were all important. I believe that my school cares deeply about their students' increasing mental health needs. I can't say the same for other DC students. Is it important to have opportunity to speak about our mental health at school? The fact that schools aren't taking advantage of the $1 million budget to implement more support shows that schools do not care about mental health of their students. My recommendation is that DBH should develop a range of mental health and wellness interventions and opportunities for every DCPS and DC charter school so that young people can connect to including individual counseling as well as a support group and wellness practice groups that address sleep, meditation, and other aspects of resilience building. The health triangle should be included in the health class curriculum. Thank you for your time, and I hope you take our recommendation into consideration.
Thank you, Nyla. Leah?
Good evening. My name is Leah Mallard, and I'm currently a senior at Bard High School, Early College, DC. I've been a peer advocate with the Young Women's Project since September 2020, and YWP is an organization that builds the leadership and power of youth so we can solve community problems. Today, I'm going to be sharing some of the preliminary results of our recent 2022 to 23 Youth Mental Health Survey, which was taken by 673 youth in 22 schools across DC and 84 youth at Bard High School. YWP launched the mental health campaign in 2019 to strengthen mental health-based programming, connect youth to services, reduce stigma, and expand access to mental health education. This year, we have 80 youth health advocates working on mental health in 16 schools. As youth advocates, we receive over 100 hours of training in stress, toxic stress, resilience building, trauma, and brain science. We also work within our schools to collect data, educate, and connect peers to resources, and work with adult leaders to address the youth mental health crisis. Last year, YJC youth leaders presented more than 45 testimonies to the GC Council, educated more than 4,000 peers, and created student online support virtual wellness centers in 13 schools. This issue is important to me because teens are trying to balance many things at once. Between puberty, school, sports, and work, it gets very overwhelming. During the pandemic, myself and a whole bunch of other teens began experiencing things like depression, anxiety, and PTSD for the first time. Most of us can't even recognize what those feelings are or how to deal with them or who to go to.
Since school is where we spend most of our time and it's where we access information about programs and services, we must have mental health services available during a crucial part of adolescence. At my school, our counselors and psychiatrists have been available inconsistently or just recently hired, making it hard for students to establish bonds with them, which was backed up by the survey that we conducted. We found that 92.7% of students at Bard don't know the name of the DBH clinician at their school, and 70% of students don't know the name of their counselors. I have a few recommendations, and the first is that schools should teach health education that includes mental health, given that 67% of BAR students have never received any mental health or wellness education, and never in health class have we seriously covered mental health problems and solutions for more than 1 week. We need to learn more about it, and it should be taught as passionately as math and English. DCPS isn't providing enough virtual wellness for students. It's evident from our survey results that many students do not know where to reach out for mental health resources. Over 39% of BAR students have described the stress level to be beyond manageable. And our solution is to create virtual wellness centers for DCPS and charter high schools. The centers will be interactive and provide in-person wellness services for students across DC. And we hope to implement this solution before the end of the school year. Our goal is to reach at least 40% of students across DCPS. Thank you for your time, and I hope you take these recommendations into consideration.
Thank you, Leah. Anaya? Anaya, we are having trouble hearing you with your connection. Maybe if you turn off your video, you might come through a little bit more clear. Anaya, are you there? Oh, okay. Video went off. Anaya, can you hear us? I see you. Can you hear us?
Yes, sorry
Oh,
about that.
there you go.
Okay. I'm a college-bound senior at H.C. Wilson Senior High School with plans on studying journalism and music theory. I'm the vice president at H.C. Student Government Association. One issue that we are dealing with is making mental health resources more accessible to H.C. Wilson students. I'm thankful to be able to testify on this issue today and bring attention to this problem. Mental health and wellness is important for stability and maintenance in every aspect of our lives. It affects how we interact with others, how we view situations, and how we deal with them. Building a positive mindset and healthy coping mechanisms betters our minds and bodies. Personally, I, like many of my peers, have battled with depression, stress, and anxiety. Students at HD Wilson, along with myself, usually don't concern ourselves with mental health staff or support counselors. Either we don't trust them, we don't know about them, or we don't feel as though confiding in them will be effective. Students tend to confide in their academic counselors or teachers instead of their mental health staff, whose job it is to support mental health. A month ago, I learned that my school had a therapist, which was a shock to me because I didn't know about him earlier, especially since I am the vice president, meaning that I interact with staff on a daily basis. 66.7% of students do not know their mental health counselor. When asked about who students were comfortable going to for mental health support in our survey, 39% said that they were not comfortable going to their counselor or they didn't have one at their school. 39% said that they were somewhat comfortable. This is unacceptable. Mental health counselors should make more of an effort to be known. Students should know the names of their counselors and feel comfortable talking to them. Usually, we are told to come into class and get straight to work. Our curriculum does not cover mental health. When a fight happens, we are never asked about how the fight impacts our mental health. If we had our mental health team come and present about the causes of toxic stress and how it impacts our body, we might be able to understand why these fights happen. If a mental health curriculum was introduced, we could learn about the healthier coping mechanism to our stress. Mental health education should not be considered an afterthought. It should be part of the DCPS curriculum. I have several recommendations below, but because I have time limits, I'll give you a summary of each. Schools should use the Adverse Childhood Experience ACE framework to assess and educate youth on trauma and resilience building. ACE screening helps to identify individuals at increased risk of having a toxic stress response and target interventions early when they are likely to be more effective and less expensive. Schools should also implement mental health check ends into their lesson plans. They should ask students how they feel about their course load and give them time to unload about their feelings. 69% of students have not received mental health support in schools. Schools need to make it known that schools care about students' mental health. Thank you for your time, and I hope you take these recommendations into consideration. Thank you.
Thank you. Amanda?
Good evening, Chair. Sorry. Good evening, Chair Henderson and members of the Committee on Health. Thank you for the opportunity to testify today. My name is Amanda Benhivar, and I am a Ward 7 DC resident. I am a senior at Bard High School Early College, DC. I will be graduating from Bard this summer with my high school degree with an associate's degree in literature arts. I plan on going to college in the fall and being a future psychologist. I have also been connected with the National Center for Children and Families for over 5 years, where I've gone to Knoll Elementary School to be a teacher's aide for a kindergarten class on Saturdays. One issue that we are dealing with is the lack of mental health support in schools. I am thankful to be able to testify on this issue today and bring attention to this problem. Like many other students, I have spent most of my time in school. School plays an important role in many students' lives. In many cases, school becomes a safe haven for students who are not getting their needs met at home. I have personally struggled with mental health for several years, and I have never gotten the proper tools to help me. It has been brought to my attention that I am not the only one. Many of my peers have a similar story. As I have started to connect myself with YWP, I have gained more knowledge about mental health and noticed that students do not receive proper mental health support at schools. Our mental health team is not widely known at Bard. This is a huge issue. According to a survey we conducted about school-based mental health, one of the questions being, in the last 3 months, what mental health wellness support have you received? 56% of Bard students replied with never, and 2% of students replied with often. Another question is, do you know the name of your mental health counselor? The results for 70% of students replied with no, and 30% replied with yes. Most of the students do not interact with mental health team. Most students will only know them if they happen to stumble across their offices and read signs that says their name. How are students supposed to feel comfortable talking to their mental health staff if they don't know who they are? Bard needs to do better. I have several recommendations below, but I have time limits. I'll give you a summary of each. Schools should hire more mental health support staff. Currently, the DBH clinician position at Bard is vacant. The DBH clinician position needs to be filled. We appreciate the work that Mr. Bardash, our social worker, does for us, but he is very overworked. He should not be the only one that handles students struggling with a mental health concern. Schools should train teachers on how to deal with mental health. Not all teachers are prepared to handle students who have mental breakdowns or how to properly address a situation in a case where the student might cause harm to themselves or others. This should be taught in training that teachers have to go through. There should be a quick lesson about the best way to approach students. DBH should build a consistent cross-school communication and referral system that provides clear, detailed information on services, provider background, and contact information, how to schedule appointments and what to expect. Make scheduling counseling appointments easy so students can click on a link or QR code to find time that works for them. Thank you for your time, and I hope you take these recommendations into consideration.
Thank you. And finally, Nadia.
Ooh, good evening, Chair Henderson and Councilmember Parker. It's great to see both of you. I'm Nadia Goldmaritz. I'm the Executive Director of the Young Women's Project. Thank you so much for this opportunity to testify. We're thrilled to see you as the leader of this committee. The Young Women's Project, as you know, builds the leadership and power of young people. You've met many of our young leaders today. And thank you so much for being so welcoming and bringing them into this important public debate. Our young people take on 3 roles. One is as advocates, another is as educators and peer organizers, and then also as systems change agents, which usually means identifying gaps and problems with systems and then working to try to figure out how to address them. We have 120 young people working in 22 schools right now with 2 programs. One is the Youth Justice Campaign, where everybody you heard today is part of that work, and we're doing focusing on mental health, school-based mental health. The other one is the Youth Health Educator Program, which focuses on sexual health education and condom distribution, and you will see them in the DOH hearing. So let's see. My testimony today is 3 things. I will try to be quick. It's been a long day. One is sharing some findings from our survey, which our young people already did. The other one is talking about some of the limitations of the behavioral health expansion and the clinician pipeline from our perspective. And then the other one is talking about some needed solutions. We started doing mental health work, YWP, 3 years ago. And we've done a bunch of different projects. Every year we do an annual survey. This year it was with about 670 young people. We also built a system-wide infrastructure of virtual wellness centers last year. And you can see them in 13 schools. And this is all linked in my testimony. And we've educated 4,000 young people. So we've been on the ground in 22 schools, talking to leaders. We've also been in countless meetings with DBH and DCPS leadership. And we have a lot of observations of that work, I think. So there's 3 points that I want to make in my testimony. Number 1, the mental health crisis for young people continues. I think the data that we have from our survey, the data that we have recently released from the YRBS survey indicates that youth are stressed, close to 50%, depressed, 47.7% of young women, especially, and also dealing with grief, as has come up. At the same time, and this is what our survey shows, which I think is how it contributes to this data, is that young people are not aware of, in touch with their counselor. They're definitely not in touch with their DBH counselor. They're not necessarily comfortable, and they're not getting any mental health education, which is the saddest of all, right? 80% of young people, less than an hour. I mean, that's low-hanging fruit that we can take on. I think young people need to understand stress and trauma and how to deal with it, but they don't right now. On the clinician pipeline, from where we sit, a lot of attention, money, focus has been on this. This certainly is the piece of work that DBH has kind of carved out for themselves that they're responsible for. But the math doesn't, it does not add up to more than a partial solution. There are 155 clinicians in the schools right now, 15 in high schools. And there are 18,000 students. So that's not going to address the need. What I would like to urge the committee is to get more involved in this debate. From where we sit, there is, the 2 sides are very much apart. We have DCPS counselors who are focused on academic work. We have DBH, which is focused on building the pipeline, but a whole lot of other infrastructure, data, outreach, communication falls in the cracks. We have several recommendations that address this, but in addition, we would love to see a task force, a roundtable. We'd love to see some leadership of this committee. So thank you so much for hearing my testimony.
Thank you. And thank you to all of the witnesses for sticking with us and providing your testimony and your feedback. I have to say, it's so exciting to see students who are testifying again. It's so exciting to have such a variety of schools represented and school communities represented here. But it's also a bit heartbreaking to also hear that it doesn't matter if you are at a application school, at a charter school, at a early college, high school, it doesn't matter. All of the students seem to be facing the very similar issues. And so no one seems to be doing this well. So it definitely gives us a lot of food for thought, not only as we have conversations with DBH, but also when we have conversations with charter leaders and with DCPS later in the month. I don't have any specific questions, although I want to say shout out to Amanda for wanting to be a psychologist. I don't know if anybody else was trying to go into that area, but as we have this conversation about workforce and needing folks to go into this field, really, really appreciate that. Councilmember Parker, do you have any questions for this witness or for this panel?
Yes. Anaya, I took note that you said that students don't trust the counselors, and you, if I recall your testimony, you said it's in large part because they don't know them. And I just wanted to underscore that. I don't really have a question there, but that resonates why, again, it's so important that we make clear who these individuals are in our schools. You also referenced the ACE framework to target interventions early. I'm not terribly familiar with that framework. I'm not going to put you on the spot to educate me on it, but I also wanted to note that I'm going to look into that. I did have a question, and it was more about mental health should be a part of the curriculum. And this was something that has come up several times. And so what would be your recommendations? Earlier, I asked, should that be peer-led? Should that be teacher instructed? What would be your recommendations for a mental health focus aspect of the curriculum? And anybody can answer that, but Anaya, that was part of your testimony.
Okay, first, let's hope my things don't cut off.
And I think you might be going in and out, Anaya. Maybe try turning off your camera again. It doesn't seem like it's working. Oh. Can you try singing something? If you're not. It still seems broken up. Why don't I jump to another question and we'll circle back. And Anaya, if I don't get to you, I'll make sure that we follow up with you. Did anybody else want to weigh in on that, or how we might embed a mental health focused curriculum in our schools, and how should that be facilitated? Okay, I'm going to take that as the night is drawing on. Amanda, you reference a cross-school communication system. Can you just say more what you mean by that, and how might that improve the supports that students are receiving?
Hello, yes. I am connected with NCCF, that is National Center for Children and Family. If you don't know about the organization, they are amazing and extremely helpful. They are connected with multiple schools in DCPS. I've never heard them being connected with a high school, but they are connected with my previous elementary school, which I still go there on Saturdays, and I do volunteer and help. And I have even gotten my community service hours done there through NCCF. As I said, I am a teacher aide for a kindergarten class there. It is an amazing opportunity for me because I'm able to observe the classroom and see how these little kids are also struggling with mental health, whether it be genetic or whether it be social. This all comes back to me saying that I want to be a psychologist because I really like to observe like social scenes and how different things systemically can affect children, especially in DC. DC is so small, but yet so large and diverse. I did kind of want to come back and say the previous panel, no, it was this panel. Nyla said that she went to Chavez and had a lot of help from her teacher, Ms. Solomon. I also did too. She was my teacher when I was at Chavez in middle school. And it really showcases how teachers do play a big role in schools. And you can ask many students, and many students will tell you that being in a teacher's classroom, every teacher will be different from the way that they teach and from the way that they interact with the students. I really do agree that mental health should be in the curriculum. A lot of teachers don't know how to deal with situations like this. And at Bard, we are very short-staffed when it comes to mental health. I agree with London when she said that we should have something during lunch, whether it could be whether it be facilitated by an admin, or it doesn't even need to be lunch. It could be an advisory, because we have advisory, but it's not the main focus as well. I'm sorry, I think I kind of sidetracked there.
No, that was great. And I'm really impressed how you just recalled so many different testimonies throughout the evening. So thank you for that. Nadia, I would just say hats off to the work that you're doing, and it's on display. And I hear you in terms of conducting a roundtable, and so more to come, and in hopes that we can strategize across sectors around how we can change some of the trends that your survey highlighted. So thank you all for your testimony and sharing. And then Anaya, if you could hear us, I will be sure to follow up. Sorry about the technical difficulties.
Thank you, Councilmember Parker. And thank you to all the witnesses. Amanda, I agree with you. I had some really amazing teachers in school and middle and high school, and I don't think teachers get enough credit for the extra work that they do outside of the academic support, but also the support that they just provide, just in terms of trying to fill the gaps where there may not be enough clinicians or school psychologists available. But Ms. Mortiz, Gold Mortiz, you are our last witness of today. And let me tell you, it's kind of crazy. So we've been, the DBH portion, it has been 6 hours. I don't know if anybody's been watching this. We've been here for 6 hours. And in a traditional world, we would probably take a little break, and then somehow we would have to figure out how we're going to do the government witnesses, but not today. So I'm actually going to recess this hearing. We will pick up part 2 next week with Dr. Bazaran, all fresh and refreshed in the afternoon, in the daytime. And we'll certainly bring up a number of the concerns that were raised by public witnesses today. So I want folks to don't feel as though your testimony today is going into a vacuum. It actually gives us a little bit more time to organize what you said, look at the trends, and then also generate some questions for the government witnesses for next week. So I want to thank all of the witnesses who spoke today. Your testimony is critical to ensuring that the committee understands how the agency is serving district residents. For those who are unable to testify, the record will remain open until 5 p.m. on Wednesday, February 15th. If you want to submit additional testimony for the record, you may email your statements to Ashley Strange at astrange@dccouncil.gov, or leave a voicemail at 202-430-6046. If you do leave a voicemail, please speak slowly for the transcription purposes, and also include your name. Dr. Barbara Bazaran, the DBH director, will appear before this committee next week on Thursday, February 9th at 2 p.m. There is no further business before the committee at the moment. I do want to also extend a thank you to all the public witnesses who testified this morning for the Health Benefit Exchange, as well as the director of that agency. So we will recess until Thursday, February 9th at 2 p.m. Thank you. Have a good evening.
Thank you.
Good night, everybody.
Good night.
Thank you.